D'Souza, sir, Medical Superintendent, State Cancer Institute, Head of the Department of Medical Oncology at SMS Medical College, for his welcome words, please. Dr. Sandeep D'Souza, sir.
Morning. It gives me an immense pleasure to all of you in this our precision oncology fourth precision oncology conference, and really I'm very much overwhelmed by your response, and on single call you have accepted my invitation and coming from out of city and on this busy schedule and spending your time in this busy schedule. So really I just uh, take my words that whenever you will go out of this our hall, and you will have no zero doubts in your mind, because our faculty is well learned faculty, and well learned and excellent faculty which is coming out of Rajasthan, and also from Rajasthan itself. They are very well learned, and if you have any let us know immediately. So this conference is really 2 days conference, day 1 and day 2. Day 1 is divided into 2 halls, and day 2 is also in 2 halls. And we have workshop, molecular oncology workshop, and palliative oncology workshop tomorrow morning in 1 hall and 2nd hall. I welcome all of you, and not taking so much time to start this our events on the time. And I would just request you to be on time, and please complete your sessions on time. And I hope my faculty who is coming outside from Rajasthan will enjoy 2 days this conference and enjoy the city itself. It's a very beautiful city, heritage cities, and sometime you find any opportunity to go outside, let us know. We will arrange your outside visit. Thank you very much. Now I invite our chairperson, please invite our chairperson for further proceeding. Thank you, sir.
So once again, good morning, and thank you everyone for participating in this conference. It's a pleasure to welcome, invite Professor Dr. D.P. Singh, sir, Senior Professor and Head, Department of Radiation Oncology at the prestigious Mahatma Gandhi Medical College and Hospital, Jaipur. Over to you, sir.
So it's a very important conference, and we are discussing the very important some trials in the head and neck cancer. That's most common in our country. So without delaying, I invite the first speaker, clinical consultant, radiation oncology at Indraprasth Apollo Hospital, New Delhi. He will deliver on the results of phase 2 study of IMRT, pre-radiation and concurrent adjuvant nivolumab in patients with loco-regionally recurrent or second primary head and neck squamous cell carcinoma. Dr. Robin, you may proceed.
Good morning. Thank you, chairpersons, and good morning to all the early comers to the hall. At the outset, I'd like to thank Dr. D'Souza and his team for inviting me to this conference. Can I have my slides, please? Uh, Good morning. I'll straight away start the session for the day. And it's probably a very important topic which we encounter almost very frequently in our daily practices. Head and neck cancer is pretty common, and the failures are also not uncommon. So we all know that head and neck cancers make a chunk of our treatments which we do in our practice. But the unfortunate thing is around 15 to 50% of the patients would actually develop recurrence at some point of time, which is a great challenge for us to manage such patients. And the practice is, if any patient who fails post radiation chemo, the first option is to consider a patient for surgical treatments if possible. But majority of our patients land up in a situation where they are unresectable because of the large chunk of the disease, the centrally located residual disease, or a infiltrating nodal disease, which is not amenable to any form of surgery. So most of these patients would actually land up in a palliative chemotherapy where the survivals would be as low as around 5 to 7 months or so. But we all know that whenever a disease is localized, we have an inherent tendency to do some sort of local treatment, because we inherently feel that cure is only possible if there is some sort of local treatment. So re-radiation came into the picture, and survivals in some of the studies increased by another 3-4 months to around 12 months. Then there were some protocols done for variable amount of doses, less than 45 gray or more than 45 gray. And we saw that patients who got dose which is higher than 45 gray had a better survivals. But all these treatments are not without side effects. There has been evolution of the protocols. There has been pembrolizumab based therapy. There was an extreme trial which became a standard for palliative. Then there was a pembrolizumab based therapy. And with the new therapies of immunotherapy like nivolumab, which was approved when the Checkmate study was done, and it became a standard of care for advanced head and neck cancers in many situations. So what is nivolumab? It's basically anti-PD-1 therapy. Now, how it acts is, it is a basically programmed cell death protein inhibitory. So what it does, it binds to the PD1, which blocks the interaction of PD1 with the PDL1 ligands. So the tumor cells, which initially would impair the T cell activity, which could act as a, so basically these were not recognized by our T cells. And by blocking this cascade between the tumor cell and the T cell, they became a little more sensitive to our body's own immune system. So this study was actually done to assess the response of the treatment, in which radiation was combined with concurrent nivolumab and also given in an adjuvant setting. 1 year progression-free survival was the primary endpoint, and the secondary endpoints include 1 year OS, quality of life studies, and acute late toxicities. There were some exploratory objectives also to identify potential biomarkers who could benefit with this form of therapy. Now, the scheme of the trial was, it is a multi-centric trial done in 3 institutes of Enmoy, Cleveland Clinic, and Wisconsin Medical School, where IMRT was combined in a conventional fashion. The dose of 60 to 66 gray over 6 to 6.5 weeks with nivolumab, which was given 2 weeks prior to starting radiation, and then concurrently every 2 weekly, to a total dose of 240 mg. Fixed dose was given. In an adjuvant setting, the dose started at week 10 and given every 4 weeks to a dose of 480 mg till there was disease progression or unacceptable toxicity. There were a lot of inclusion criteria. Any disease which is recurrent in patients with more than 18 years of age, life expectancy of more than 6 months, both patients who were unresectable or resectable were included, and post-surgical indications again were positive margins, extracapsular spread, gross residual disease, N2, N3 disease, T3, T4 disease, and perineural invasion or lymphovascular invasions. The most important inclusion criteria was the area which we are going to radiate now in the previous session should have received at least 40 gray of dose. The time interval between the first treatment and the current radiation should be at least more than 6 months. No salivary gland tumors were included in this study, no distant metastasis, and the carotid artery encasement can be there in the inclusion criteria, but the patient should not have symptoms related to carotid involvement. The exclusion criteria were patients who were subjected to some sort of previous immunotherapies were not part of it. Patients on immunosuppressive drugs like corticosteroids were not part of this study. Uncontrolled intercurrent illnesses were excluded from this study. And RPA class 3 patients. Now, what is RPA class 3? Is patients in which the disease recurs within 2 years, unresectable, and had a lot of comorbidities along with this. This categorizes as RPA class 3. So those patients were not included. Metastasis, yes, they were not included to this. Now, the results were analyzed in January 2022, where 51 evaluable patients were studied who completed IMRT with nivolumab. The median age was 62. RPA class 1 and class 2 were equally almost same. Majority were males. ECOG performance status, again 0 and 1 formed the majority of the trial. And median follow-up of 12.5 months was seen in. Now, as far as the results are concerned, the progression-free survival at the end of 1 year was around 60%. And the overall survival was around 80%. As far as the toxicities were concerned, fatigue, radiation dermatitis, dysphagia, dry mouth, mucositis were the common toxicities. But grade 3 or higher toxicities were quite uncommon. Depletion in the lymphocyte count, colitis formed the majority of them. As far as the quality of life is concerned, it remained stable. It was assessed using the FACT head and neck questionnaire, and it was pretty stable from the beginning till the 52-week interval when they were seen. And the last, which was the potential biomarker, the survival of the patients with 1.5-fold increase in peripheral blood PD1, Ki67 and CD8 plus T cells at week 2 and 4 was predictive of a better overall response of around 19 months versus 13 months in patients whom the increase was not seen. So the study concluded that IMRT radiation with concurrent and adjuvant nivolumab is clinically effective, well tolerated, and deserves further exploration in patients with different and second primary tumors of head and neck carcinomas. Thank you. And my take home on this is, yes, it is a well conducted. The best part is that they have included a good category of patients, the RPA 1 and 2. We can further select these patients to improve our outcomes in terms of selection of our patients. In a few other studies, when these two were combined, a few factors like NLR ratio, that is neutrophil lymphocyte ratio, was important. The higher the ratio, the poorer is the outcomes. Similarly, hemoglobin was an important factor in some of the studies. Again, that meant that a patient with a better GC overall had a better outcomes. CRP was another factor which defined outcomes. More the CRP, the poorer was the outcomes. And RPA was probably the most important factor to categorize the patients in terms of survival rates. Yes, thank you.
Thank you, Dr. Robin. Any query from the house? Sir, can after 6 weeks, 6 months, can we repeat the radical dose? Suppose patient has received the radical dose, 60 gray in head and neck carcinoma. After 6 months, such a...
Now, the challenge is not just the radiation dose, the challenge is what dose the organ at risks have received. Okay. So here for as a radiation oncology community, the most important factor is your spinal cord doses. The second is we actually see the patient in totality. The parotids are another important thing. A patient who will go into xerostomia, a re-radiation will only increase the chances of xerostomia. There are for me in my clinical practice, the most challenging part is the edema of the epiglottis and the larynx, which causes microaspirations in patients. So a lot has to be looked into the organ at risk doses that we need to give. Definitely, the longer the period between the first and the second will define the better outcomes of the treatment as anyways. Within 6 months, if disease is occurring, it's primarily a radio-resistant disease. So yes, the chance outcomes will definitely be poorer.
Very good, sir. Thank you. Thank you.
Thank
Thank you, Dr. Robin. Our second speaker is Dr. Mayur Mayank, Senior Consultant, Radiation Oncology at Metro Heart Institute with Multi-Speciality Hospital, that Faridabad. Yes, Dr. Mayank, you can.
Thank you, sir. Thanks a lot, and good morning, all. And on the outright, I would like to thank the organizers, especially Dr. Jasuja, for giving me the opportunity to come down over here and discuss about something which has been a very important thing in our practice, as sir also told initially. Head and neck cancers form actually a chunk of diseases in India, and it may be even considered the capital of head and neck cancers in India. In the world, and we all know that by the book the dictum is to give 3 weekly 100 mg per meter square cisplatin, but everyone knows that we give 40 mg per meter square because of a lot of issues. So this was basically a multi-institutional trial conducted at AIIMS New Delhi and Jhajjar, then BLK Max, Army Hospital, and JIPMER. And I'll be presenting actually the slides which were presented at ASCO for this abstract. So coming down to the main, this thing. So this was a concert trial, which was basically a non-inferiority phase 3 randomized control trial of 3 weekly versus weekly cisplatin in radical radiation and locally advanced head and neck squamous cell carcinomas. So there were multiple, as I told you, there were 4 major institutes. Also AIIMS Rishikesh was a part of it. And coming down to the background, we know that 100 mg per meter square 3 weekly is the standard dose of radiation, but most of the centers actually used to prefer to give 40 mg per meter square. There was a trial actually conducted by the Tata group in which they gave 30 mg per meter square weekly, and that was found inferior to 100 mg per meter square, and that was published in JCO in 2017. And at that time, it was concluded that 100 mg per meter square should be the standard of care in all locally advanced head and neck cancers receiving radical radiation. However, there are issues with 100 mg per meter square, and it is easier to give 40 mg per meter square the low dose cisplatin because it causes a better radiosensitization. Higher per meter square dose delivery can be done. It has got a better tolerance, and there is reduced toxicity. The time this trial was conducted or planned, that time there was no evidence that 40 mg per meter square is non-inferior to 100 mg per meter square. And this was a non-inferiority trial done to compare the same. Now, coming down to the study details, the hypothesis was that weekly cisplatin given 7 cycles, 40 mg per meter square, is non-inferior to 3 weekly cisplatin with a better tolerability and a better toxicity profile. It was a multi-centric open-label phase 3 randomized control trial, which was registered in the Clinical Trials Registry of India. Coming down to the patients, so the inclusion criteria included treatment naive, locally advanced, that is stage 3 or stage 4, non-nasopharyngeal small squamous cell head and neck cancers suitable for concurrent chemo radiation, age group 18 to 70 years with a ECOG performance status of 0 to 2. All the patients had to have an adequate organ function, that is the counts must have been normal, the liver profile, the renal profile, and the cardiac profile should have been normal. There should have been no contraindication to cisplatin and a good creatinine clearance of more than 60 ml per minute. The exclusion criteria included uncontrolled other diseases, hearing loss, documented weight loss of more than 15%, and patients with hepatitis, HIV, or infection. So the main objectives of the study, the primary objective was actually 2-year loco-regional control, and the secondary objectives were the overall survival, progression-free survival, the toxicity, especially the grade 3, grade 4, early or late radiation toxicity, and the compliance of the patients. The randomization was done by a computer-generated simple randomization. The sample size collection was, sample size calculation was done expecting a 60% loco-regional control at 2 years in the standard arm, that is the 100 mg per meter square arm, and a 65% in the test arm, which was the 40 mg per meter square arm, with an 80% power of the study, one-sided alpha error of 5%, and a non-inferiority of 10%. So they concluded that there should be 130 evaluable patients expecting a 10% dropout. So they actually added 10% more patients for that, expecting for that part. The loco-regional control rates was calculated by the proportions method, and the OS and PFS was calculated by the Kaplan-Meier survival methods. Categorical variables were compared using the chi-square and Fisher test, and statistical calculations was done using the Stata or the IBM SPSS software. So now the radiation treatment, actually the treatment was delivered both by 2D conventional and by SIB-IMRT or VMAT technique, depending on whatever was the availability. There was no strict criteria that whether you had to use cobalt or whether you had to use IMRT. The dose in cobalt was 60 gray and 35 fraction over 7 weeks, which was the conventional dose. And in SIB-IMRT or VMAT, they used a dose of 69.96 gray and 33 gray at 2.12 gray per fraction. And they divided into 3 dose regions, the high dose rate, the intermediate dose rate, and the low dose rate. Chemo was given 3 weekly cisplatin, 100 mg per meter square, day 1, day 22, day 43, which was a control arm. And in the test arm, it was given 40 mg per meter square, starting from day 1 of radiation, day 1, 8, 15, 22, 29, 36, and 43. Now, this study was conducted from April 2018 to January 2021, 6 centers, 4 states. For trial purposes, the RT dose more than 60 gray and more than 200 mg per meter square cisplatin were considered adequate radiation and chemo doses respectively. The last follow-up date was 31st March 2022. Coming down to the consort, so they actually screened 472 patients, found 403 eligible patients, was 41. They treated 131 patients in each arm because few patients were either not eligible for treatment or were not treated. In the final ITT analysis, 133 patients were taken in the standard arm and 133 patients were taken in the test arm. So coming down to the baseline parameters, actually everything was pretty much similar. The median age range was around 55 to 59 years. Males were more than females. Primarily, the primary was found in the oropharynx in almost 80% of the patients, larynx 20%. P16 test was done on few cases, and there were almost everything was considered similar to each other. Coming down to the stages, most of the patients were either stage 3 or stage 4A. Only few patients were stage 4B. ECOG performance status was good. Cardiac abnormalities and this thing was well balanced. The only difference which was there, which I found on the abstract, which was not written on this, that most of the patients in the test arm had actually had a low ejection fraction as compared to the standard arm. Coming down to the treatment delivery, so radiation dose, most of the patients received almost 60 to 70 gray, almost 18 or 90% patients in the standard arm and 94% in the test arm. Nearly 75% patients received treatment by cobalt, and only 20 to 25% patients were treated by IMRT or VMAT, and the median duration of radiation was almost 51 days in both the arms. Coming down to the chemo parameters, so almost 77% patients received more than 200 mg per meter square in the standard arm and 80% in the test arm. Coming down to the median dose, where there was a difference, which you can see that only 225 mg per meter square was the median dose in the standard arm, which was the 100 mg per meter square arm, while 240 mg per meter square was the median dose in the test arm. So actually the meter square dose was higher in the test arm as compared to the standard arm. Median range and median duration of chemo was almost similar in both the arms. The CR rates, PR rates, early death rates were almost similar. The only thing is that standard arm has got a higher early death rates as compared to the test arm, 10 compared to 7. And The other parameters were almost well managed. Whether we see the radiological responses, they were also well managed. All the values were non-significant. Now, coming down to the primary endpoint of 2-year local regional control. So actually what they found in the ITT, the 2-year local regional control, the hazard ratio was 4.51, and the modified intention to treat analysis, it was 3.72. So this was well within the non-inferiority margin, which was set by the investigators. That local control rates at 2 years were 54% nearly in the test arm and 47% in the standard arm, with a hazard ratio of 0.84 and an absolute difference of 6.44%, which was more than the 5% which they had put in their statistical analysis as per this thing. For coming down to the survival data, this was almost similar again in both the arms, with most of the median survival of 25.7 months. And median PFS was same, 2-year local regional control were almost same. There were nothing which was significant in the survival data. Same as you can see in the graphs, it was almost same, whether it is time to local regional failure, the overall survival, or the progression-free survival. No significance was found either in either of the two arms. When we come down to the toxicity, there was a major difference which was seen. The test arm had less toxicity, especially when we are considering mucositis, the renal toxicity, and vomiting, compared to the control arm of high-dose cisplatin. Again, the hyponatremia was less in the test arm. IV fluid usage was less in the test arm. Hospitalization and interruptions, everything was less in the 40 mg per meter square arm compared to the 100 mg per meter square arm. For the intention to treat population, the deaths and this thing was almost same. And during this entire trial was conducted during the COVID period. So there were some unrelated deaths to COVID also, which have been reported in the study. On multivariate analysis, they found that the weight loss more than 20% and stage 2-4B were independent poor prognostic factors. So the investigators have told as a limitation that COVID pandemic had actually affected this thing, and the results that resulted in frequent treatment interruptions and affected the outcomes. So coming down to the conclusion, what they concluded was that low dose cisplatin at 40 mg per meter square is non-inferior to 100 mg per meter square in treatment, on definitive treatment with radiation and locally advanced squamous cell carcinoma, non-nasopharyngeal. It has better tolerated, has got a better toxicity profile, and it should be considered as the standard of care in all these cases. So these are the acknowledgements as put down by the investigators. Thank you, sir.
Thank you, Dr. Mayur Mayank.
Yes, sir.
I think it's the most common accepted
Yes.
treatment in head and neck cancer,
Yes,
CT plus RT.
Yes, sir.
What about the 30 mg? Most of the people, they are using 30 mg weekly also.
Correct, sir. So there was a trial from Tata addressing the same thing, sir, because as we know, Tata uses 30 mg per meter square weekly. And what they found was that actually the local failure rates were higher in the 30 mg per meter square arm compared to the 100 mg per meter square arm. So that was conducted by Dr. Kumar Prabhash and Vinita Naroha, and that was published in JCO in, I think so, 2017 or 18, if I'm not mistaken. So 30 mg per meter square is inferior to 100 mg per meter square. But according to this trial, and also there was a meta-analysis which was conducted by Struven et al., which showed that 40 mg per meter can be considered non-inferior both in the radical setting and in the post-operative.
Excellent.
Yes. Sir, we know, sir, that a cumulative dose of more than 200 mg per meter square is more important. Definitely. Yes. Yes, sir. Sir, in the end, it has to be more than 200 mg per meter square, whether we are giving it weekly or whether we are giving it 3 weekly. So the thing is that which is better tolerated, that should be the way forward, and it should be individualized. If a patient is able to tolerate 100 mg per meter square, good performance status, well-built patient, then 100 mg per meter square should be the way forward. But in other cases, we can actually split it and make a cumulative dose of 200 mg per meter square, which is our dictum.
So the Western world is using the 100 milligram per meter
Correct,
square
sir.
3 weekly.
Correct, sir.
The Indian side, if you see, majority of oncologists prefer a weekly dose,
Yes, sir.
and they are using 35 to 40 milligram
Yes, sir.
per meter square.
Because mostly, sir, people are using a flat dose of 50,
Yes,
which
50.
comes to
That's
30
why
to
the
35 mg per meter square.
35 to 40 milligram
Yes.
they are using 50 milligram as a
Yes.
flat dose.
Yes, sir.
Majority of.
Sure, sir.
Thank you, Dr.
Thank you,
Mayank.
sir.
Next speaker, Dr. Rohit Ribello, Assistant Professor, Medical Oncology, Ananta Institute of Medical Sciences, Udaipur. Delivering the talk on Association of Plasma Tumor Tissue Modified Treatment Type and Outcome. Yes, sir. Doctor.
Good morning, everybody. At the outset, I would like to thank the organizers and Dr. Sandeep Jasuja sir for inviting me for this conference. So I'll be presenting this study, Association of Plasma Tumor Tissue Modified Viral HPV DNA with Tumor Burden. It was basically a phase 2 study to find with the pick the winner concept in order to take it for a phase 3 concept, where they're trying to check if dose de-escalation in HPV positive oral squamous cell carcinomas would be the way to go. This is something that has been going on for quite some time. I think when I was doing my MD in radiation oncology, that's the time I was reading about dose de-escalation. And 2 years after working as a consultant in medical oncology, I think we are still in the clinical trial phase, and the standard of care has still not changed to dose de-escalation, although HN005 is testing that concept right now. So what they did in this particular study was, so it was activated in 2014 and ended in 2017, where they were testing P16 positive oropharyngeal carcinomas with chemotherapy 60 gray IMRT or just plain accelerated IMRT, because accelerated fractionation is known to be better than standard conventional fractionation because of the radiobiology of head and neck cancers. Acceleration does really help in improving the progression-free survival as well as the local control rate. So they're trying to see in this HPV positive group if chemotherapy can be taken out in order to reduce the toxicity profile of these patients. So this was how they proceeded with the study in P16 positive, low non-smokers, loco-regionally advanced oropharyngeal carcinomas, where less than 10 pack years was considered to be low non-smokers. Centralized review P16 was done by IHC, as we know the CAP guidelines that state that intense staining of more than 70% of the field constitutes a positive P16. Then they were stratified based on unilateral versus bilateral versus neck irradiation to 2 arms, 60 gray with 40 milligram per meter square into 6 cycles, or only 60 gray with giving accelerated fractionation, where 6 fractions per week were used as compared to the conventional fractionation of 5 fractions per week. One thing we need to note that in the further study, that is HN005, they've actually not followed the same thing, even though in this pick the winner was the chemotherapy arm. But in HN005, they've actually taken 100 milligram per meter square 2 cycles. So what they found, what they did in this particular study was they took 3 particular time points of sample collection. That is pre-treatment. They took intra-treatment, that is between 20 to 28 gray, that is in the after the 2nd week of radiation, between the 2nd to 3rd week of radiation, and also post-treatment, that is 2 weeks to 1 month post-treatment. So what they did was they took circulating tumor tissue modified viral HPV DNA detection from blood, and undetectability was defined as less than 5 fragments per ml. If HPV 16 was below the range, then they also tested for HPV 18 and other HPVs that are known to cause head and neck. Quantitative or digital PCR. Mentioned before, the plasma was taken, and the hypothesis that they were trying to test in a corporate concept was that higher TMV at T0 squared with the higher GTV of primary as well as lymph nodes. So some correlation between the tumor bulk as compared to the tumor DNA. Intra-treatment, they were trying to look at the decrease from T0 to T1. So does that rate of decrease have any correlation with progression-free survival or local regional control? And post-treatment, that is at between 2 weeks to 1 month when they've removed the plasma, they were trying to test whether this has any correlation to the 2-year local regional failure and as well as the progression-free survival. So these were the statistical methods that were used to check. So the patient demographic profile constituted about 50% of the patients had cisplatin, 87% were male, about 70% were between the age of 50 to 70, 92% white. Most were good performance status patients. Most were about 90% of patients were T1, T2, about 61% of patients were N2B. As we know that in HPV positive is more than the primary burden. So generally had a larger nodal burden. Donated at least one sample specimen. And about 40% of the patients continue to donate their samples till the time point D2. So as you can see below, the median collection times are mentioned below, and most of them actually stuck to the average time points where sample collection needed to be done. So what we can see here is most of the patients, about 78% of the patients had HPV 16 positive. About 10% of the patients, P16 positive patients, had 0 TTMV fragments at base. TTMV fragment. So GTV to T0 TTMV, and in so there was not very much significant correlation when it compares to GTV, as can be seen in the final results. The second hypothesis tested was change in TMV fragments assigned. Again, the p-value here is 0.02, so there is significant p-value difference when there is a drop in the TTMV fragments. And the third hypothesis actually showed significant benefit. That is, it had a good negative predictive value. So if there is absence of TTMV post-treatment, then definitely the negative predictive value is about 93 to 95%. So definitely this test has a good negative predictive value, as can be seen in this in the finalized conclusions. So definitely there is a basically the test they want analysis to 50%. The patient high pretreatment TTMV fragments. The MPC arm achieved a more rapid decline in TTMV by 2 weeks of chemo radiation, unlike IMRT. And the negative predictive value was 93 to 95%. So definitely in patients who do not have TTMV detectable after chemoradiation, as well as in patients who achieve a more rapid decline in the TTMV values, there is a benefit. It has a good negative predictive value. These patients tend to do much better. So the winner in this arm was the chemoradiation arm as compared to the accelerated arm, which has been taken to the next study. That is the NRG HN005, which is currently occurring, where they're trying to test 60 gray with 2 cycles of cisplatin versus 70 gray with 2 cycles of cisplatin. Probable reason they have used 2 cycles of cisplatin is because 60 gray can be delivered in 42 days. So the third cycle of cisplatin comes on day 43. So that's why I think in order to compare both arms, that is the reason they have given 2 cycles of cisplatin. And this is currently occurring. And we should see whether after this, we will be actually de-escalating dose in HPV positive, or we are still going to stick to the standard 70 gray with RT.
Thank you, Dr. Rohit. Excellent presentation. Any query?
Dr. In how many patients you are doing HPV in routine in head and neck cancer in your day-to-day practice? This is my first question from Indian perspective point of view. Number 1. How much you are inclined regarding the de-escalation treatment in a HPV positive patient? Because as Dr. mentioned that India is the capital of globe in head and neck cancer, because 33% patients are seen in North India and more than 50% patients, or you can say in Northeast. Means head and neck is more common in Northeast as compared to North India, but 33% is a big chunk. Means we listen so many talk regarding the de-escalation treatment for HPV positive patient. Where we are, as you mentioned about phase 2 trial, are we doing a de-escalation treatment? Means less than 66 gray, or a cisplatin should be less, as you mentioned, 2 doses. What your take-home message to the audience?
At present, the guideline still sticks to standard fractionation. There is no phase 3 data that has shown superiority or non-inferiority when you compare de-escalation. To be very honest with you, P16 is something that currently we are not doing in any of the patients, because from where I practice, I think Dr. Manoj would be better in this because he has more number of cash patients. But where I practice, I mainly get scheme patients, and most of them are not willing to probably do this testing. And I think most of the patients who come with cancers generally have a strong smoking history of more than 10 pack years. So this is something we are not doing currently, but I think this is something we need to start. I think there is a code that we can use to do P16 testing, but definitely P16 testing is not the final. You need to do ISH. If P16 is positive, you need to do ISH to confirm it is actually HPV positive, because P16 has, its sensitivity is very, very low. So if you look at just P16 and ISH, that is not going to be feasible in our patient population because of the financial constraints. Definitely in bigger centers, in bigger cities, it probably would be possible where they're treating more number of cash patients. But in our center, that we have this sort of constraint. De-escalation is probably something that we are trying to test, because these patients do very well compared to the regular normal head and neck patient. These patients do very well. So once these patients are doing well, now we look at reducing their toxicity and improving their quality of life. Currently, the data does not exist, but I think definitely this NRG 005 will probably give us the answer to this question. But I think we're 5 years away from that data.
Yes, excellent. Means I just want to convey you, even at our center, we are doing HPV P16. We have a subset of patients. Those are non-smoker having a tonsillar involvement or a oropharynx, and you clinically thought that probability of, as per pathologist, P16 is positive. We are advising that in a special subset of patient, not routine for all patients. This chronic smoker, there is no need. But if non-smoker and having a tonsillar involvement, oropharynx, or a big node in the neck and the primary site is low, means T is low and neck is bulky, bilateral, and young patient, we prefer that in such patient, we prefer that we should go for a HPV, because the data is going in favor of that you can de-escalate the treatment, and these patients are responding better with the chemo radiotherapy as compared to the routine patient, those who are smoker or tobacco chewers basically. So the things are changing, and this is one of the beautiful presentation by you. Thank you.
Thank you, sir.
Thank you, Dr. Rohit, and thank you, Dr. Sunil Gupta, for excellent comments. Our next speaker is Dr. Faiz Akram, Associate Professor, Department of Radiation Oncology, Maulana Azad Medical College, New Delhi, talking on the radiotherapy alone versus concurrent chemoradiotherapy in intermediate risk nasopharyngeal carcinoma, multi-center phase 3 trial study.
Good morning, everyone. At the outset, I would like to thank the organizers for inviting me. I will be presenting this abstract, which was presented in ASCO 2022. Radiotherapy alone versus concurrent chemoradiation in intermediate risk nasopharyngeal carcinoma, a multicentric open-label non-inferiority randomized phase 3 trials. Earlier evidence, looking at the earlier evidence, we know that oh, sorry. We know that concurrent chemoradiations followed by adjuvant chemotherapy has been the standard of care in nasopharyngeal carcinoma. In pre-IMRT era, sorry. In pre-IMRT era, at radio was used. In IMRT area, loco-regional control have increased and primary failures have shifted from loco-regional to distance failure. Let us see the data in the IMRT era. This systemic review and meta-analysis of more than 2,000 patients was done by Zhu et al. And was published in Journal of Cancer in 2017, comparing chemoradiotherapy versus radiotherapy alone in a stage 2 nasopharyngeal carcinoma. And he concluded that the overall survival and recurrence-free survival was almost the same. And the toxicity in the chemoradiation arm was more than the radiotherapy arm. स्लाइड नहीं कर रहा है। ये स्लाइड मूव नहीं कर रहा एक्चुअली स्लाइड ही मूव नहीं कर रहा स्लाइड मूव नहीं कर रहा यहाँ चेंज हो रही है लेकिन वो बटन में कुछ A meta-analysis was published by Wang et al. In 2018, comparing concurrent chemoradiation versus radiotherapy alone in stage 2 nasopharyngeal carcinoma. And they concluded that overall survival and progression-free survival in both the arm was similar. Again, a systematic analysis was done in 2018 by Liu et al., in which they compared the role of chemotherapy in nasopharyngeal carcinoma with concurrent chemoradiation and IMRT alone in stage 2 nasopharyngeal carcinoma. And adding chemotherapy to IMRT does not show any improvement in overall survival or local regional failure survival. A phase 2 multicentric trial was done by Hang et al. In 2020 and was published in Frontiers in Oncology. And he concluded that adding chemotherapy to IMRT does not improve treatment outcome for stage 2 nasopharyngeal carcinoma. Now coming to the main abstract. This is a non-inferiority trial. It was initiated in 2015 and the data cutoff was 3 years. Early result was presented in ASCO 2022, and this was a multicentric trial done in China. The inclusion criteria was histologically confirmed nasopharyngeal carcinoma, stage 1, stage 2, and T3N0 with patients KPS greater than equal to 70. And exclusion criteria was neck lymph nodes with extracapsular spread, maximal axial diameter of lymph nodes greater than 3 centimeter, positive neck nodes at level 4 or below, and pre-treatment plasma EBV DNA level greater than equal to 4,000 copies. The outcome was primary endpoint was failure-free survival, and the secondary endpoint was overall survival, local regional failure-free survival, distance failure-free survival, and adverse events. This trial had 2 arms, concurrent chemoradiation arm and radiation arm alone, which was the experimental arm. And radiotherapy was similar in both the arms. It was given by IMRT technique, 66 gray to 70 gray with SIB planning. And in the concurrent arm, cisplatin concurrently with 100 mg per meter square every 3 weekly for 3 cycles was given during IMRT. And the number of subjects in concurrent chemoradiation arm was 169 and radiation alone arm was 172. Primary outcome measures was intention to treat, 3 years failure-free survival. Primary. Coming to the results, the primary. The primary outcome was intention to treat, 3 years failure-free survival, which was 90.77% in RT arm and 92.1% in concurrent chemoradiation arm. With a difference of -1.4, the upper limit of one-sided 95% confidence interval was 4.5, and P for non-inferiority was significant. And per protocol analysis of 3 years failure-free survival was 90.3% versus 90.2% in concurrent chemoradiation arm, and with a difference of -1.8%, the upper limit of the one-sided 95% confident interval was 4.3, and P non-inferiority was significant. And failure-free survival did not breach the barrier of inferiority margin. Secondary outcome was almost, there was no significant difference in the secondary outcome, that is overall survival, distance, metastasis-free survival, locoregional recurrence-free survival in intention to treat populations or per protocol population. And patient in the concurrent chemoradiation arm developed significant more grade 3, grade 4 hematological and non-hematological adverse events, and vomiting, anorexia, mucositis, weight loss was more in concurrent chemoradiation arm than radiation arm. And there was no grade 5 toxicity reported in either arm. The author concluded that radiotherapy alone provide comparable disease control or survival and less toxicity compared to concurrent chemoradiation arm in the intermediate risk group treated with IMRT. Considering the guidelines, different guidelines, we can, my conclusion is that nasopharynx should be treated by IMRT as the standard of care, and IMRT with concurrent chemoradiation is the standard backbone of management of locally advanced nasopharyngeal carcinoma. T2N0, higher level of evidence are there of escaping concurrent chemotherapy. T1N1, the distance metastasis potential is not high. Using IMRT has consolidated locoregional recurrence. Adding of concurrent chemoradiation may be warranted in high risk group. T2N1 and T3N0. This is the only single randomized trial, so omitting chemotherapy should be only on clinical trial basis. Thank you.
Thank you, Dr. Faiz. Any query from the house?
So nasopharynx is not commonly seen in basically in North India, basically seen in Southeast Asia, or you can say Northeast. We have seen nasopharynx basically in a advanced stage, locally advanced stage.
Yes, sir.
Where people are talking about a NACT followed by chemo-RT, or chemo-RT followed by adjuvant 2 cycle of chemotherapy as per the guidelines.
Yes.
Means I don't know about the Southeast Asia's EB virus routinely we are not doing at our centers. Means nasopharynx we diagnosed, and depend upon the local stage we treat. Majority of time my radiation oncologist colleagues are agreed that they prefer a radical CT-RT followed by adjuvant 2 cycle. Any debate on this?
No.
Means, and for virus point of view, we are not checking the loads. Yes.
Actually, sir, this trial has been done in
I know.
a region where the nasopharynx
It's
is
the commonest.
endemic.
Yeah, epidemic. Very common disease in Southeast Asia, China, and these areas. But routinely our practice is little bit different because our nasopharynx is presented in locally advanced disease, NAC nodes, as well as yes, new adjuvant chemo RD, and if required, then adjuvant. This is a take-home message from the Indian concept point
Yes.
of view.
Thank you.
Thank you, Professor and Sunil. The next speaker is Dr. Manoj Mahajan, Director, Oncology Services, Senior Consultant, Medical Oncology, Pacific Medical College and Hospital, Udaipur, delivering the talk on nimetuzumab plus chemoradiotherapy versus placebo plus chemoradiotherapy in patients with locally advanced nasopharyngeal carcinoma. Again, a prospective phase 3 trial. Dr. Mahajan, please proceed.
Good morning, everyone. First of all, I would like to thank organizers, Dr. Sandeep Jasa sir, giving me the opportunity for the presentation. So my talk is on the nimetuzumab based. Can you run the slides? Nimetuzumab based concurrent chemotherapy in nasopharyngeal cancers versus concurrent chemotherapy plus placebo. So basically, nimetuzumab is a humanized monoclonal antibody against EGFR, and it is quite common. Almost 80 to 90% patients of head and neck express the EGFR. So we are trying to improve the overall survival rate in all these nasopharyngeal cancer. As sir has discussed, the standard of care is NACT followed by CTRT. So we are just trying to see is the addition of some molecule will improve the overall survival rate. So this abstract is presented in 2022 ASCO. It's a nimetuzumab plus chemoradiotherapy versus placebo plus chemoradiotherapy in locally advanced nasopharyngeal carcinoma. So it's a prospective randomized controlled double-blind multi-center phase 3 trial. Mostly in the all investigators are from China. So this is acknowledgement for the authors, all authors and investigators. So the background we have, as we have already discussed, concomitant chemoradiotherapy increases survival in patients with locally advanced nasopharyngeal carcinoma. So addition of nimetuzumab to radiotherapy was demonstrated to improve clinical efficacy in phase 2 study of NPC patients. And we want to prove it in phase 3 trial. So this is the phase 3 trial. Next slide. So key eligibility criteria of this trial was mainly stage 3, stage 4A patients. Primary tumor was measurable and KP was more than 70%. It was randomized in 3:1 manner, where the one arm was nimetuzumab plus CTRT. Nimetuzumab was given 200 milligram every week for 7 to 8 weeks versus chemotherapy standard 100 milligram cisplatin per meter square, every 3 weekly, 3 cycles, along with radiotherapy, which can be IMRT or conformal RT, day 1 to 5 for 6 to 8 weeks against the placebo plus the same arm. Primary endpoint for this study was 5-year overall survival rate, and secondary endpoints were objective response rate, disease control rate, disease-free survival, and loco-regional recurrence-free survival. Next slide. Okay. So randomization was done. It was quite well balanced. Treated patients were so baseline demographics are quite well balanced. Median age was around nearly 45. 3/4 patients were male patients. Carnoscopy nearly 89%, 90% in all the arms. Maximum chunk of the patients were stage 3, stage 4, nearly 90%, 98%. Nimetuzumab less than 7 times was given 3.9%. Most of the patients received more than 7 times, nearly 96% patients. Radiotherapy less than 25 fractions in 3.3. Most of the patients do completed like more than 25 times, 96%, 97% completed in both the arms. Chemotherapy more than 2 times were taken by most of the patient, nearly 95% patient. And cisplatin dose was like 246 and 244 in both the arms. So coming to the 5-year overall survival rate, this was a full analysis set, which showed median with the median follow-up nearly 75 months. 5-year survival in nemotuzumab arm was 76.9% versus 64.3%. So addition of nemotuzumab to conventional treatment provided nearly 12.6% absolute survival benefit in 5 year at 5 year. Median OS was not reached. So was the same in per protocol analysis that we'll see. Next slide. Per protocol analysis, as the slide shows, rates were 74.7% versus 64.3% at the end of 5 years, but it is not statistically significant. So it's a non-significant, though it was improvement, but it was not statistically significant for per protocol set. Subgroup analysis. In most of the subgroup, it favored like number of fractions patient has taken, number of chemotherapy, age, tumor stage. It favored the nemotuzumab arm, with except where the cisplatin was taken less than 2 times. So effect of cisplatin still, I guess we cannot deny in such advanced subgroups. So the next secondary endpoints were disease-free survival rate. In the full analysis set, we can see 3-year survival rate 65 to 65 versus 60%. Median was 50.6 months and 42.6 months. So there was non-significant difference at the end in 3-year DFS favoring nemotuzumab arm, but it was statistically non-significant. The other parameters, response rate, overall response rates, if we see overall response rates, those were quite matching. But if we see the complete response rate with the nemotuzumab in full analysis set, it was nearly 57% versus 45%, nearly 12% increment. And evaluable subjects, it was like 444 patients, nemotuzumab versus 62.49%, nearly addition of 12 to 13%. So nemotuzumab improved complete response rates up to 13.3 compared to the placebo plus CTR. The next secondary endpoint, loco-regional recurrence-free survival rate at 3 years or 5 years was not statistically different. As we can see, both the graphs are matching even at the end of 3 years and even at the end of 5 years. So loco-regionally, it was well controlled. It was both the graphs are matching. Distant metastasis-free survival, again, both the graphs are quite. Coming to the safety profile, typically most in nemotuzumab arm as compared to the CTRT. So it's more or less comparable in terms of statistics. Both the arms were, and treatment discontinuation were hardly any in both the arms. Most common side effect profile, mainly it was hematological, including leukopenia, lymphopenia, neutropenia, platelet counts, thrombocytopenia, and transaminitis. So again, the side effects were more or less numerically, though it was slightly lower, but it is comparable and statistically it is similar. So in conclusion, nemotuzumab combined with the chemoradiotherapy in treatment for locally advanced nasopharyngeal carcinoma, 5-year OS rate was increased by 12.6% with 36% risk reduction, and complete response rate was increased by 13.3%. So nemotuzumab combination, it doesn't add any new adverse effect profile, and it has a good safety profile. So this trial can be considered, and we can just think of in subset of patients, we can think of using nemotuzumab. Thank you.
Thank you, Dr. Mahajan. Any comments?
Indian picture, this is a very encouraging data, I tell you.
Yes.
But if you see the organs, they exclude the nasopharynx even for the They exclude
Yes.
the nasopharynx and given the nimetuzumab and platinum 30 milligram per meter square. Means I discussed number of times why we are excluding the nasopharynx in head and neck cancer once we are talking about nimetuzumab role plus
Yes.
cisplatin. Even Tata has shown the
Yes.
response rate. The issue is that I think so personally that number of cases are much less.
Yes. People would be much
Yes,
low
yes.
in
And-
such patient.
And
in such
second thing, as in a medical oncologist, I think the therapies are different. Peptide-based drugs are more important in nasopharynx as
Yes.
compared to the paclitaxel. If you see the guidelines and the biology. This is very encouraging data, and we should start the nimetuzumab plus platinum as Tata Memorial shown in other head and cancer patients. Why they have excluded? I personally feel they excluded because
Yes.
of the number of patients are less.
lower
I
accrual.
don't know about the other reason. Anybody can update us?
Lower accrual because even our practice nasopharyngeal carcinomas are much low.
As you suggest, this lower accrual is a one thing, and second thing is a most of them is a younger patient. Well, with the nimetuzumab also. So, if we can do a head and neck study, or we have a data of the head and neck, we should include nasopharyngeal, and as a subset, we can analyze in future.
Thank you, Dr. Majan and Dr. Sunil and Dr.
Thank you, sir.
Next speaker today is Dr. Vijay Patil, Professor, Medical Oncology, Solid Tumor, TMS, Mumbai. Delivering talk on low immunotherapy in chemo.
Am I audible?
Yes.
Are the slides visible?
Yes, sir.
Thank you for giving me this opportunity. I'll be speaking today on the phase 3 study of evaluating low-dose nivolumab with palliative chemotherapy in head and neck cancers. Coming to the background, we know that cetuximab and pembrolizumab and nivolumab do improve outcomes. But unfortunately, in our country, the access to this drug affordability basically is below 5%. And in TMH, we had developed oral metronomic chemotherapy as an alternative standard of care. It does improve oral survival over intravenous cisplatin. Its oral has minimal side effects, and it's financially very affordable. We have refined the metronomic chemotherapy to make it triple metronomic chemotherapy. It has led to a response rates of around 43%. This is as opposed to a response rate of 15%, which you get with immunotherapy in this setting. However, the responses have to be short-lived. So they used to die off after 3 to 4 months. Now, we all know that the responses with nivolumab are quite sustained. Nivolumab mechanism of action is by inhibition of PD-1 receptor on the T cells. 70 to 75% of the receptors need to be occupied for it to have an activity. Thankfully, the 70% receptor occupancy actually happens at a dose of 0.3 milligram per kg. If you take an Indian whose weight is averagely around 50 to 60 kg, this would turn out to be a dose of around 18 mg. Multiple retrospective analysis from Seoul, from Russia, and one from our group itself had suggested that low dose might have an impact, and our results were actually in head and neck cancer itself, which suggests that low dose might have an impact. So to study this hypothesis, we decided to do a phase 3 randomized study where half the patients would receive triple metronomic chemotherapy and half the patients received triple metronomic chemotherapy with a nivolumab at a dose of 20 mg. The dose of 20 was selected as we were targeting 0.3 milligram per kg. Assuming a weight of 60 kg, it would have come down to around 18 mg. And hence, we wanted a logistically feasible dose because during the study we had planned while sharing, and hence we went with a dose of 20 mg. So the patients who were adult head and neck squamous cell carcinomas, ECOG 0 to 1, who warranted palliative systemic therapy, which were 1:1 randomized. We stratified them according to the site of the tumor, the previous treatment, and what was the duration of the time after which they had failed. The primary endpoint was overall survival, and the secondary endpoint was progression-free survival, quality of life, and adverse events. Nivolumab 20 mg was actually given 3 weekly. This was the sample size analysis which we had done. We actually wanted a nearly 14% improvement in overall survival to be considered that it would be good. And our ethics actually had asked us to do an interim analysis. It was a planned interim analysis that had to be done after 75 events had been done. And we could actually stop the study for efficacy if the p-value would have gone below 0.006, and that exactly what happened, and hence the study was stopped after the first interim analysis. When the first interim analysis was done, at time 151 patients had been recruited in the study, 75 in the TMC arm and 76 in the TMCI arm, and all patients were included for intention to treat analysis. One patient in the TMC arm, his intent got changed. He was initially labeled as palliative, but after rediscussion, his intent was changed to curative and has had to be withdrawn from the study. So for per protocol analysis, there were 74 patients who were there in the arm. Now, if you look at the baseline characteristics, which were comparable between the two groups, as it is a case seen in most of the TMH studies, oral cavity predominates, and nearly 90% of our patients in this study also have oral cavity. This is an interesting bit of information. We don't have information about PD-L1 scores in oral cavity from India yet. And what this shows you is that if you look at this, greater than 50 PD-L1 score is nearly seen in 25 to 30% of our patients. 1 to 50 is seen in nearly 45 to 57% of our patients. So very few patients, actually only 15% of the patients, actually 10 to 15% comes out to be negative. So nearly 80% of the patients of oral cavity have a PD-L1 score which is greater than 1% or more. Now, the kind of population selected for this study was what we see in a real pragmatic world. Most of these patients had received previous treatment, which was 62%. And if you see, most of them had failed before 6 months. And that is nearly occupying 2/3 of the study population. So we are looking at a population which has very poor prognostic features. And most of them had received some form of therapy, 60% of them either a platinum or a taxane previously. Why is this important? Because when we compare these results with the other, we must understand that most, nearly 2/3 of the patients in this study had previous exposures to chemotherapy and had failures within 6 months, which would put it as a platinum refractory disease. It came as a surprise to us, but we saw amazing response rates with the use of triple metronomic combination with immunotherapy. And the response rates, so just to give you a purview here, cisplatin 5-FU or paclitaxel carboplatin gives a response rate of in the range of 25%, 20 to 25%. Cetuximab plus cisplatin 5-FU in the extreme gave a response rate of around 36%. Cisplatin 5-FU pembrolizumab gives you a response rate of around 42% in the patient who had a high CPS of 20 or more. In others, it gives actually a response rate of 36%. Triple metronomic in this situation gave a response rate of nearly 50%, with the addition of nivolumab giving it to 60, increasing to 65.2. All these response rates are in accordance with RECIST, and which radiological comparison has been done. And you could see the water plot here, which would see not only the response rates are increased, even the depth of response was higher with addition of nivolumab to the triple metronomic chemotherapy regimen. This is one of the regimens in head and neck cancer which has the highest documented response rates which have been reported up till now. Did it lead to improvement in progression-free survival? Yeah, it did lead to an improvement in progression-free survival. The 1-year progression-free survival improved from 3% to nearly 27.5%. Did it met the primary endpoint? Yes, the study met its primary endpoint. The 1-year overall survival jumped by an whooping amount of around 28%. Did it lead to a increment in side effects? Logically, when we are using such a low dose of nivolumab, it shouldn't, and that's what is seen here. If you could see, not much increase in side effect with the addition of nivolumab to the triple metronomic regimen. Overall, both the arms are well tolerated with grade 3 and 4 side effects of less than 30%. This in contrast to the extreme regimen where grade 3 and 4 side effects are seen in 80% of the patient. Uh, uh, in contrast to the keynote 048 regimen, where grade 3 and 4 side effects are seen in nearly 85% of the patients. Did it lead to improvement in quality of life? Yes, it did. Physical functioning, role functioning domains were much improved with addition of nivolumab. For the sake of time, I'm not showing you the increase in symptom scores, which were better with addition of nivolumab. The key point was immunotherapy is inaccessible to our patients. Here in this chart, according to the uh, cost of the drugs, which is at Tata Memorial Hospital, it does not take into account the cost of administration, adverse events, or doctor's visit. Only the cost of the drugs. You could see this is what in US dollars would be the cost for a keynote 048 regimen. This would be for extreme. This would be for using single agent pembrolizumab or nivolumab. And this is with the cost of triple metronomic with additional low dose nivolumab lies. There's a slash in price of around 95% in the cost of the drugs itself. If you take into account that the adverse events decrease from 85% to 30% with triple metronomic, it's mainly a oral regimen with 3 weekly low dose of nivolumab. The cost will further slash down with this regimen in comparison to keynote 048 and extreme regimen. So to conclude, this is the first randomized study which has actually shown that low dose nivolumab addition to metronomic chemotherapy improves outcomes. And it is an alternative to those patients who cannot access full dose checkpoint inhibitors. Can it be as good as full dose checkpoint inhibitors? At present, we don't know. We need to do another study to see that. But it is definitely an option to those patients who cannot afford full dose checkpoint inhibitors. I need to thank the funders, which was mainly Motivation for Excellence, Mumbai Oncology Association, Natco Pharma, Intas Pharmaceuticals. I need to thank Dr. Kumar Prabhas sir, under whose guidance this whole study was done, and all the team members. Well, thank you. If there are any questions, I'll take them.
Any query from the house? So if there's no query, thank you, Dr. Pat.
Thank you. Thank you.
How are you, sir?
Yeah, I'm fine. Fine. Nice to see you.
Yeah. So I was just like, we have used 20 milligrams. Since 20 milligram vial is not available, nivolumab. So do you think that same vial can be used after 21 days?
So this is a good question, and this is the question I keep getting a lot. So when we did the study, there was no data on stability of open vial of nivolumab. Now there are two papers. One has come in JOP and one has come in some other journal. One from the Japanese and one from the European group. Both show that the nivolumab vial, once open, the activity and purity is maintained for 28 days at least. So we at Tata actually are using, like, the patient buys a 40 mg vial, takes 20 mg and keeps it like trastuzumab in the fridge and uses the 20 mg in the next setting.
Thank you, sir.
Thank you.
Thank you, Dr. Vijay Patil. If
Thank
there is no query, here the session of head and neck cancer is over, and I hand over the mic to for next pharmacist to organizers. Thank you all for patience sharing.
So thank you Oncology from the prestigious Bhagwan Mahavir Cancer Hospital and Research Center in Jaipur. Sir is going to speak on individualizing patient journey. Infected metastatic squamous cell carcinoma of head and neck.
Very good evening, everyone. Thank you, organizers, for this opportunity, and Merck to provide me this opportunity for this session on carcinoma of head and neck cancers. So, patient with recurrent squamous cell carcinoma of head and neck has different needs, and they have different abilities to tolerate treatment. Like they need a treatment that prolongs survival. They need a rapid tumor responses because of heavy tumor burden causing symptoms. So they need a rapid response. But most of the regimes in past have used 5-FU infusion, which may be a challenging and complex thing, may not tolerate 5-FU. And most of the patient, because of either renal functions have in tolerate. So this is the treatment landscape of recurrent metastatic squamous cell carcinoma. So up to start of the century, we had only chemotherapies like methotrexate, paclitaxel, docetaxel for either single agent or in combination for recurrent carcinoma of head and neck with overall survival of up to 6 months. Only in 2008, when this extreme regime came, we had a survival of 10 months for the first time, but subsequently post decade, in middle of last decade, we had some in 2019, first of chemotherapy and plus TPX, which is extreme regime with taxanes. And then in 2020, now we have some data of TPX followed by ICI, which has led to highest ever overall survival of 21 months. So coming to first line treatment, extreme study, it was an open label randomized multi-center phase 3 study in first line recurrent squamous cell carcinoma, and the patient was randomized to cetuximab plus platinum based CT or chemotherapy alone. Chemotherapy was cisplatin or carboplatin with 5-FU day 1 to day 4. And if there was response or stable disease, they were allowed to go on maintenance cetuximab monotherapy in one arm. Overall endpoint, primary endpoint was overall survival. So the overall survival was significant 0.4 months with a hazard ratio of 0.8. As far as response rates are concerned, the overall response rates were 36% versus 20%. And duration of control of disease, then it was 80% versus 60%. Extreme regimen significantly improved pain and swallowing compared with CT alone. Like these parameters, you can see this problem with social contact, social eating problems, speech and sense problems, these and swallowing problem. These were all much better improved by addition of cetuximab. Then we had a TP Extreme, which is a large randomized study comparing the TPX, that is cetuximab, platinum, and taxane with Extreme. And this was also in first line recurrent metastatic squamous cell carcinoma. Patients were randomized to Extreme arm versus TPX arm, which contained cetuximab 400 milligram plus cisplatin 75 milligram per meter square and docetaxel. So major differences were cisplatin dose was 100 mg in Extreme, while it was 75 in TP Extreme. There's in Extreme they were given 6 cycles, while TP Extreme was only 4 cycles. And further, this maintenance cetuximab was weekly in Extreme, while it was 2 weekly in TP Extreme. So as far as the results are concerned, the overall response rates and median OS, these were more or less similar in both arms, but the rate of progressive disease was less with TP Extreme. But there were other differences like convenience because of 4 days of 5-FU infusion, which was not required in TP Extreme. Grade 4 adverse events were more in Extreme as compared to TP Extreme. CT exposure was 6 cycles in Extreme, while it was 4 cycles in TP Extreme. And maintenance was weekly cetuximab versus 2 weekly cetuximab in TP Extreme. And number of patients who received and planned number of cycles, they were more in TP Extreme, 72% versus 44%. So these are the trials which shows that cetuximab plus chemotherapy in first line recurrent setting is efficacious. The left one, the orange one are for Extreme and right one is for TP Extreme. In all these trials, the response rates of 30 to 60% have been reported, and overall survival in the tune of 10 to 14 months have been reported in various trials. These are also the various trials, and the pink ones are the real world data from India also. They have shown responses up to 70 to 80%, and overall survival again this in the tunes of 9 to 14 months in various trials and real world data. Now coming to Keynote 048 trial, which was for pembrolizumab plus minus chemotherapy versus Extreme regimen in first line recurrent squamous cell carcinoma of head and neck. So these were all patients were randomized into 3 arms: pembrolizumab monotherapy with 200 milligram every 3 weeks up to 35 cycles, pembrolizumab plus chemotherapy, in which pembrolizumab plus carboplatin and 5-FU was given for 6 cycles, followed by pembrolizumab maintenance. And third arm was Extreme arm, in which cetuximab, carboplatin or cisplatin with 5-FU was given and followed by cetuximab maintenance. This is the breakup of PD-L1 expression of these trial patients. So 15% patient had PD-L1 less than 1 CPS, 42% has 1 to 20, 43% has more than 20% of CPS positivity. So pembrolizumab monotherapy has not shown any superior OS over Extreme in intent to treat, borderline in CPS 1, and significantly better in CPS more than 2. You can see this left side curve, which is of intent to treat, the hazard ratio is 0.83. The upper one, CPS more than 1, the hazard ratio is 0.74, which is borderline significant. Curves are separating well after 8 to 10 weeks, and there is slight plateau also. In CPS more than 20, again the curves start separating at 8 to 10 weeks, and there is wide separation of curves with plateau. When we talk about chemo plus pembrolizumab as compared to Extreme, it was in intent to treat and 7.7 in CPS 1 more than 1 and CPS more than 20. Again, the overall survival was better with pembro plus chemotherapy as compared to Extreme arm, and again the curves are separating well and plateau after but again because in this Keynote trial, after overall response better OS, the response rates are similar to extreme with as compared to pembro plus chemotherapy, but there were more progressions in pembro plus chemotherapy arm as compared to extreme arm. You can see on extreme left and extreme right these highlighted curves. So response rate, one is for CPS more than 20 and one is for CPS less than 1. So response rates are although similar, but the progression of disease, which is in the lower part, which is almost double with pembro plus chemotherapy. And in right side of curves, this is for pembrolizumab monotherapy versus extreme. Again, response rates are very low with pembro monotherapy, and progressive disease are more in all groups, I mean, irrespective of CPS 1 or 1 to 20 or more than 20. So again, now we see the CPS less than 20 population is approximately 57% in this Keynote 048 trial. And why it is significant? Because there was no PFS and OS advantage with pembrolizumab monotherapy versus extreme in CPS 1 to 19 subgroup. There was again no PFS advantage and numerically higher OS with pembrolizumab plus chemotherapy as compared to extreme in CPS 1 to 19 subgroup, and higher overall response rates and less progressive disease with extreme as compared to pembrolizumab monotherapy or pembrolizumab chemotherapy in CPS 1 to 19 subgroups. So in those patients who have CPS more than 20, definitely pembrolizumab had better overall response rates and better OS. But in CPS 1 to 19, the overall response rates were less, progressive disease was more, and OS advantage was not there. Now coming to second line treatment. So these are the two trials, Checkmate 141 for nivolumab and Keynote 040 for pembrolizumab. Both are phase 3 open label trials. Both have randomized a patient of recurrent head and neck squamous cell cancer within 3 to 6 months of failure of platinum to nivolumab versus investigator choice or pembrolizumab versus investigator's choice. Investigator's choice consists of Erbitux, cetuximab, methotrexate, or docetaxel in both these studies. The median OS was statistically better with nivolumab or pembrolizumab in both trials as compared to investigator's choice treatment with significant p-values, but PFS was not significant and response rates were also not very high, and they were also not significantly different. So in if we talk about the treatment options, either we have option of using the extreme or TP extreme arm trial regime followed by immune checkpoint inhibitors in second line, or we can use pembrolizumab monotherapy or pembrolizumab plus chemotherapy as per Keynote trial followed by extreme or TP extreme in second line. So in TP extreme study, those patients who had received second line treatment, 64% patient received second line therapy after failure of TP extreme, and out of this 17% had received IO and 44% had received other type of chemotherapies or cetuximab based treatment. And if we see those patients who had received IO after TP extreme, they had a significantly better OS, like 21.9 months as compared to 14.9 months those who have not received IO after failure of TP extreme. While in extreme arm, there was no significant difference in survival, irrespective of what treatment they received in second line. So this is again the curves. In extreme arm, there was no difference, but in TPX arm, those patients who have received IO after TPX chemotherapy, they had better OS as compared to those who did not receive. This is another poster presented in ESMO Asia from India. So they used paclitaxel, carboplatin, and cetuximab in a weekly fashion for 12 weeks, followed by cetuximab maintenance. So PFS was 7 months and overall response rates of 80%. And upon progression, they received either nivolumab or oral metronomic chemotherapy. And those who patient received nivolumab as second line, they had better PFS of 6.5 months and OS of 20.4 months as compared to oral metronomic therapy, which had PFS of 2 months and oral response of 10% only. So they concluded that first line weekly chemotherapy with cetuximab is an effective regime for palliative therapy for platinum sensitive recurrent metastatic head and neck cancer, and addition of second line nivolumab on progression improves the outcome. This is another retrospective observational study in which they analyzed those patients who have received cetuximab first followed by IO, or those patients who have received IO first followed by cetuximab. So the result shows that median OS was similar in both arms, but the response rates were significantly higher with those patients who have received cetuximab first followed by IO. So to conclude that pros and cons of immunotherapy. So pros, ICP inhibitors are no doubt the therapeutic highlight of decade. Clinical activity in heavily pretreated patients after failure of chemotherapy, mild toxicity profile, more suitable for elderly and frail patients, and longer follow-up is needed, but more patients are expected to survive beyond 5 years as per the plateau of curves seen in Keynote 048 trial. Cons, there is risk of early progression because response rates are very low, especially in a locally recurrent symptomatic disease, those who have high volume disease in a locally confined space with vital structures nearby, nerves involvement. So they may not get benefit response also, and they are at risk of early progression. There is a high rate of disease progression compared to extreme, irrespective of CPS in Keynote 048 trial. Risk of hyperprogression as seen with immunotherapy drugs, which is always there in 25 to 30%. And there is a subjectivity in toxicity evaluation of treatment-related adverse event and difficulty in recognizing immune-mediated adverse effect also. There are some unanswered questions, like there is no direct comparison between two immunotherapy arms. CPS more than one, OS was highest in Pembro plus chemo, followed by Pembro and followed by extreme. But in CPS more than 20, OS was highest in Pembro monotherapy arm, even more than Pembro plus chemotherapy arm. And we need to understand this for further treatment sequencing. More long-term survivors are reported as compared to long-term responders. More information on disease subgroup and subsequent treatment in each subgroup is required. And lastly, carboplatin was the main platinum in Pembro plus chemo arm, while in extreme it has been shown that cisplatin is associated with more responses and long-term survival than carboplatin. So to summarize, it is important to maximize response in first line when patients are still relatively fit. Platinum compounds represent the chemotherapeutic backbone of curative and palliative treatment. So distinction between sensitive and refractory disease has to be made. Treatment needs to be individualized based upon the CPS score, although CPS high is not absolutely predictive of response. The biological age and frailty, which always argues in favor of immunotherapy. Disease burden and pace of disease, like bulky, symptomatic, rapidly progressive disease, always favors chemotherapy. Multiple studies and real-world evidence supports extreme in first-line treatment of recurrent head and neck cancer. TP extreme showed a favorable safety profile, adverse events, and convenience than extreme. Choice of chemotherapy agents vary as per local practices to use cisplatin or carboplatin or paclitaxel, docetaxel, whatever they want to use. But prioritizing cisplatin over carboplatin may improve local control. In second line, no chemotherapeutic agent is superior over other. TP extreme is the treatment option for patients with high tumor burden or symptoms that mean a rapid response is key treatment goal. Good availability and affordability of immunotherapy per se does not guarantee optimal cancer care, because there are negative immunotherapy trials also in head and neck cancer. Optimal sequencing helps to improve OS in patients. Results from TP extreme and real world evidence on sequencing has shown higher OS in patients receiving first line cetuximab based treatment followed by IO based treatment. Thank you. Thank you, sir.
Deepak, what about the patient selection? All stage patient or advanced head and neck cancer in this study?
Only recurrent, those who are not amenable to further local treatment or metastatic.
What about the primary? In advanced stage or stage 1, stage 2? You have recurrence may in any stage.
No, sir, recurrence, those who are advanced means those who have stage 3 or stage 4, those are not amenable to surgery or RT.
Okay. Is there any study because of nivolumab and cetuximab? Nowadays, persons are using nivolumab also.
Sorry, sir?
Nivolumab.
Nivolumab, no, I am not aware of, sir.
Okay.
Thank you, sir.
So thank you, Dr. Deepak sir, for such a elaborative and fantastic presentation as always. We move to the next session, and this again is academic partners is Biocon, and it's a pleasure to welcome and invite Dr. B.S. Ankit Nehra, consultant medical oncologist at SCG Hospital, Jaipur. So Dr. Nehra, welcome, sir, and Dr. Nehra is going to speak about the quality of life in locally advanced head and neck cancer patient.
Good afternoon, everyone. Thank you, organizers and Biocon, for giving me this opportunity. I'll be talking about quality of life in locally advanced head and neck cancers who are being treated with radical intent. So quality of life management in locally advanced head and neck cancers who are being treated with radical intent. Can I move my slide from here? Yeah. Next slide, please. So quality of life, by universally accepted definition of quality of life, it is a multi-dimensional because there are element of emotional, social, physical well-being. It is a process. It might change with time. It can be different at the baseline, during the treatment, and after treatment when the patient is recovering. And it is subjective because it is a questionnaire. So it relies primarily on the patient's judgment of the symptomatic burden. So quality of life in head and neck cancer is primarily impacted by site of the disease, the burden of the disease, and the modality of treatment what the patient will be receiving, either a surgery or a radiation or concurrent CTRT. Major factor which affects quality of life the patient who are undergoing concurrent CTRT is xerostomia, taste disturbances, dietary restrictions, dysphagia, and pain. Other factors like social implementations, social impression of the relatives, and even the depression. And the quality of life is measured by EORTC quality of life questionnaire version 30, and quality of life head and neck version 35. Next slide, please. So this is a 2020 cross-sectional study from Patna, where assessment of quality of life in radically treated head and neck cancer patients were there. Next slide, please. So as we know, head and neck cancer poses a significant healthcare burden in India, and almost 1/3 of the patients usually present in first-line setting. Okay, fine. Thank you. And the multimodality treatment is often recommended, which has a detrimental impact on quality of life. And to assess the objective of the study was to assess the diverse domain of the quality of life of radically treated head and neck cancer, and the impact of treatment after completion and on subsequent follow-up, how the quality of life remains and improves. So if we see the distribution of the patient, total number of patients was only 73, relatively less number of the patients. Most of the patients of oral cavity, almost 75% of the patients were either in stage 3 or stage 4A, 4B. And most of the patients received surgery followed by adjuvant RT. And a time gap between the completion of the treatment and researchers interview, there was study was done at baseline and up to more than 24 months. So if we see this impact of treatment of a type of treatment or the quality of life question is based on EURTC quality of life 30. So the treatment was either a concurrent CTRT or RT, radical RT alone, or a surgery followed by adjuvant CTRT, or surgery followed by RT alone. So global healthcare, EURTC quality of life questionnaire comprises of scoring from 0 to 100, where 100 being the best in terms of functioning of the patient, and 0 is the worst outcome. So almost all the patients, whether of CTRT, RT, surgery followed by adjuvant RT, or surgery followed by CTRT, the global health status being at a physical functioning, role functioning, emotional functioning, and cognitive functioning, it was almost equal in all of the subgroups. Moving on the symptoms like fatigue, nausea, vomiting, pain, dyspnea, insomnia, it was also it was also similar in all subgroup of the patient. It was more in RT alone patients, but it was not statistically significant. Again, the swallowing difficulty in swallowing was again in RT alone arm was higher.
margin is stage on. In breast cancer, yes, we can take a review cancer after the neoadjuvant chemotherapy. Even colon cancer, even rectum cancer, we surgeon decided the newer margin as earlier after neoadjuvant chemotherapy. But still, a lot of institution, lot of surgeon with the help of the plastic surgeon and infrastructure, they are slightly reusing the, but still the data is not encouraging.
Yeah, it is
So
a gray
we
zone.
usually landed into the R1 resection, and later on we have to push means every patient had to push the CT-RTA, of course, there is no problem. But still in head and neck cancer, because the unavailability of the good neoadjuvant chemotherapy, this thing has not come up in picture.
So I agreed. What I can make from this discussion is that most of the times the first goal is to get a R0 resection, and after that, if we can do a functional result to the patient, then we can think of it. Like in tongue, we can get a more less resection if patient has responded well. So is chemosensitivity a good prognosis, or what are the challenges you face after a neoadjuvant chemotherapy has been given to the patient? So first question to Dr. Varun. What is, if the patient has responded well to chemotherapy, say there is partial response to the patient. So does those patients have good prognosis?
Yes, definitely not in terms of surgical excision. Probably I would say it probably would only make a technical difference for surgeon after this thing. But as far as the total disease outcome is concerned, if we have administered chemotherapy in preoperative context because of advanced disease, and if it has reduced, it definitely indicates a good prognosis, because anyhow patient is also going to receive some adjuvant radiation or RTCT also. So if it has, he or she has responded good to initial chemotherapy, definitely the adjuvant which we are going to give with the intent of getting DFS or OS advantage, which probably will be more if the disease is sensitive to the modality. So definitely it would make a difference in prognosis.
I agree. Subjectively, we feel that it is good prognosis and most of the patients do well. But again, we lack strong phase 3 data, which says that an induction chemotherapy improves the survival. So we don't have very strong data to support that. But obviously, from surgical point of view, resectability point of view,
NACT anyhow doesn't have a strong data in this thing, head and neck. So.
Yes, yes.
In the subset, around 20% patient they develop complete remission. So in these patients, we can expect good overall survival or result tumor control.
Absolutely. Dr. Mukesh, next question that do you feel that some patients do progress while giving induction chemotherapy? There are 10 to 20% of the patients when we offer them induction chemotherapy, they are somehow going to progress. So are we missing an opportunity for curable treatment in such patients?
In resectable disease, neoadjuvant is not a good idea, and risk of progression always is there in neoadjuvant treatment, either in head and neck cancer, in breast cancer, everywhere. So it is a tricky situation, and we have to manage and try to avoid induction chemotherapy in day one upfront operable disease.
Agreed. So basically in resectable disease, we should try to offer it afferently if the patient is operable. And coming to inoperable setting, patient comes to you with anterior tongue with a 6 centimeter node with complete encasement of carotids. And second scenario is CA buccal mucosa with intracranial extension. So obviously these patients are apparently inoperable, but do you try for curative treatment in such patients? Would you like to give induction chemotherapy in such patients, or you would like to?
In our practice, we are routinely sending such patients for neoadjuvant treatment, and to be more precise, we are sending for induction chemotherapy, because what we have learned from our radiation colleagues is they are also comfortable. They also want that the disease burden should come down before we start the radiation in such patients. So again, with a doubtful outcome, but we do send such patients for induction chemotherapy.
Okay, and any chances of surgery in these patients in future if responded very well, or definitive CTRT only?
Such patients, it depends. It
Depends on the response.
But we generally don't see that kind of response in such
Absolutely.
patients. They generally don't.
Because of poor biology. Understood. Dr. TP Soni, sir, your take on this? Definitive chemoradiation in such patients after?
Such a large node, 6 centimeter node, my choice will be neoadjuvant chemotherapy followed by response assessment. Review for radiotherapy or surgery according to the response. Around
20% patient will develop a good response, complete response.
Okay, definitely. And what is your take on definitive chemoradiation after induction chemotherapy? How many patients do have long-term survival after offering definitive chemoradiation as compared to surgery?
In oral cancer, inoperable, role of radiotherapy, even after radical CTRT, we expect poor local result and overall survival, and I expect 1 to 2 year disease-free or oral survival.
Absolutely agree. Long-term survival hardly in the tune of 10 to 20% in such subsets. So coming to the important subgroup, that is technically unresectable disease. So what we have discussed till now, that unresectable disease, if we give CTRT, 10 to 15% of the patients have long-term survival. And if we give induction chemotherapy, then probably 40 to 60% of the patients in a technically unresectable group might be converted into surgical candidates. And rate of R0 resection is around in the tune of 40 to 60%, depending upon the response and induction chemotherapy received. So what are the technically unresectable groups? I would like to start with Dr. Pawan sir. Okay. Dr. Gaurav, what are the technically unacceptable disease when you like to offer induction chemotherapy?
Again, that when we have a T4B disease, where again we have an N3 disease, which is encasing major vessels. So these are the two indications in oral cavity.
And if the disease is involving vallecula, oropharynx, and disease involving extensive skin involvement and zygoma, ITF.
Yes, Dr. Mukesh sir.
I just want to ask, is any terminology still exist, or in NCCN guidelines there is a moderately advanced or very advanced disease?
Yeah.
There is no such terminology.
There is a separate thing where we label this as an advanced head and neck cancer. If we talk about TNM, then we have T4B disease coming into it, N2, N3, and metastatic. Metastatic again as a different thing, but definitely T4B and N2, N3 disease comes under advanced head and neck cancer.
Yeah, so basically NCCN does not mention these subgroups, but from surgical and decision-making point of view, these indications have been made. And in many of the trials, they have used in this way. TMH has many trials on this. So these are the main indications from our discussion, that disease with edema up to the zygoma, or disease reaching up to the with high ITF involvement, with involvement or valvular involvement. These are the indications where they are technically unresectable at day 1, and these patients should be offered induction chemotherapy if they are fit for it. So now coming to the discussion of induction chemotherapy regimen, I would like to start with Dr. Mukesh. What is your take? What is your preferred regimen? Say you have 10 patients when referred for induction chemotherapy. How many patients would receive triplet, a DCF, and how many patients would receive a doublet?
I would like to give triplet therapy, and it is definitely TPF. And most of the patient very difficult to tolerate TPF, and we used to give only 3 days, 550.
You give only 3 days, right?
And few patients are not able to tolerate. Then we have slightly modification of TPF 3 weekly to weekly TPF.
Okay, you give modified weekly dose. Okay.
Yes. Modified weekly TPF. It also shows very good response.
And do you use doublet in some patients, or you shift to weekly, triplet weekly if this is not tolerated?
Status is very good and no comorbidity, then 3 weekly. And if patient is borderline, then we
say 65-year male, but ECOG PSS1 is fit, so you would like to go for TPF 3 weekly, 3 days, but you don't use 5 days. Okay. Dr. Pawan sir?
Delivery of the chemotherapy is important, as we discussed, and usually probably in Rajasthan, we all institution using 3-day TPF, and even some of the institutions still using with infrastructure PICC or port insertion also, and no Baxter pump, no other they are using. But now the question is doublet, and means I say that during COVID period, even in the fit patient during COVID period, to avoid the hassle of a 3-day admission in the hospital. We used almost 2 and 3 year doublet also. And I'm sorry to say, but is a doublet is again a little poor responser than the TPF as we use.
Agreed, sir. But point well note taken that in such patients when time when there is crisis, we can use doublet. And what is the doublet you use? Or do you use carboplatin or cisplatin? And
Carboplatin, paclitaxel carboplatin.
Carboplatin. Dr. Varun?
I would like to differ a little. What I do is usually I divide the patients whether they are fit enough to get triplet or doublet first. And if at all triplet, then that patient has to be fit enough to get the complete 5 days regimen is what we do. We have the facility of chemo port insertion and PICs at our place. So if the patient is fit enough, we give the full dose, and we don't keep it admission for 8 or 10 days, just for the infusion time. And after that, we monitor the patient on an OPD basis only. So and if patient is not fit, then definitely doublet. As sir said, doublet is always a valid option.
So we see all the 3 institutes having slightly different practice. They are modified in their way. I would like to give just my input. So basically, I also agree that I see the fitness of the patient. If patient is fit for triplet, then I decide whether to give for 3 days or 5 days. If age is more than 50, 55, then I go for 3 days. If patient is quite young, less than 45, 50 and fit, I go for 5 days infusion. And if patient is very frail or borderline, then I go for doublet in those patients. And PSCC in port, we do recommend PSCC to most of our patients. So doublet data we'll be discussing in next few slides. We have around phase 3 data of comparison of doublet with triplet. And I would like to make a point in doublet. We usually prefer cisplatin based regimen when it is curative. But again, it varies from individual to individual practice. So any take on OMCT with paclitaxel data? There was a retrospective analysis in ESCO 2022. If anyone has gone through it, Dr. Varun.
In neoadjuvant setting?
In neoadjuvant setting, it was a retrospective data of around 80 or 70 patients. And response rate was very good, more than 90%, and almost 2/3 patients were converted into surgical resectability in the surgical borderline resectable group. Yeah, Pawan sir or Dr. Mukesh sir, you are using it? We have started in 3-4 patients. Yeah. It is weekly paclitaxel with OMCT. We have started in 3-4 patients. Let's see, time will tell whether they are going or not. Yeah. I mean, it has response rate in that means partial response rate in the tune of 80 to 90%. So more than the doublet. So let's see, but it's a retrospective analysis, so it's difficult to comment on it. So number of induction chemotherapies. Do you offer more than 3 cycles in any of the patients, or 2 or 3? Any surgical change in surgical setting, morbidity or mortality in those patients who have received induction chemotherapy, or any surgical difficulties you find, that something fibrosis or something you find with post chemotherapy
patients, especially when we are offering plastics, encountered difficulties with the vessel status.
Particularly in my clinical practice, although we explain very well, counsel very well to the patient, but most the patient who respond very well after the neoadjuvant chemotherapy, they lost to follow up because they said we got a response, our each and everything is all right, so we should avoid this surgery. And after 3-4 months or 6 months down the line, they again recurrence as suspected and they come back. And now, sir, Dr. Sahab, ab kya kare? So this is again an observation by me.
Absolutely agreed, sir. Because we need to counsel the patient that definitive therapy is must. Otherwise, there is no role of giving such toxic induction therapy. So in every patient, we should discuss with the patient the whole plan of therapy. That if we respond, then what is the plan? If we not respond, then what is the plan? We should brief the patient and should discuss well with the patient and family. So going through this, just some newer data presented in ESCO 2022, that we discussed that phase 3 randomized study comparing doublet docetaxel with platinum, that is with cisplatin versus DCF as a neoadjuvant chemotherapy in technically unresectable group. We have already discussed the indications of technically unresectable group. Patients of oral cavity, borderline unresectable, were randomized into docetaxel cisplatin versus DCF arm. Primary endpoint was OS and secondary endpoints were PFS and adverse events. If you see the OS data, the 2-year OS of triplet arm was better, 29% versus 23.5%, and hazard ratio was 0.8 with the triplet arm. We see about the PFS, then 2-year PFS was again better in the triplet arm with hazard ratio of 0.8. If we talk about adverse events, obviously triplet was slightly difficult to tolerate with more diarrhea, FN, neutropenia, and electrolyte imbalance. So this concludes that triplet induction regimen is superior to doublet in improving survival. However, it comes at the cost of additional toxicity. Coming to adjuvant radiation, now few set of questions for Dr. T.P. Soni sir. So what are the indications of adjuvant chemoradiation in locally advanced head and neck cancer? What are the regimen schedule you use? What is the technique you use? And what are the areas you cover? And what is the change in plan post induction chemotherapy in your radiation patients? And do you need to change your plan when you are administering concurrent chemotherapy or target therapy in such patients?
So indication of adjuvant radiotherapy is stage 3-4, PT3, PT4, or multiple nodes positive, depth of invasion, perineural infiltration, lymphovascular invasion. These are adverse feature, and we have to give adjuvant radiotherapy in these cases. Positive, and extranodal extension is positive, then we add concurrent chemotherapy cisplatin, 40 milligram per meter square along the radiotherapy. Preferred technique is IMRT, because in IMRT, eyes, optic nerve, optic chiasma, and nasopharynx, oropharynx, cochlea. These are the ORs we can spare with IMRT, along with dose escalation to the primary tumor area. And with the IMRT, we can deliver SIV, where in a single day, in a single fraction, we can give 2 different types of OA and to the to the electric less single. So IMRT is preferred technique, at least. Area to be covered. Area to be covered is primary disease with margin. We have to see pre-op imaging. In case of buccal mucosa, we have to include if disease is involving upper alveolus or RMT, then we have to cover infratemporal fossa, ITF, whole buccal mucosa area. If disease is reaching up to angle of mouth, we have to, in our target area, we have to include, we have to cover the, we have to cover our target, we have to increase our PTV2. We have to cross the midline also. And if nodes involved, then we have to cover full NAC level 2, level 3, level 4. And in case of multiple node positive or T3, T4 lesion, then opposite NAC node, at least level 2 we have to include. Post neoadjuvant chemotherapy, there will not be any significant changes in dose prescription level of nodes and primary disease. To continue cisplatin.
Okay, your area to be covered changes or not? This was my question was. You take the day 1 scan or post induction chemotherapy scan for planning?
Day 1 GTV.
Day 1 scan.
Before chemotherapy.
The doses also remain the same to the area that those have responded. So as such, we don't have any benefit of giving induction chemotherapy before giving that.
After neoadjuvant chemotherapy, the size of the node may reduce. The nodal remission they may be there, visa remission may be there, but we have to cover the full buccal mucosa or full where it was
Yeah, we have
wherever.
to cover it, and the dose also remains the same. That is
Yes,
what you want.
yes.
Agreed. So coming to the concurrent chemotherapy regimen, when we give adjuvant CTRT. So first question, that what are the indications when you will use chemotherapy with radiotherapy in adjuvant setting? Starting with Dr. Mukesh.
In resectable diseases, if there is a node positive disease with margins and there is a extranodal extension, then it is an indication for adjuvant CTRT in resectable disease. And locally advanced CTRT.
Okay, those patients who have received induction chemotherapy before surgery, so in those patients you will give concurrent cisplatin to all the patients if those received induction chemotherapy, because again at nodal status and margin status would change. It will be YP after surgery. So you would you offer
status is fine and offer adjuvant CTRT.
Okay, and what is your practice to give cisplatin weekly or 3 weekly? And so you have 10 patients. Then
weekly cisplatin.
You prefer weekly in most of your patients.
Yes.
Do you use 3 weekly or you don't use at all?
No, we use 3 weekly cisplatin, but preferably we use weekly.
Okay, in selected patients only use. Okay, and what those patients who are cisplatin ineligible, what do you give in adjuvant setting after surgery?
He is like usually we give time we have to think about the age, neurosensitivity, renal function, and the cardiac function, whether we can give a lot of fluid to the patient or impending neurotoxicity, so that patient is cisplatin eligible. So in setting we can offer carboplatin, but recent data as in your coming slide, I think the docetaxel is into
data for docetaxel
cisplatin eligible patient.
Yes.
So we have cisplatin 3 is better in overall survival and local control, but at the toxicity. So preferred option is weekly cisplatin.
Yeah, Dr. Varun.
Yeah. So
Any
for,
other points?
Yeah. So the indications remain the same. If you have an extranodal or extracapsular extension, positive margin, end-to-end 3 disease. So regimen, as rightly everybody has said, weekly cisplatin is preferred. Though we I have observed, I have a little less experience than sir, and what I have observed is then there is chances of radiation being non-compliant in between because of toxicity. That hampers the delivery of radiation also if you use 3 weekly for toxicity. So weekly is definitely better. And post-induction patients, the disease anyhow is downstaged after NACT. So probably I give it to all the patients who have taken NACT for locally advanced disease. For cisplatin ineligible, if platinum is an option, if it is only cisplatin ineligible, then definitely carboplatin. But if patient is absolute platinum ineligible, then there are studies of cetuximab, probably not in a very practical practice, but docetaxel probably now might come into picture after the data.
So I agree. In my practice also, most of the patients, say 70 to 80% of the patients do receive weekly cisplatin, and we have data that it is now non-inferior to 3 weekly with decreased toxicity. I would say that in young fit patients are offered 3 weekly cisplatin, and those who have received induction chemotherapy, again I shift to weekly cisplatin if patient is fit. So this is the data which shows randomized study of weekly versus 3 weekly. We have concert study published in ESCO 2022. We have Kyoto study in 2022, which shows that OS of 3 weekly cisplatin is non-inferior to 3 weekly cisplatin with slightly decreased toxicity, especially neutropenia, cytopenias, and infection and renal toxicity. Again, we have other data which also confirm the same. PFS and OS data is also similar with weekly cisplatin. We were talking about docetaxel, that those patients, we have many of the patients, those who are cisplatin ineligible, especially those who have received induction chemotherapy or those who have undergone surgery and they have become frail and GFR is altered or age is more, then cisplatin cannot be offered. And we don't have much data, especially phase 3 data in a definitive or adjuvant setting for such patients. So we have few data, phase 2 data for cetuximab or 5FU infusional with carboplatin, but again, due to cost or toxicity, we are not able to offer to most of our patients these drugs, and most of the patients end up having carboplatin with radiation in such setting. So with this background, this was a randomized study when patients received definitive radiation versus definitive radiation plus docetaxel, either in adjuvant setting or definitive setting. Endpoints were 2-year disease-free survival and 2-year OS, along with quality of life and adverse events. If we see the 2-year DFS, then 2-year DFS was much better in docetaxel arm, 42% as compared to 30% as compared to radiation only arm, and hazard ratio was around 0.67. If we talk about the OS, then 2-year OS was also better in the docetaxel arm, reaching around 50% as compared to 41% with the radiation only arm. And hazard ratio was around 0.7 with significant p-value in the docetaxel arm. So for this trial, we have now one good option, which is again cost effective in patients, those who are cisplatin ineligible. Then now they are undergoing trials and data for those patients, like we can add immunotherapy with or without cisplatin in selected patients. So this was a phase 2 data presented with fixed dose pembrolizumab with cisplatin and IMRT in intermediate or high risk previously untreated locally advanced head and neck cancer, which included most of the patients of locally advanced head and neck cancer. There were 2 schemes of pembrolizumab. One was administered concurrently with CTRT and other was given in sequential after completion of CTRT. So primary endpoint was 1 year locoregional failure rate less than 60%, 1 year PFS more than 60%, and dose limiting toxicity less than equal to 20%. If all 3 criteria were met, the arm with numerically superior PFS would be potential regimen for the phase 3 study. So if we see the PFS data, the PFS of sequential pembrolizumab, which is given after cisplatin and completion of cisplatin and radiation, is slightly superior, and it met composite endpoint in both the arms. That was 1 year progression-free survival was more than 60%, and dose-limiting toxicity was also less than 20% in both the arms. But sequential arm had numerically better data as compared to concurrent arm. Again, same we can see with OS data that numerically sequential arm was better. So conclusion from this data was we can add pembrolizumab, but we need a phase 3 data. So sequential pembrolizumab with cisplatin and IMRT would be the candidate for next phase 3 study. And we need to have biomarkers like PD-L1 status and circulating or tumor DNA or other biomarkers, which we can individualize the patient treatment according to the precision oncology. These are a few ongoing studies like RTOG 0920 study, which again compares cetuximab plus RT versus only RT in intermediate risk operated locally advanced head and neck cancer patients. Results are being awaited. Other is RTOG 1216 study, which is again a phase 2 study, which compares cisplatin plus radiation versus ATES plus cisplatin plus radiation versus docetaxel plus cetuximab plus radiation. So this would be an interesting study, which includes targeted therapy and as well as immunotherapy in comparison with standard of care cisplatin with RT. So this is a phase 3 study. So we would definitely like to see data of this, and this might be a game changer for patients of head and neck cancer. Just last 2 slides. I would like to ask Dr. TP Soni your take on re-irradiation. Those patients who recur in previously irradiated field or who have second primary in those field, what is the cutoff you take for giving IMRT or radiation with definitive intent in such patients?
See, we have few publication on recurrent head neck cancer, IMRT. It is feasible. It is there is no clear-cut guideline, but people use recurrent re-radiation after 1 year, of previous radiotherapy. After 1 year, the BD, the cumulative BD of spinal cord or brainstem is expected to be cumulative dose should be less than 100 gray.
Okay.
So suppose previous RT dose and this time whatever dose we are giving, the dose to the spinal cord or brainstem and mandible, it should be as low as possible. There is no concept of irradiation of elective nodal area. We have to cover only the gross disease with
area.
little bit of small margin, and we can go ahead up to 50 to 60 gray doses, up to 60 gray after surgery, with the considerable toxicity rates. Severe grade 3 rate is expected up to 25%. We have to counsel the patient about the toxicity of dysphagia, mucositis, osteoradionecrosis, and subcutaneous fibrosis. These toxicity are going to be up to 25% severe, late-term toxicity also. With the overall survival approximate around 2-year-old survival approximately 50%.
30 to 50%.
50% in recurrent disease. 2-year-old overall survival rate up to 50%.
Okay, so basically this was an abstract phase 2, which again conducted IMRT irradiation with interval of 6 months. This trial included interval of 6 months from previous radiation to starting of current IMRT, and included concurrent and adjuvant nivolumab in such patients, but it was a phase 2 data. So it met its primary endpoint of 1 year PFS, which was around more than 70-75%. And so this trial is feasible. So basically we would likely to see a phase 3 trial of this subset in near future. So just last conclusive discussion about the circulating tumor DNA. We know that it is still not in practice in head and neck cancers, but just one line from all the consultants, that how do you see circulating tumor DNA in future in oral cavity or head and neck cancers?
It is useful and looks tempting to evaluation of the response or giving the chemotherapy continuously in recurrent head and neck metastatic cancer. But it's a tempting, but in Indian scenario, it's a high cost and other things, and whether it is feasible or not is still waiting.
Standardization of it.
Standardization.
Absolutely.
But it looks very tempting.
Dr. Varun?
Yes, as sir has rightly said, it looks very tempting, lucrative. It might be very useful in future. At present, many other constraints probably which might hamper us from using this, but definitely in future it might see a regular use.
Dr. T.P. Soni? Yeah, it is quite primitive stage in head and neck cancers, but we have seen from our data that in lung cancers we are using liquid biopsy very frequently. So probably this is the future. So basically this is just a data which was a liquid biopsy for detecting MRD in head and neck squamous cell carcinoma, and the conclusion was that before clinical presentation of the disease, in almost most of the patients, 11 patients recurred, and liquid biopsy was able to detect the recurrence almost 4 months before the clinical recurrence or recurrence of the disease. So probably we can start treating those patients in near future, but we need to have a concrete data due to standardization. When we will send many number of samples and we'll have a standardization and low cost, probably that will be the time we can use liquid biopsy for head and neck cancers. So I would like to thank all my esteemed panelists, and thank you, Jasuja sir, for giving me this opportunity. Thank you. I think this was the last session before the lunch, so I think we can proceed for lunch. Yeah.
So thank you so much, Dr. Hitesh, for such a wonderful presentation. And it's thank you everyone, all the esteemed panelists, Dr. Pawan Agarwal sir, Dr. Varun Nagori, Dr. Gaurav Goyal, Dr. TP Soni, and Dr. Mukesh Chaudhary for such a great interaction. Now we come to an end of the head and neck track. And thank you so much. We request all of you to please join for lunch, which is at the in front of you at the Hall Diamond 1. Thank you so very much. The next session starts at 3 p.m.
And now we straightforward go to the Deepika Chauhan, Senior Consultant, Santi Mukund Hospital, Delhi. And she will speak on comparison of quality of life in patient randomized to high dose once daily thoracic radiotherapy with standard twice daily thoracic radiotherapy in limited stage small cell lung cancer. Dr. Deepika.
So this is comparison of quality of life in patients randomized to high dose once daily thoracic RT with standard twice daily thoracic RT in limited stage small cell lung cancer on CAL-GB 30610. So as we all know, in CAL-GB 30610, we have seen that 70 gray once daily radiation therapy was not associated with a superior overall survival compared to 45 gray twice a day thoracic RT in limited stage small cell lung cancer. Now, since both arms appear to provide similar clinical benefit, how to choose which regimen is to use? So for this, so in this, we are going to find out how the quality of life impact the implementation of a particular dose trial. So in this, it was a wonderful study. Then fact esophageal cancer, eating cell line analysis, ECOG acute esophagitis scale, HADS, the EQ5D, and a single item assessing difficulty in swallowing. So all these were thoroughly implemented, and the results we will be discussing. So a patient, the time points were baseline and every odd week during radiation therapy, followed by 12, 6, and 52 weeks after starting the radiation therapy. So the primary endpoints were Fractal TOI, followed by FACT eating and swallowing subscales at 12 weeks. That is 3 months post completion of treatment. So mean changes from baseline were compared between arms using general linear mixed models. So 417 patients consented to participate in the patient-reported outcome sub-study, and the completion rate of the questionnaires were 87% at baseline and 71% at week 52, which is quite commendable. I think it's not moving. So if we come to the results, there were 646 patients, out of which 417 patients consented to participate in the patient-reported outcome sub-study. Baseline protocols for 364 patients, out of which 342 patients, at least one follow-up, and for 340 patients, baseline and at least one follow-up. The completion rate of the questionnaire was 87% at baseline and almost 71% at week 52. So if we compare the demographics, both arms were properly matched, and mostly the population, the race which participated was white race, non-Hispanic, and most of the patients were of PS 0 to 1. I think there is some issue in the cursor. Okay, so as per the result, the FACT L total score mean worsening was significantly less in the once a day treatment arm at week 3. We can see here at week 3, once a day treatment was quite superior with a significant p-value. Similarly, the same thing was depicted in physical well-being the social family well-being, and emotional well-being. So in all these three, once a day, the red dotted is once a day treatment arm, and the blue triangle is of the twice a day treatment arm. So we can see in all this, once a day treatment has done fared very well. If we talk about functional well-being, FACG score, and additional concern score, the same thing. It was depicted that once a day treatment arm was better tolerable to patients as compared to twice a day arm because of obvious reasons. So if we talk about Fractal trial outcome index, the mean worsening was less in the once a day arm at 3 weeks, and the p-value was significant, but it was greater in once a day arm at week 52. So this depicts that the acute reactions were more in the twice a day treatment arm but the subacute reactions were more in once a day arm because of 4 hours of radiobiology. So if we talk about FACT-E, it was better in once a day arm at 52 weeks. We can see it here very well. So for the acute esophagitis score, so esophagitis is the main problem, main radiation-induced side effect, which causes a lot of discomfort to the patient. So it was seen that it was worse in twice a day treatment arm at week 3. We can see it here. But it was worse in once a day treatment arm at week 12 here. So the second major concern, difficulty in swallowing, it was greater in twice a day treatment arm at week 3, but the same reversal, greater in once a day arm at week 12, which was statistically significant. If we talk about EQ5D, it was lesser, the worsening was lesser in the once a day treatment arm at 3 weeks with a significant p-value. And mean worsening in HADS anxiety, it was less in once a day treatment arm at week 5. Okay, so we can see here, if we talk about the results, the treatment convenience, we can see that treatment was inconvenient for almost, we can say, to the tune of 30 to 35% in twice daily arm as compared to almost to the tune of 25% in once a day treatment arm. And if we talk about the conveniently accepted tolerated treatment, it was 75% in once a day treatment arm as compared to 67% in twice a day treatment arm. So the take home points, both once a day and twice a day radiation regimens are well tolerated with latest techniques like IMRT or at least 3D CRT. The once a day arm had better quality of life scores at week 3, but worse scores at week 12. And the once a day treatment arm was perceived to be less inconvenient. Thank you very much for your cooperation.
Dr. Deepika, what was the difference in survival, overall survival?
So it is almost the same. So we have already proved in CalGB trial that once a day treatment versus 45 gray twice a day treatment. So like 1.5 gray, 2 times, at least 6 hours apart. The overall survival rate are similar. Both the arms. That's why they have created all these indices. They have used it very well. So all the patient-related objective and subjective assessment was done through these questionnaires. And then it was seen that once a day treatment arm was better in terms of convenience to the patient.
Any comments, opinion, questions from the house?
So we have seen one more important thing here, that during radiation, once a day treatment arm was better in terms of the radiation induced side effects. But once treatment is over, that is at 12 weeks, the recovery was better in twice a day irradiated
What was
patients.
the dose per fraction and your
What you will
selected-
suggest, whether we should practice once a day or twice a day?
So it is
Overall,
like,
overall.
mostly now once a day treatment is followed, but previously we used to follow twice a day. So with the CalGB results, when both are equal in survival, we have started using once a day treatment because it is more convenient for the patients. Yes, sir.
Thank you.
Thank you, sir.
Next speaker is Dr. Lalit Sharma. And Dr. Lalit Sharma is consultant medical oncology at Manipal Hospital, Jaipur. And the topic is 2 cycles versus 3 cycles of neoadjuvant sintilimab plus platinum doublet chemotherapy in patient with resectable non-small cell lung cancer.
Thank you for the kind introduction, sir. With your permission, shall I start? So at the outset, I would like to thank the organizers, especially Dr. Sandeep Jasuja, sir, for giving me this opportunity and for arranging this academic feast for all of us. So the job cut out for me is to reflect upon the NeoScore trial. This is basically a phase 2 trial, and it studied 2 cycles versus 3 cycles of neoadjuvant sintilimab plus platinum doublet chemotherapy in non-small cell lung carcinoma patients who were resectable. And as we know, immuno-oncology drugs, they are kind of well established and have their own standard place in the standard of care treatments of patients with metastatic and recurrent lung cancers. Now, gradually, the success rates, the encouraging results kind of encourage the investigators to look upon these molecules to improve the survivals of patients who are presenting with early stage lung cancers, be it in the adjuvant scenario, like durvalumab is now kind of pretty well established in the adjuvant setting. And then they started looking for neoadjuvant setting also and newer molecules also. So is the scenario here, and sintilimab was looked upon in this particular trial. So in the neoadjuvant setting also, with most of the data coming in, encouraging results are there, but still the duration of the treatment for the neoadjuvant setting is not yet very well established. So this is what the question they were trying to answer in this phase 2 trial, whether to use these therapies for 2 cycles or for 3 cycles in the neoadjuvant setting. So in this phase 2 study, they compared the efficacy and safety of 2 cycles with 3 cycles of neoadjuvant sintilimab plus chemotherapy in the resectable stage 1B and 3A non-small cell carcinoma. So this was a randomized open label phase 2 trial, and they recruited patients who were either 18 years of age or older, had an histologically confirmed and a treatment naive scenario. The patients were kind of staged on the base of American Joint Committee staging system. They had to be between 1B to 3A, and they must be a resectable non-small cell lung carcinoma. The eligible patients were randomized into 2 arms. One arm had 2 cycles of the treatment regime, whereas the other arm had 3 cycles of the regime. And the treatment regimes were in the form of sintilimab was given in a dose of 200 milligram plus carboplatin AUC 5. And then the squamous variant patients were given nab-paclitaxel in a dose of 260 milligram per meter square, whereas the non-squamous one were given pemetrexed at a dose of 500 milligram per meter square in a 3-weekly fashion. So which is at this point of time, the standard therapy for squamous and non-squamous histologies. So this was combined with sintilimab 200 milligram every 3 weekly. So after a surgical resection, patients then received a total duration of 4 cycles in the perioperative period. So the patients who had received 2 cycles before the surgery received 2 more, and those who had received 3 cycles before the surgery received another cycle of adjuvant chemotherapy. And then this was followed by 1 year of sintilimab in accordance with the 1 year of durvalumab, which is standard of care at this point in time. So the major endpoint which they evaluated was MPR rates, and MPR rate was major pathological response rate, which was defined in the way that the percentage of participants having less than 10% viable tumor in the pathological examination of these specimens. So this was kind of somewhat inferior response as compared to complete metabolic response or a complete pathological response, which we were seeing in other trials of neoadjuvant setting in breast carcinoma. Here we were trying to assess a major pathological response, that is less than 10% viable tumor in the resected specimen. The secondary endpoint, as usual, were pathological response rates, overall response rates, disease-free survivals, and 2-year overall survivals, and the safety data, that is the tolerability of the drugs. So the patients were recruited from July 20 to September 21. Around 60 patients were enrolled and they received the neoadjuvant treatment. The patient characteristics were pretty well matched in both the arms. And among 55 patients with successful R0 resection, they observed that a higher MPR rate of 41.4% was seen in the 3-cycle group, compared with the 2-cycle group, which had a major pathological response rate of around 26. Sorry. So it was 41% versus 26% in the 3-cycle versus 2-cycle arm. And meanwhile, the complete pathological response rate or the pathological complete remission PCR was seen in the 24 versus 19%, which was also significant. And the patients in the squamous subgroup, somehow they responded far better as compared to the non-squamous group. They achieve a statistically higher MPR rate, 51% versus 12.5% in the non-squamous rate. Then in the squamous subgroup itself, the MPR rate was around 60% compared with 43.8% in the 2-cycle arm. And in the non-squamous, it was 21% versus 0% in the 2-cycle arm. So overall, one is that the squamous pathology responded far better as to the treatment as compared to non-squamous. And in the squamous one, in both the arms individually taken, subgroups individually taken, the 3-cycle neoadjuvant regime fared far better as compared to the 2-cycle one. So the overall response rate, though, did not show any statistical difference between the 3-cycle and the 2-cycle group, being 55% versus 50% respectively. And the patients well tolerated in both, tolerated the regimes very well in both the groups, with only 5% of patients experiencing a grade 3 or worse immune-related adverse events. So to conclude, basically that NeoScore is the first randomized study comparing different treatment protocols of immunochemotherapy in the neoadjuvant setting, 1. 2 is that a 3-cycle neoadjuvant therapy achieved a numerically higher MPR rates compared with the 2-cycle regime. And more importantly, the squamous pathology was probably more responding to the neoadjuvant therapy, and they had a better MPR rate as compared to the non-squamous subtype. Thank you for the patient hearing.
Any questions or the comments from the audience?
Either the presentation was very clear or untowardly unclear.
Yes, this was very clear. Thank you very much.
Thank you.
And now we should invite next speaker, that is Avinash Talete. He's a medical oncologist, Restora Oncocare, Apollo Hospital, Mumbai. And he will speak on use of immunotherapy in patients with poor performance status identification and management of the common adverse events with IO issues, with response assessment, and with IO pseudo progression and hyper progression. Avinash.
Yeah, good afternoon, everyone. I'm Dr. Avinash Tadele. It's indeed an honor and privilege to be amongst the best of the minds here in Jaipur. And special thanks to Dr. Sandeep Bhai that he has invited to visit the pink city of Jaipur. So I had been given this tough topic and I really had a hard time finding the data for it. And I could just मैं नहीं कर रहा कुछ. What is it? Apologies. So I could just find out these the six studies which are phase 2 studies which address the immunotherapy in poor performance status. So the first one is from the this is the US based data. Is a phase 2 study of pembrolizumab with or without low dose chemotherapy with ECOG PS2 and above. Now they randomize 1:1, one arm receive pembrolizumab 200 mg alone or with combination of carboplatin AUC1 and paclitaxel 25 mg per meter square every weekly. So they had an overall 43 patients were there. They were equally divided. And pembrolizumab arm, monotherapy arm showed a CR and PR of 31%. Pem with chemotherapy showed 47%. PFS median was 257 in monotherapy and slightly better 377 in combination arm. There were no treatment related deaths reported in carboplatin. Few allergic hypersensitivity to carboplatin resulted in modifying the treatment. Again, second one is the PS phase 2 study of pembrolizumab in advanced lung cancer again. This is a UK based data where PS2 and above with more than 2 weeks of prior to the therapy, they were randomized to pembrolizumab 200 mg thrice weekly. And they were the co-primary endpoints was response rate and DCB's durable clinical benefit. And secondary endpoint was overall response, PFS, OS, time to progression, and duration of stable disease. So 60 enrolled patients were subject to the analysis, and the median age was 72 years here. 72% were ex-smokers. 60% received pembrolizumab as a subsequent line of therapy, and 48% had PDL1, which were less than 1%. So talking about efficacy wise, here the people in first line therapy responded poorly, and surprisingly second line therapy they responded well, subsequent line therapy they responded well. And there was also a very discrete data for response when there is it will be difficult to identify any inference from this data. Sorry, the median PFS was 4 months and the median OS was 9.8 months. The safety results of all those patients, few experienced immune related adverse events, and most common were like grade 3, grade 4 were dyspnea, hyponatremia, and anorexia. No treatment related grade 5 adverse events or early deaths was seen. What is happening here? The real world, now these were the phase through. This is the first of its, the only study real world single center data available to us. This Ahan et al. They published their own retrospective data of around 155 patients. And they were matched with PDL1 testing and they were given nivolumab or pembrolizumab between 2014 to 19. What is? Okay. So the median follow-up here was 17 months for subjects with PS1 and PS2 and 4. Overall response rate was higher in PS1, 29% as compared to PS2 and below, 2.9%. Same was there with the durable clinical response, 71% in PS1 and 14% in PS2. So the hazard for OS among the patient with PS1 was 6.9. So here in the real world data, what we see is PS plays an important role in the response of immunotherapy. Overall, 61.9% experience AE of any grade, 38 had immune-related adverse events, and they were associated with PS1 OS on multivariate analysis. This is second is another one is the retrospective multi-center analysis of pembrolizumab. This was again an observation study of 153 patients with PS2. The median age again was 70 years, so geriatric population is represented here. And few of them they received neoadjuvant therapy. All the patients had PDL1 or a TPS above 50%. And the result was the median follow-up here was 18 months, 6 months PFR and median PFS and median OS was 27%, 2.4 and 3 months. This is subjecting to the what is happening here. This is the PS2 determined by comorbidities had a significant better outcomes. There is an issue here. Significant better outcome versus disease burden with 6 month progression-free rate of 49 versus 9%. So if there are no comorbidities, they had better response to the immunotherapy. This is something new that we had learned here. And the median PFS for people with no comorbidities was 5.6 months versus that with comorbidities was 1.8 months. And the median OS again was 11.8 versus 2.8. So it tells us that even with poor performance status in absence of comorbidities, that is the low PS due to the disease, they will have a better response rate. Looking at the safety data, there were 44 patients experienced immune-related effects. Grade 1 and 2 were common. Some few had a limbic encephalitis, and one was discontinued because the A-related toxicity of myocarditis. 2 deaths were pulmonary toxicity were reported in that study. Now, association of ECOG PS survival in patients with advanced lung cancer. This is a Segal and colleagues. They have reported retrospective single center data of 74 patients. Now, here also again they were given pembrolizumab as the first line therapy. So overall response rate and durable disease control rate in the entire cohort was 23.9 and 74.6. Overall response rate in ECOG PS 0 to 1 and ECOG PS 2 and beyond was 27.9 versus 17.9. Again, we see a better PS has a better response rate even in immunotherapy. The median progression-free survival and OS in the entire cohort was 4.8, 8.9 and 9.9 months. PS2 here we had taken into consideration from the beginning of the pembrolizumab monotherapy until progression of disease. This is the treatment related outcome of data of all the subjects. Median PFS of PS1 or 2 and beyond was 7.9 versus 2.3. So again, we can conclude here from the 2 trials real world data that better PS has a better response rate and better disease control rate. Median OS was also falling in the similar lines. It was 23 months with a PS 0 to 1 versus 4.1 months in PS 2 and beyond. Again, here the same thing has been depicted in the Kaplan-Meier graphs. Safety results again. 0 to 1 PS had 31% immune-related adverse events. This is the last of those studies where they published the results of real-world single center, the PS2 and beyond, treated with the first-line pembrolizumab therapy. Median PFS here was 1.6 and 2 months respectively. Talking about the immune-related adverse events, they are graded according to the CTCAE grading. For most of the grade 1 and grade 2, we have to withhold the drugs till they reverse and become less severe until grade 1, and then we have to restart them. Any grade 3 or grade 4, we have to permanently discontinue. This includes immune-related pneumonitis, immune-related colitis, immune-related nephritis, and immune-related endocrinopathies. Immune-related hepatitis is titrated as per the AST and ALT enzyme ratios. Anything which is 1.5 to 3 times of the upper normal limit, we have to withhold the immunotherapy until it comes down to the normal. If the AST or ALT is more than 5 times and the bilirubin is more than 3 times of the upper normal limit, we have to permanently discontinue the immunotherapy. Again, patients with liver metastasis who begin with moderate transamination elevation, and there is a 50% relative increase from the baseline in the first week of immunotherapy, we have to permanently discontinue the immunotherapy. And for immune-mediated skin disorders, Stevens-Johnson's and toxic epidermal necrolysis, grade 3 and grade 3, we have to wait it till it subsides, becomes grade 1, treated with steroids. For grade 4 and above, we have to permanently discontinue it. Again, if this is one practical thing, if steroid dosing cannot be reduced to less than 10 mg of prednisolone or equivalent for 12 weeks for the toxicity related treatment related to toxicity, again we have to permanently discontinue the immunotherapy. Pseudo progression, that is a tumor flare. Now it is defined as increase in the size of the primary tumor or appearance of any new lesions followed by a tumor regression. This pseudo progression is characterized, if we look at the biopsy picture of pseudo progression, there we see infiltration of various immune cells such as T and B lymphocytes. These immune-related cells, as immune-related cells are seen in the part of tumor, they need to be defined differently than the normal solid tumor RECIST criteria. Hence, there was a need for IR RECIST. How common is pseudo progression? It is, if we go back and look at the data, there was in the keynote 001, there was only less than 1% of the cases had pseudo progression in non-small cell lung cancer. Definition of RECIST 1.1 and immune related response criteria has been summarized here. So for the RECIST, we use criteria of 30% decrease as a partial response. In immune resist, that has been revised to more than 50%. For progressive disease, we describe as 20% increase in some diameter for solid tumors. For immune response, we describe it as 25% relative increase to the slides. And stable disease is same, no appearance of no new lesion. So, thank you for your patient listening. Any questions? I would be glad to answer any of those. This is not working.
Now, next speaker is Dr. Aditi Mittal, a consultant medical oncologist, SMS Medical College, Jaipur. She will be speaking on immunotherapy stage 4, non-driver mutated PD-L1 positive, interpretation of PD-1, MSI TBD in TMB in NSCLC selection for first line immunotherapy.
So good afternoon, one and all, respected seniors and my dear colleagues. So it's a very exhaustive topic. I hope I do justice it in 15 minutes. So I'm here to present a wild type metastatic NSCLC and what are options and what can we do for in first line immunotherapy. So first the how. What are the biomarkers available and what tells us for whose patients from which patients we to give immunotherapy and whom not to give. So there are 4 mainly antibodies for PDL1 testing and available on 2 IHC platform from DACO and Ventana. Now the sample specifications for PDL1 testing is we need normal formalin fixated tissue is required. Self block can also be used. So how to interpret PDL1? Any staining, any membrane staining of any intensity is taken as positive. The tumor cells are only counted. The macrophages are not counted. That is the most important thing. And the percentage of cells are. So there was one study which actually compared the 4 types of antibodies to PDL1, whether they are concordant or not. So yes, it was found that they were concordant and they were on linear regression. So in this slide, you can see there is membrane PDL1 staining of NSCLC. So this is PDL1 positive tumor. There is a glitch. Just a second. So second biomarker which we can use is the microsatellite instability, which is a DNA repair mechanism. We know that there are base mismatches, insertions, and deletions. And we know that, of course, mismatch repair machinery is there to take care of that. So when there is problem in this, we have MSI high. So how to test it? We have got 3 types that we can test it. We can do it by ISC, we can do it by PACR, and we can do it by NGS. So there was one study which actually told that how many patients with advanced and metastatic cancer have high MSI. So it was found that the NSCLC patients, almost 0.8% in their cohort, had the high MMR. Most it was common for CRC and gastroesophageal cancers. Now the third upcoming biomarker is tumor mutation burden. Tumor mutation burden is defined as the total number of somatic mutations in any exome. So in most of the studies, the high TMB was taken as greater than 10 mutations per megabase. So high TMB has been shown to be present in smokers specifically, and high TMB has been shown to actually predict the response to immune checkpoint inhibitors. So it's upcoming biomarkers and many trials are being done to show its ability. So there are various trials which have shown that the high TMB actually predicts the response to immune checkpoint inhibitors. So the quest for biomarker, of course, we don't have a perfect one till now. Tissue is always an issue. So judicious use of tissue is very important. There are 4 IHC antibodies available for PDL1. PDL1 positivity is read as membrane staining and in tumor cells, reported as 1% of total tumor cells. Use of NGS for molecular testing is very, very important and allows for identification of a wider range of actionable mutations using the least amount of tumor tissue. MSI high or deficient MMR is associated with higher mutation rate, and of course, the number of new antigens increases. Tumor mutation burden is a new promising biomarkers, and they will respond good to. So, of course, we all know that tissue. We first order IHC and then we end up exhausting the tissue. So, of course, we should take care of that, and we should advise for molecular markers initially only. So now we come to the first line immunotherapy in non-small cell lung cancer. So what are the treatment options? Before the advent of the immunotherapy, there were few options. There was chemotherapy, or we can add bevacizumab for advanced NSCLC. But now we have myriad of options of including immunotherapies, chemotherapy, and the doublet, the triplet, and the quadruplet. So we can. So firstly, we can divide the patients into 3 cohorts. The less than 1% PDL1, of course, we are talking about patients who do not have actionable mutation. That is very important. And then we go to divide them into three, and we have a monotherapy option, IO combination, IO chemo combinations. So there are several PD-1 and PD-L1 inhibitors that are available and are in trial and in the pipeline, which are supposed to come. So first we talk about the patients with no actionable mutations and who have PD-L1 greater than 50%. Yeah. So this was the first positive trial of immunotherapy in these patients. So before that also there was a trial which was done, but that trial was negative, which was done with nivolumab. From that trial, we learned that we need to segregate patients with high PD-L1. And then this trial was carried out using pembrolizumab, PD-1 inhibitor. And the patients were taken as PD-L1 greater than 50%. And we see the overall survival is 26.3% in the patients who were receiving only pembrolizumab versus the patient who were receiving chemotherapy, they were 13.4 months. The hazard ratio was 0.62. So this changed the paradigm of NSCLC, and then we started using pembrolizumab for these type of patients. Then there was again another study which used atezolizumab, IMpower 110. The study was almost similar. The patients were PD-L1 greater than 50%, and this also showed that there is a benefit in overall survival with a hazard ratio of 0.76, and we can see the curves are separate from each other. Then we have one more PD-1 antibody, that is semiplimab, Empower Lung 1. Again, it's a similar study. They use semiplimab, and their overall survival is still not reached for both the patients, but we can see the curves are quite away from each other, and we expect a good hazard ratio. Hazard ratio is 0.57 only. So now we talk about combination of IO. So combination of nivolumab and ipilimumab. In the first line NSCLC, the patients were given either, there were many arms of this study. So we'll just be comparing nivo-ipi versus chemotherapy, and then we see it was for nivo-ipi, it was 21.2 months overall survival versus 14 months for chemotherapy. So yes, it was also, FDA also approved nivo-ipi in the first line NSCLC setting. Can we add chemo? Yes, we can add chemo with the immunotherapy. And there was one Checkmate 9LA trial which used 2 cycles of histology-based chemotherapy with nivo-ipi. And it also showed there is an advantage in overall survival. So if you see, that is the gist of the trials that we have discussed. So there are 3 trials using monotherapy. Then there is Checkmate 227, which use nivolumab and ipilimumab. And then there is Checkmate and 9LA with nivo-ipi plus 2 cycles of chemotherapy. And we can all see that rather than PFS, the OS has a better advantage, as we know that immunotherapy produces more advantage in OS rather than PFS. Okay, I'll just hurry up. So there is then we come to IO with the chemotherapy in advanced non-squamous NSCLC. And Keynote 189 was used platinum-based chemotherapy for these patients, and there was, of course, the response rates increased. The response rate become up to the grade of 60%, and the overall survival also reached almost to a tune of 27.7 months. And this also becomes the new standard of care. Then we come to quadruplet. Yes. So quadruplet includes the carboplatin with bevacizumab and with atezolizumab. So when we compared both of the quadruplet and triplet arm, it was found the hazard ratio was 0.70, and there was almost doubling of overall survival, as we can see from the data. Then there was first line atezolizumab with plus chemotherapy, which did not use bevacizumab and used atezolizumab with carboplatin and nab-paclitaxel. And atezolizumab was given until progression. The results were not very impressive, but still the hazard ratio was less than 1. So chemo IO options, of course, the best results that we have is Keynote 189, pembrolizumab plus platinum-based chemotherapy. Then we have the triplet and the quadruplet, and then the atezolizumab and platinum-based chemotherapy. What for the squamous? For squamous patients presenting with squamous cell carcinoma, of course, we are in dearth of options. So yes, Pembrolizumab plus chemotherapy was used in Keynote 407 trial. Pembrolizumab plus chemotherapy was used, and those were given. And we have a very good data. The overall survival did not reach, it is still not reached, and there was 60% response rates in these patients. So now we come to the patients with the less PD-L1 expression. So of course, these only 30% of the patients have high PD-L1 expression. Rest of them will have less PD-L1 expression. So what are the options of treatment for these patients? So when single agent pembrolizumab were used, the median overall survival did not increase much. It was 16.7 months versus 12.1 months. And thus, it was given that we should add chemotherapy to the arm of immunotherapy. There was one analysis, first line chemo IO versus IO in advanced NSCLC with PD-L1 1 to 49%. And then here we see that chemo IO is better than the only IO monotherapy. So the options we already discussed, like in Keynote 189, we can use pembrolizumab with platinum-based chemotherapy, or in IM Power 130, we can use atezolizumab with the nab-paclitaxel and carboplatin. Or squamous cell carcinomas, we have Keynote 407 using pembrolizumab and chemotherapy. In Checkmate 227 trial, nivolumab and ipilimumab was used, and it also demonstrated good effect for this group of patients. So I'll just quickly go to the meta-analysis. It was done in 2019. It has 20 RCTs, including almost 12,000 patients. It tells the basic thing. All the immune checkpoint inhibitor therapies have better therapeutic effect across all efficacies and all safety endpoints. It decreased the risk of death by 23% in patients with non-squamous cell NSCLC and 21% in the squamous cell patients. This was the overall survival benefit forest plot. This was the PFS benefit forest plot. So take home message, no perfect biomarker still. We are still in a hunt of it. Immunotherapy alone or in combination with chemotherapy standard of care for wild type NSCLC. Observed OS effect is stronger than PFS effect. For PD-L1 high advanced NSCLC, single agent PD-1 or PD-L1 inhibitor can be the mainstay of treatment. Chemo-IO combination increases response, but survival similar to single agent PD-1 inhibitors. IO-IO combination have similar responses and survival to single agent. For PD-L1 negative or PD-L1 1 to 49%, IO-IO or IO chemo are better options. Although long-term survival is possible, it is only realized in a subset of patients. Thank you.
Nicely presented and excellent way of telling the treatment of non-small cell lung cancer. And any questions or the comments from the audience? Thank you, Aditi. Next speaker is Dr. Yashwant Kashyap. He is the Assistant Professor Medical Oncology, AIIMS Raipur. And he will speak on primary result of phase 3 randomized double-blind placebo-controlled study of atezolizumab plus carboplatin plus etoposide with or without tiraglobimab in patients with untreated extensive stage small cell lung cancer. Dr. Yashwant, please go ahead.
Thank you, sir. After seeing so many development in non-squamous small cell lung cancer, now I will be discussing about what was tried to do better for our patients of small cell lung cancer. So for that, this was a phase 3 randomized double-blind trial in which atezo with chemotherapy was compared with a newer drug, which is a new development, which is a part of a newer precision oncology development. This drug was developed, tiragolumab. So I will show in further slides that what for many things were done for this group. So we have seen in IMPOWER 133 trial that aiding Atizo has prolonged the survival in patient, affordable patient for on which we have added in chemotherapy backbone atezolizumab also. So now our idea was to do something better. This drug has done badly, and skyscraper trial one was negative trial, which was done in non-squamous NSCLC. So this drug is now tried in small cell lung cancer, because unmet need is more in small cell lung cancer, because only Atizo has shown to benefit the survival for our patients. So it is a new molecule known as TIGIT, which is a kind of immune check point inhibitor, which act as synergetic to Atizo. So this skyscraper 02 trial, in this trial, one arm was standard Atizo with etoposide with platinum chemo, compared to chemo with Atizo with tiragolumab. So there were total it was given in first line setting. So total 490 patients. Out of 490, primary endpoint was overall survival. So in this, both the arm were comparatively balanced. Then on both the arms, PFS was similar. So you can see that adding this drug has not benefited our this group of patients. And in full analysis also, this drug also has not benefited our patients. In further, patient with brain mets also have not benefited with this drug. Duration of response was also not much different in both the arms. Though this drug was comparable, there was no added safety issues. And grade 3 and 2 toxicity were almost comparable in both the arms. So to conclude, addition of tiragolumab to Atizo and chemo did not provide further benefit, and it was a negative trial for extensive stage small cell lung cancer patients. And there was no difference in PFS or OS in both the arms. And though this drug was well tolerated, but this drug has not shown benefit. And both the arms, there was a not much benefit. But I think this trial just shows that more unmet need is there, and similarly, slowly, more TIGIT or similar molecule will be added, which will be prolonging survival of patients.
Comments from the house. Any questions? Thank you.
Thank you, sir.
So the next speaker is Dr. Ankur Punya. And Dr. Ankur Punya is Assistant Professor, Department of Medical Oncology in Sri Ram Cancer Center, Mahatma Gandhi Medical College, Jaipur. And the topic is study of pembrolizumab versus placebo for completely resected early stage non-small cell lung cancer.
Good afternoon. So my talk is regarding the Pearls Keynote 91 trial, which is the pembrolizumab versus placebo for early stage NSCLC who are completely resected. This is a subgroup analysis which was shown recently in the ASCO 2022. So basically, outside 50% of patients come in early stage, but I will say it's very less in our country. And for any more stage 1B, that's more than 4 centimeter to stage 3A, adjuvant chemotherapy is recommended. Atezolizumab has shown a good result in DFS benefit in this particular subgroup for the patients who are PD-L1 positive. So basically, this trial design was the patient who were stage 1B to stage 3A who were completely resected and who had PD-L1 testing done. Patient received the adjuvant chemotherapy, which was as prescribed, and then they were randomized between 1 year of pembrolizumab versus placebo. The primary endpoint was DFS in overall population and in the PD-L1 more than 50%. So around 590 patients were allocated in both the arms, and more patients discontinued the treatment in the pembrolizumab arm because of the adverse events, 130 compared to just 30 patients in the placebo arm. Baseline characteristics were pretty well balanced in overall group as well as in the PD-L1 TPS more than 50% subgroup. They were equally balanced. EGFR and ALK mutation number was low, but in around 60% of the patients, it was not even tested. So we cannot really say anything about that. So this, as was previously published also, the DFS shown around a 10% benefit at 18 months. It was 53.6 versus 42 months. And in the population of TPS more than 50%, because we have still not reached the number of events, so its data is still immature, but the results are very good. Same I would say about the OS, because data is still immature at 18 months, so we need a little bit longer follow-up to say whether the DFS benefits converts to an OS benefit. Adverse events were more in the pembrolizumab arm. Grade 3-4 events were around 35% compared to 26%. And the treatment discontinuation rate was 20% in the pembrolizumab arm because of these adverse events. Overall, all-cause adverse events, they were pretty much similar, except the hypothyroidism, which is more common because it's an immune-related side effect with pembrolizumab. As you can see that thyroid-related disorders, pneumonitis was more common, as is there with any immunotherapy. So regarding this particular subgroup analysis, it was based on what type of surgery was done, what type of treatment the patient received. So lobectomy was the most common surgery in around 80% of the patients, and they had all kind of node negative 1 or 2 stage, tumor size less than 4, more than 4. Almost 85% of the patients received some sort of adjuvant therapy. And in adjuvant therapy, different kind of regimes were used, but most common was cisplatin plus vinorelbine. And most of the patients received cisplatin in the adjuvant setting, and around 30% received carboplatin. So if we see these different subgroups, in almost all the subgroups, we can see it goes slightly in the favor of pembrolizumab arm, because the numbers are not that much great. So we cannot individually identify any particular subgroup and say that particularly this had this benefit, like the patient who didn't receive any adjuvant chemotherapy. It goes slightly favor in the placebo, but the number was very low. So it's not possible to say. Similarly, for the patient who received 1 to 2 cycles were very low. But most of the subgroup we can see are going in the favor of pembrolizumab. So to conclude, pembrolizumab generally improved DFS compared with placebo, regardless of the type of surgery, how many number of lymph nodes were involved, tumor size or type, and what kind of adjuvant chemotherapy was received. Results of this subgroup analysis should be interpreted with caution because of the lack of power of individual groups. So together with the overall efficacy and safety findings, this support that author concluded that pembrolizumab should be considered as an adjuvant therapy for stage 1B to 3A post chemotherapy. Thank you.
Any questions or the comments from the house? Thank you, Ankur. And we'll move to the next session, that is management of uncommon mutations, panel discussion. I'll invite Dr. Naresh Somani as a moderator. Dr. Naresh is there? Oh, good. Good to see you.
Good afternoon, everyone. Respected honorable chairpersons and our good friend, mentor, our guide, Dr. Bhatti Sahab, welcome you in Jaipur. I would like to invite our esteemed panelist, Dr. Deepak Shukla, our friend, medical oncologist from Manipal Hospital, a popular doctor, a doctor of second opinion, a reliable doctor for the city of the Jaipur. Our young budding colleague, Dr. Mukesh Rulania from SMS Medical College, colleague of organizing secretary, Dr. Jasuja, Dr. Tarachand Gupta, medical oncologist from Bhagwan Mahavir Cancer Hospital. Dr. Tarachand is here. He's on the way. Should I wait for him or I should continue? Okay. And my friend, my colleague, Dr. B.S. Ankit Nehra from HCG Cancer Center, Jaipur. And I think Dr. Mohit Saxena is not with us. And Mohit Saxena is there. I'm sorry. Dr. Mukul is not here. So Dr. Mohit Saxena, medical oncologist from Narayana Super Specialty Hospital, Gurugram. And Tarachand will be joining us. And we have with us in the audience, Dr. Bhati and Dr. Organizing Secretary, Dr. Jasuja, to make the comments and to make it more lively. So I have been asked to make it the discussion part on the less common, uncommon, or the rare mutations in the lung cancer. So as we all know that ALK and ROS1, they are also sort of by definition the rare mutations. The frequency of the ALK has been reported something like varying from the 1 to 8% also, including the patients of the squamous cell cancer also, depending on that which methodology like IHC or PCR or FACE or ultimately NGS we do use. But because the treatment has been refined so much, has been talked so much, so these sort of the common rare mutations I won't be covering. I will be talking about, we will be discussing more about those rare mutations for which therapy are now being discovered, now being popularized, and now being available so that we can have the better understanding of these rare mutations. Panelists are with us. So biomarker testing demands and target therapy options for the lung cancer continue to expand. And this applies right from the beginning, the diagnosis of the lung cancer, then continuum process at the time of the subsequent relapse also, with the change of the histopathology, with the change of the mutation, like the dynamic markers upcoming, including the PDL1 negativity to the positivity. And various these newer markers, we all are now being available. And thanks to the various pharma partners that the new drugs are being developed for them, and they are effective in subsequent line, and they are effective as well in the first line also. And survival of patients with the drivers in the lung cancer mutation, if we look at them in totality, that is the most important, that is it really making the impact? Yes, the survival has increased double, triple compared to the conventional doublet chemotherapy, platinum-based chemotherapy. So there's the real world data that yes, if we use the TKI, probably the outcome remains the better. So obviously, survival of patient drivers in lung cancer mutation consortium has shown the improvement, and that goes to the tune of the 3.5 years as a median survival across the various mutation. But still, there is a large gap in overall number of the patients of the lung cancer which are being tested actually. So from here, let's start with this background, the discussion. So let's start with our Dr. Shukla, that what is the gap he feels at his practice, that ultimately how many patients of the non-squamous, non-small cell lung cancer, advanced cancer stage 3C or 4 are not able to go for a proper biomarker testing or comprehensive genomic profile. Dr. Shukla.
Thank you, sir. Sir, so the main reason possibly is the means the availability of the tissue. Cost, I won't say, because now we have numerous company-sponsored panels which are available at low cost. So most of the time, the tissue is an issue, and also means I personally prefer using NGS. But the issue in ordering an NGS and its report coming, that means the time taken is 3 weeks. And for a newly diagnosed stage 4 lung cancer patient, this waits sometime in spite of the best counseling. I have seen in practice patients do get lost to follow-up, or I think the waiting time as well as the tumor tissue, these are the two main issues.
So Dr. Mohit Saxena, you practice in Delhi or Gurugram. Do you feel that the 3 weeks period is still the way at your place, or you get the report in something like 7 to 10 days or maybe less than that?
It still be the NGS should be preferred because it covers the rare mutation. It might take around 14 days or so with the available platforms. But I don't want to prefer the 3 mutation or 2 mutation testing at this point of time because we can miss many things.
So we welcome Dr. Tarachand also, he has joined us. So Dr. Mukesh, you are working in a big government setup where almost everything is free to the patients. So what difficulty or challenges you face when ordering these sort of the investigations in the real situation? What is the gap in the biomarker testing at your place?
So currently, sir, there is no pre-test for lung patient in our center. Likely no EGFR, L cross at present, not pre. So our patient does not undergo, maximum number of patients does not undergo testing due to financial issue. We undergo some patients for testing like by Pfizer coupon, and some patient by other companies sponsored. But maximum number of our patients of non-squamous NSCLC does not undergo biomarker testing in our center at present.
So Dr. Tarachand, we were discussing the gaps in the biomarker testing, actually what number of the patients are still not able to go. And at the BMCHRC, as far as I am updated, few of these markers are being done in-house based on the various technology of the IHC and the PCR. So what percentage of the patients, the indicated patients are not able to go for the biomarker testing because of the various reasons? What's the percentage? 10%, 50%, what's the percentage?
Sir, nowadays, as the scenario of Rajasthan has been changed after the Chiranjeevi and RGHS. So, and other patient, there are 2-3 types of the patients are in Rajasthan now, Chiranjeevi, Bhamasha, RGHS or other panel. And one chunk is the cash patient. So the patients who are in Chiranjeevi, Bhamasha taking the treatment are around 20%. But they are also undergoing for the free coupon, sponsored coupons by EGFR, Alcross. Rest the patients are undergoing for the NGS because those cash patients are sufficiently affordable who are not enrolled in the Chiranjeevi, so they are going for the NGS.
So next 2 slides, of the famous Dr. Tony Mock. He discussed the 2 ways to do the biomarker testing. In direct pathway, that is you diagnose the lung cancer, you do the common or easily available everywhere, little bit doable in a cost-effective manner like EGFR, ELK. If the negative, start treating the patient and then go for the comprehensive panel, and then you may or may not detect the uncommon mutation. The advantage of this is that you get the faster results. It's a sort of the cost-effective way, but disadvantages are the tissue becomes an issue, tissue consumption is there, and patient may likely proceed with the chemo, sometimes over enthusiasm the doctor with immunotherapy. First line, sometimes the patients are more than PD-L1 50% positive, EGFR ELK is negative, temptation for the immunotherapy, waiting for the comprehensive genomic profile, and then target therapy is sometimes reserved or being missed in the subsequent line. The other approach is obviously the direct pathway, that is the comprehensive genomic profile, waiting for the result and then starting the treatment. Dr. Jasuja has a comment or the question, please. And all your comments will go to the panelists, not to the me.
One comment and one question. Comment is the extending my words of our my colleague and very knowledgeable colleague, Dr. Mukesh Ulania, that we are not seeing the patient without this tumor marker and everything, because we are lucky enough to cater those patients who are become poor after the outside of hospital, and they are coming to us with all kind of report. We are lucky enough to do this. we are not going to exercise in this patient, and we are just taking that considered with all biomarkers.
So that's the comment. And what's the question?
And the question is that what is your take on in a liquid biopsy if tissue is an issue?
So let's start this question because Dr. Ankit comes from a setup where probably what Dr. Jasuja is telling, that the patients are being treated in a different way. They have lots of the report, and then they are sort of the so-called being exhausted. So Dr. Ankit, if I ask you this question, how you will defend yourself and me on my behalf, you would like to answer this?
So in the number of patients, what I see, almost most of the patients are, even I see Chiranjeevi Bhamasha only. So the scenario is same with me also, sir. So only thing that the Pfizer coupon is almost now is off, and with the other coupons we can do NGS at the cost of like 5 to 8K. So that we can do, and that is with the turnaround time of 10 to 15 days only. So that is the way to go. And even after that, whatever the mutation comes, a patient remains in Chiranjeevi only.
So I was surprised to understand, since last few days I was trying to understand actually the NGS. So if there is a one patient and one machine and one molecular oncologist, and the patient can afford it, the comprehensive genomic profile report can be given in one day. Can you believe it? If I am the patient, I can pay the cost. And if there is a molecular oncologist, the report, comprehensive genomic profile report, can be generated in the one working day. It is lesser than the IHC methodology. The turnaround time is higher because it's a cost establishment and they need the certain samples to dilute the cost. So we all believe and we are optimistic that with the more number of patients which you will be doing, probably the turnaround time, not only the cost, the turnaround time will also come. So we were discussing the two pathway, indirect and direct pathway. So can you segregate the patients clinically? Which patient you would like to go with the direct pathway, like doing the comprehensive panel upfront, waiting for the report, whatever the time it takes, maybe approximately 2 weeks, versus indirect pathway where you first do the in-house or nearby the EGFR, ELK or ROS1, and then you move for the comprehensive panel. Dr. Deepak. Doctor, let's say we start with the Dr. Taracham.
Sir, as per the new assistance from the certain labs or other companies, that now the TAT is around 5 to 7 days for the NGS, most probably, not much. So I think the time taken is not a big issue in this at present. But and another option, direct and indirect pathway. Usually, if the patients are not affordable and we are going the free coupon, then we are doing only the EGFR Alcross. Otherwise, we are doing NGS only.
So Dr. Tarachand has come late, so we would like to punish him asking the most difficult questions. And I was surprised when I was discussing outside with one of the company colleagues that they were telling me that in the Gulf, they have adopted a different model. All these comprehensive panels are collectively being paid by the company, and whichever the molecules come positive, the cost goes to that company. If it is the BRF, it goes to the Novartis. If it is for capmatinib, it will go to the Lilly. If it is, let's say, ELK, then it will be divided between the Pfizer versus the Ross people, whoever wants to claim the first line. So sort of that model. So there's the food for thought for the company people who are sitting with us here, that they should also do that sort of the networking among themselves, especially for the rare sort of the mutant. So it doesn't become ultimately the coupon of the Pfizer or Novartis or somebody else. It should become a coupon, sort of the national coupon, that yes, the cost will be paid by that consortium. So that's the point of the discussion. Dr. Jasuja, please.
Sir, my point is that in a Western world, all are insured patient, and they don't pay out of their pockets. And that's why these companies are giving free of coupon and everything. Here in India, maximum people have not much facilities like insurance facility, health, apart from basic facility like Chiranjeevi and everything, where these drugs are not available. So what is the fun of to do in this all mutation, and why they pay here in the patient where the patient have to afford this costly
So the
treatment?
answer for that is that in spite of this system, only 80% of the patients, as per their words, are able to go. That means still there is a gap in the advanced rich countries where it is being paid by insurance or by someone else. The gap always remains because of the various regions. Maybe tissue is not there, not able to go for the liquid biopsy also because that may not be covered under the insurance. So, or availability, whatever the way is. So, so any comment from the panelists regarding this question? How do you test sequential, or you would like to go for the comprehensive, minimum comprehensive panel for which all the drugs are available? Dr. Rulania.
Sir, if there is a cost is no issue, then I initially go for comprehensive tumor profiling.
So, Dr. Mohit, what are the clinical scenario where you would prefer going for the sequential? Which patient you will go for sequential, thinking that this patient should not wait for a long time?
Probably the disease burden is high and we have a lot of tissue like the node biopsy. Then we can think about that even after doing the EGFR and ROS, we'll have sufficient tissue for the NGS.
Dr. Aditi, you have any comment to make?
Regarding this, sir? This.
Regarding this pathway, how to choose the patient, sequential versus NGS. Suppose the patient is in the clinical crisis. Would you like to segregate that patient to go for the chemotherapy, not waiting for anything? Or a quick EGFR and ALK in-house or in surrounding the somewhere?
So of course, if the patient is sick and like the lungs are not good, then of course I would like to have a quick EGFR ALK and I would like to start the therapy. If it is negative, of course, the chemotherapy, and if it is positive, of course, the targeted therapy, and not wait for the NGS.
And I believe that you all will agree with me that it is not always the cost. We see the reports of IHC, often a patient clear-cut morphological diagnosis of the adenocarcinoma, and all exhaustive markers IHC are done, probably I will say useless, and tissue is being exhausted. So that is one of the major reasons that we are not happy with the tissue. So these are the various reasons which are the limitations for going for the test. So Dr. Deepak, what's your experience? How you meet out these problems or remove these barriers?
So just on the previous question, so possibly means the patient with leptomeningeal metastasis or EGFR mutation, a patient leptomeningeal mets even at the time of diagnosis means we have seen patients. Possibly in that subset of patients, I have personally had some success of sending NGS and ordering a droplet digital PCR report is available in 48 hours.
That's true. That's true. So a patient in the clinical crisis, maybe that you treat the patient parallel and try to do the limited panel. And Dr. Ankit, you would like to make any comment, your experience that what's the region out of these, or all these all are the applicable in the different percentage?
Yes, sir. So if the patient is symptomatic and if we should not wait, we can't wait for NGS, definitely EGFR. Otherwise, I would like to go for NGS because there is a limitation of the tissue. And if there is a histological diagnosis of adenocarcinoma is there, I won't waste my tissue for even the IHC and directly go for NGS.
So now very burning questions. And this is not in favor or against any lab individually. So how confident you are of your partner lab finding these uncommon mutations? We are here to talk about the rare mutations, uncommon mutations. So what's your gut feeling says, Dr. Tarachan? Tarachan, please come this side. It is finding it difficult to move.
Sir, confident, I cannot comment because I am not compared with one-to-one lab. Regarding the uncommon mutations, till now I have come across only the three patients only, two MET mutation, skip mutations, and one is ROS mutation. I have not seen any other patient with the rare mutations only.
So Dr. Gaurav, those patients who are non-smoker, female patient, adenocarcinoma, and you get some sort of the report and that turns out to be the negative and you start treating the patient. So do you parallel to that try to attempt the liquid biopsy as the companion diagnostic or complementary diagnostic in spite of having the tissue biopsy as the negative for the comprehensive panel? Dr. Saxena.
If the tissue is available, then we would like
No,
to
tissue
go
you have done, that's a negative. The clinical profile says it's a female patient, adenocarcinoma, non-smoker. Would you do the liquid biopsy in this patient where the adequate tissue biopsy is negative for a comprehensive profile, including all 7-8 markers which we do in the routine clinical practice?
You want to say that if tissue is available, it is negative for common mutation, then would I like to complement with the liquid biopsy? I think no.
So anybody do advocate this to patients or do practice this? Try to explain to the patient.
Sometimes, sir, again, the problem with NGS, the reports come after means let's say 2 weeks. So at the just 3-4 days means prior, they will inform there is lack of tissue. So means before sending the test to then could not be done because of genetic DNA extraction. So possibly while sending, I discussed with the pathologist that is the tumor sufficient to do an NGS test. I think this should be taken if they say that tumor is possibly not inadequate. In that case, we can discuss with a well-informed, educated patient that possibly if we wait for 7 to 10 days and then suddenly they say that NGS cannot be done, that the liquid biopsy in such cases.
Dr. Jasuja.
So, sir, in my point, concern is about the liquid biopsy if you do in a patient of negative on tissue. And my important question is how many patients have inheritance of this tumor in their germline mutation? That's why sometimes it's rare, no doubt. And somatic, what you found on tissue is the somatic mutation, and 99.9% are on somatic mutation. If they are inactive, there is no need of liquid biopsy. But yes, if you are strong suspicion of inheritance, then germline mutation can be only detected by liquid biopsy. So there is a window of opportunity, what you are suggesting, if we can go for that.
That's very, very important to understand about the liquid biopsy. Now, another point is by the time you get the report, that's a common scenario. Patient who are initially in the clinical crisis receive maybe 1 or 2 cycles of the chemotherapy, and they are probably responding to the treatment also. So what you do once you get the report, like let's say like a rare mutation, BRAF or MET or other things where drugs are available in form of the TKI. So what you do? We all try to change the partner treatment as far as the EGFR or maybe ALK or maybe ROS1 is concerned. But when the rare mutations are being reported, patient has received 1 or 2 cycles of the chemotherapy, what you do? Dr. Ankit.
So, sir, if the mutation is like, say, RAS is there, so sotorasib is approved in second-line therapy, I can continue the chemotherapy, and if the patient is affordable, I can add IO. If there is a agent like BRAF, which is first line is approved, or for MET, and there is a therapy. For RET, we can add a immunotherapy drug because still we don't have access to self-percating.
So Dr. Deepak, PDL1 is being reported very high, something like 60-70%. Common mutations has been excluded. So are there any rare mutations, specific rare mutations where you will have the temptation to continue the chemo plus IU?
Means in BRAF mutation and possibly KRAS mutation, there is data. We can continue with the immune checkpoint inhibitor with chemotherapy. But again, one must restrain itself from doing this because particularly the most common mutation that we see in clinical practice is EGFR mutation. So if a patient is on IO and then he went on to receive, there are increased toxicity is reported when a patient received OC after IO.
So that's the important slide I would be discussing here and has been reported that you treat the patient with chemo plus minus IO and someone has done some more comprehensive panel, liquid something, and tomorrow it is being reported as the EGFR positive exon 19. Please now do not have the temptation to give the osimertinib. And if you want to give osimertinib, a washout period of let's say 28 days is required before you challenge the patient with the osimertinib. Otherwise, undue toxicities will be there.
Fact,
Now,
sir,
this,
they have made means the duration should be, I think, more than 3 months. Means at least 3 months washout period should be given. Even means later than up to a year, the side effect there. But in initial 3 months, there are more side.
So this slide talks about the rare mutation and the expected response rate of the immunotherapy plus minus chemotherapy. And there are the 4 scenarios where like efficacy, toxicity, if you look at, and then probably the consensus feeling is that probably there is no role for the IO in any sort of the driver mutation positive upfront.
I think KRAS is the exception.
Sorry?
In the KRAS mutated patient upfront, we can use ICI plus, and there is very good data.
BRAF has shown something like 20% or more positivity, but probably that also did not say that you give the upfront immunotherapy. And in interest of the time, we would like to move a little faster. And so that's the important slide for discussion. I would like to say EGFR. So we have the common EGFR, we have the rare EGFR also. Something even in the EGFR exon 19 mutation, sensitizing mutation, non-sensitizing or sort of the resistant mutations are there. And then we have the exon 20 insertion mutation. We now have the interest for our patients also detecting these rare mutations because we try to treat them differently, either with the osimertinib or afatinib, or in the exon 20 insertion mutation, at least in the second line, Now the drugs like amivantamab are going to become soon. And believe me that the clinical trials are also now being established in Indian scenario. So do not hesitating talking to your patient for the rare mutation. Dr. Sukla, do you have any experience of seeing in the comprehensive panel these sort of the rare mutations like G791K or S768 at the time of the progression or so on?
Yes, sir. Means one of the patients presented with leptomeningeal mets. She had a rare mutation. I think it was in the exon 18. One amongst, and possibly we have data for afatinib with this type 1 mutation.
Dr. Mukesh, a quick question from you. EGFR exon 20 insertion mutation, what do you do as on today?
Sir, because of non-availability of exon 20 TKI like mobocertinib and wantanumab, we consider chemotherapy, or sometimes we consider osimertinib.
So would you consider the bevacizumab also as a partner in the chemotherapy?
Yes, yes.
So we will be moving MET exon 14 mutation, rare mutation. Probably I would not like to discuss. We have discussed the capmatinib and the other approach for the MET exon 14 mutation. Treatment is now available for this. We need to diagnose it more and more. A lot many other drugs are also being reported coming in this particularly. Same is the RET receptor tyrosine kinase and the fusion in NSC also. They all are to the tune of the 1 to 2%. And they all are again good or bad. They are all are the mutually exclusive to each other. So that's the way for the other drugs. And lot many other drugs are coming. NTRK success story, rare, very rare mutation. I will say the true rare mutation less than 1%. But yes, drugs are available. We are available out of the various trials. Anybody has the experience of the NTRK inhibitor drug, lorlatinib or the entrectinib? No. So finding uncommon mutation at the time of the progression, I think that is little bit more common finding. And we have the patient experience of treating for the BRAF inhibitor for that. A patient of the T790M treated with the chemotherapy for long time, osimertinib also. And then even ABCP was given, responded well. And the fourth time we diagnosed him with the BRAF and responded well. But then patient landed in the renal toxicity. And we removed the one partner drug and continued with the dabrafenib only. So anybody had the experience based on the NGS that at the time of the progression, other than change in the histopathology, you find the newer mutation?
So we found HER2 new mutation in one patient, but didn't respond to TDM1. And we progressed in within 3 months of time. That's previously exposed to chemotherapy, and I think ICI as well.
So rare mutation like HER, BRAF, now the TDM1 also having some values in this particular scenario, and newer drugs are also coming. Destiny trial talks about this. I won't be going much in the detail in the interest of the trial. And now another interesting thing is that DXD molecule, deruxtecan, and TROP2 also being reported in a comprehensive panel. Positivity is there. Sometimes we do not pay the attention. Dr. Tarachand, do you anytime have the experience this sacituzumab govitecan out of the breast cancer, other than the breast cancer, in any other solid tumor where the comprehensive panel reported the TROP2 positive, including the lung cancer?
No, sir.
Anybody had the experience? So these are the molecules being approved. Sacituzumab, yes, we all know about the TNBC and the sacituzumab, but yes, for the TROP2 positive patient, EVOKE-1 and EVOKE-2 trials are there, which talks about give the response rate. And propion is the another trial where these sort of the molecules are being studied. So now let's come again. Where might the novel HER2, 3, TROP2 targeted therapy, antibody drug conjugates fit in the treatment? When you get the report first time, at the time of the subsequent progression, or in second line and beyond, when you try to counsel your patient to go somewhere outside to get this sort of the treatment. Dr. Deepak, you must be getting this sort of the patient. You are one of the most popular doctors.
Yes, thank you, sir. Thank you for the kind words. But I am not, most of, already discussed most of the rare mutation. In the first line, the recommendation for platinum-based doublet. And subsequently in the second line, means we can counsel, but I think clinical trials, as you rightly mentioned, is the way forward.
So we should not forget that many of these things out of the compassionate basis or outside or inside the clinical trials are now the realities in India. And in the interest of the trial, I will say that it's in the interest of the patient that we try to find out more and more rare mutations, including the RAS mutation, KRAS mutation in the lung cancer, which is not so uncommon. And I urge all the partners, pharma partners and the lab partners, that they also try to give us these sort of the reports, including the KRAS for which now the molecules are available. If there is any burning question from the house, we will be asking this to our panelists. Otherwise, thanks, and thanks to the organizers to give us this wonderful opportunity. Thank you, panelists.
Thank you. So,
Now, I would like to invite Dr. Deepak Shukla, sir. He is a consultant medical oncologist, Manipal Hospital, Jaipur.
Good evening. At the onset, I'll like to thank Sandeep sir for giving me this opportunity, and also Astra. This is a sponsored session by Astra. The topic goes the turning the tides for stage 3 non-small cell lung cancer towards the curative intent treatment. Based on the Globocan 20 data, the lung cancer as such stand second most common cancer in males. And we all know it is a lethal cancer, with the lung cancer incidence in terms of new cases is 72,000, and there are deaths close to 66,000, which in percentage wise close to 91%. So it is a lethal cancer, we all know. The reason why the disease is particularly lethal in India is because majority of our patients present in either a loco-regionally advanced state or in a stage where it is already metastasized. The present talk is for the 1/3 of the patients where patients present in the locally advanced stage. So the management of locally advanced stage 3 unresectable non-small cell lung cancer is a multidisciplinary effort to define the resectability and a treatment path. The team includes a pathologist, radiation oncologist, medical oncologist, pulmonologist, and an oncosurgeon or thoracic surgeon. And most of these patients require an FDG PET-CT and an MRI brain with contrast for a basic staging, and subsequently based on the this workup, pathological mediastinal lymph node staging and subsequently pulmonary function testing and bronchoscopy can be done. And once the diagnosis of locally advanced unresectable non-small cell lung cancer stage 3 is made, the preferred treatment is concurrent chemoradiation, which is preferred over the other approach, that is the sequential chemoradiation. So the ESMO guidelines clearly state that for patients with enlarged discrete N2 lymph node or an extensive mediastinal N2 infiltration or an N3 lymphadenopathy, a clear non-surgical multimodality treatment with chemoradiotherapy is the way forward. For patients in selected N2 group, a surgical multidisciplinary team effort may be needed to define whether a patient can receive neoadjuvant chemotherapy and can become a candidate for subsequent surgery and subsequent adjuvant treatment. So this is the paper where it highlights that the outcome of treating patients with stage 3 non-small cell lung cancer with curative intent radiotherapy and concurrent carbopacly. And this is a 2016 paper for stage 3 non-small cell lung cancer. If we look into this data and look at the median PFS with the various chemotherapy regimes that has been used, the PFS has been close to 9 to 11 months, with a median overall survival close to 2 years. The results with the sequential regime has been compared to concurrent median PFS close to 9 months, the median over into 13 months. And the efforts to consolidate subsequent radical chemo radiotherapy have been not very successful, and none of them have made it into the standard of care treatment. So for this reason, prior to the IO adjuvant era, in the stage 3 setting, this curative intent chemoradiotherapy used to give a 5-year oral survival close to 15 to 25%. And the immuno-oncology drug, though we know, we are aware of the data, there is a clear biological rationale as to why it may work. The induction of tumor antigen release and the tumor cell upregulate the PD-L1 expression in over to hide from the T cells. This PD-L1 overexpression leads to T cell inhibition, and durvalumab is a PD-L1 inhibitor, so it, and in turn, this reversal of immune suppression leads to systemic anti-tumor response with durvalumab. So the Pacific was the study. This was a phase 3 randomized double-blind placebo-controlled multi-center international study in patients with stage 3 locally advanced unresectable non-small cell lung cancer who have received definitive platinum-based concurrent chemoradiotherapy, and patients were then randomized, those who have not progressed, to durvalumab 10 milligram per kg every 2 weekly for 12 months versus placebo. And the co-primary endpoints were PFS and OS, while the key secondary endpoints were overall response rate, duration of response, safety and tolerability, and patient-reported outcomes. If we look into the patient's baseline characteristic, the median age was 64 months. There were few patients in the this study that were EGFR positive, close to 6%. Majority of the disease stage was equally distributed between the stage 3A and 3B. And almost 25% patients have received an induction chemotherapy prior to definitive chemoradiation in this trial. And the recent update at 5 years showed that at the 5-year time point, the updated median overall survival with durvalumab is 48 months, nearly 1.5 years longer as compared to placebo there, which was 29.1 months, with a significant hazard ratio of 0.72. So at 5 years, nearly 43% were alive in the experimental arm of durvalumab as compared to 33.4% in the standard of care arm. And this is the first and only approved IO to demonstrate 43% overall survival at 5 years. And what is equally encouraging for us is that the updated PFS at that 5-year mark showed that nearly 33% of the patients were progression-free at 5 years in the durvalumab arm as compared to 19% in the standard of care arm. The median PFS was 17 months in durvalumab arm as compared to 6 months in the placebo arm, with a significant hazard ratio of 0.55. And again, this is the first IO to show this promising results. So, and what is equally good to see, the in terms of overall survival hazard ratio, the hazard ratios had hold up from the initial 2-year reporting to the present reporting, where the hazard ratio is still 0.72 in favor of durvalumab. And the overall benefit seen with durvalumab was seen across the various pre-specified subgroups. Also, the PFS was improved in all of the subgroups. And if we look into the patterns of disease progression, the decreased rate of progression was seen with durvalumab. It was 45.4% with durvalumab as compared to 64.6% in placebo. The majority of the progressions in durvalumab were intrathoracic, close to 80.6%. If we look into the time to intrathoracic progression only or death with the use of durvalumab, the median time was with durvalumab was close to 25 months, while in the placebo it was 9.2 months. The first subsequent therapy after discontinuation in the ITD population was that approximately in the placebo arm, 54% received subsequent treatment, while 41% received subsequent treatment in the placebo in the durvalumab arm. Immunotherapy was used in 14% of the patients subsequently, while it was only 4.2% subsequently received after durvalumab subsequent immunotherapy, and the most commonly used agents were platinum-based doublet at the time of progression. So looking into the safety data, so the treatment effect that leads to the discontinuation of the trial drug was seen when close to 15.4% in the durvalumab arm. In the placebo, it was 10%. Any grade pneumonitis, radiation pneumonitis, in terms of grade 3, 4 was 3.6%, and in placebo arm, it was 3%. So what we can see is it was reasonably well tolerated in the adjuvant setting. And this data from Pacific is further supported from the another study from the real world, that is the Pacific R. This was a international observational study of close to 1400 patients in full analysis set from 290 active sites in 11 participating countries, and the primary investigator assessed PFS and OS were the endpoints. The patient baseline characteristics showed that majority of the patients were less than 75 years of age. 14.3% of these patients received sequential chemotherapy. What is encouraging that the PFS in the Pacific R was almost similar, in fact, even better. It was 21.7 months in the Pacific R arm as Pacific R trial as compared to Pacific trial where it was 17 months. And the patients were enrolled close to 2 months in at a median close to 2 months with durvalumab in this real world data. Again, there were no new adverse events seen. All adverse events were comparable to what is seen in the Pacific trial. The pneumonitis, a majority of the events were moderate, and the median time of onset was close to 2.5 months. Corticosteroid administration was required in close to 71% of these patients. So again, just to highlight, the first and only approved immunotherapy, durvalumab, prolongs PFS by close to 11.2 months. Also, it reduces, it leads to 32% reduction in overall risk of death with a median overall survival of 47.5 months as compared to 29 months in the placebo. The discontinuation rates overall was low, close to 15%, and 6.3% was pneumonitis was the reason in 6.3% of the cases for discontinuation. The most common adverse events were cough, upper respiratory tract infection, and rash. So the key takeaway, as already mentioned, durvalumab in the adjuvant setting gives a good median overall survival as compared to observation. It also prolongs the progression-free survival, and the 5-year overall survival is 42.9% in patients randomized to durvalumab arm as compared to 33.4% in the placebo arm. And what is particularly important and what justifies the topic in hand, that possibly a third of these patients are alive and free of disease progression at the 5-year time point, and possibly in the future reading of this trial will show that possibly we are shifting the tide towards curative intent treatment. And also it's important to note that the durvalumab also leads to incidence of new lesion, including new brain mets, as compared to patients receiving placebo. Thank you.
Thank you, sir. Thank you, sir, for the wonderful talk. And next, I would like to invite. Where is he? Yeah, Dr. Pankaj Goel, who is consultant medical oncology, Rajiv Gandhi Cancer Institute, Delhi, and he's going to talk on walk the front line in ALK plus NSCLC. Over to you, sir.
Good afternoon, everyone, and thanks for having me here. Topic given to me is the management of ALK positive NSCLC. So we'll be going through some recent updates, brushing through the whatever standard of care has been there over past 1 decade. So we are well aware that lung cancer incidence in India, it's been increasing since 2014, 2020, and 2040. It's projected that it will be even more rampant as compared to what we have it today. So mortality still remains high. Estimated number of deaths, we see that we expect more number of people dying of lung cancer. Eventually, since the incidence is supposed to be increased, so number of deaths will also be supposedly increasing by year 2040. So this is the ALK gene rearrangement. We see that there are different figures as far as the incidence of ALK rearrangement is concerned. In Asian subcontinent, most of the studies give 6 to 8%. So after EGFR, it happens to be the second most common targetable gene of mutation. And seen in around 5% of advanced NSCLC, more common among patients who are younger age, never or light smokers, adenocarcinoma, and there are around 5 ALK targeted TK which have been approved since 2011. So this was the pathway. First, it had been just crizotinib. Then these 3 AVC drugs came into picture: alectinib, brigatinib, sorafenib, and the latest one is the lorlatinib. So we'll just see how these drugs are doing in this. So as we go from this first generation to second generation, third generation, we see that the PFS has improved and also the CNS penetration has improved. Initially, it was crizotinib, which was compared to chemotherapy, and also sorafenib, which was compared to chemotherapy, which showed a better PFS, improving from around 2 months in the crizotinib study and around 8 months in the ASCENT trial in sorafenib. Then came alectinib, which actually was outstanding as far as results were concerned. PFS improved from 10.9 months to 34.8 months. Then brigatinib and alectinib and brigatinib were basically compared with crizotinib, not the chemotherapy the way the previous trials were doing. So it again showed that PFS improved from 11 months to 24 months. Not moving. Not moving. Yeah, so this was the profile 1014 update OS analysis. We see that the crizotinib did show a PFS improvement, but as far as the overall survival was concerned, it was not very impressive. And same we see with the ASCENT-4, that p-value was 0.056 and hazard ratio 0.73. So the lines were having some difference, but not a remarkable difference as far as the OS was concerned. And if you talk about the alectinib, overall survival is still immature to comment. However, the hazard ratio is 0.67. But these lines were basically parallel in the initial few 18 months, and then afterwards they started separating. So there has been an unmet need for having new agents in the arena so that we can have better results. So lorlatinib was recently designed to address these unmet needs for metastatic brain disease patients and acquired resistance to LTKI. So initially it was being used in the subsequent lines, but then we had this trial which you're talking about, the CROWN study, in which this was used in the frontline in stage 3B4 and SCLC patients who were treatment naive, and patients with CNS metastasis were allowed. And they were randomized to either lorlatinib 100 mg daily versus the crizotinib, which still happens to be the standard of care. And the primary endpoint was PFS, and secondary endpoint was overall response rate and overall survival and safety indices. So these were the baseline characteristics. We had patients 61 years and 56 years in both the arms, and they were well balanced as far as the sex, race, or ECOG status was concerned. And they were also stratified on the basis of whether they were smokers or never smokers. So this was the updated efficacy and safety, which was presented in latest ESCO at 36.7 months. If we see the lorlatinib, PFS was much better. We see that the two lines are far apart, and as PFS was 9.3 months, usually that is the PFS we see with crizotinib, but lorlatinib it was not achieved. But if we see the hazard ratio, very impressive, 0.27. And also the response rate was much better, from 58% to 77% in lorlatinib arm. And at 36 months of this analysis, PFS was 18.9% in the crizotinib arm, while in lorlatinib it increased to 63.5%. So this was a subgroup analysis. If you can roughly see that all these parameters are indicating that they favor lorlatinib, irrespective of sex, age, or smoking status, and also the brain metastasis. So we'll see the subset analysis in the subsequent slides. So this was the PFS in patients with or without brain metastasis, all patients altogether. With baseline brain metastasis, we see that lorlatinib is far ahead as compared to crizotinib. And even without brain metastasis, we see that the two lines had started getting apart just in the beginning, and they are still maintaining that difference even after 36 months. And this is the time to intracranial progression, which was much longer with lorlatinib, 37% with the crizotinib, while 92.3%, which was unheard previously with any of the drugs available. So time to progression was 16.6 months on crizotinib, while it was not achieved on lorlatinib. And hazard ratio, if we see, it's 0.08. So this was the intracranial time to progression in patients with brain mets. Again, hazard ratio impressive, 0.10. Median PFS, crizotinib was just 7.3 months, since we know this was a bad subset of disease. PFS was even lesser, 7.3, while not achieved in the patients of lorlatinib as far as the PFS in these patients were concerned. And also intracranial progression without baseline brain mets, 30.8 months in crizotinib, lorlatinib not achieved, and hazard ratio 0.02. So only 1 out of 112 patients without baseline brain mets had intracranial progression on lorlatinib. So we can very well understand it's a very impressive data, and having so much efficacy intracranially has not been seen in any of the trial previously. So this is the summary of whatever we have discussed, that the patient who had any brain metastasis, the PFS was much better as compared to the crizotinib. And even with patient who had one measurable brain metastasis baseline, the intracranial response rates were much better. Adverse event, the drug was quite tolerable, and treatment discontinuation rate was more or less same. Crizotinib, it was 9.9%, while in this serious side effects, if we treatment related, again, they were more or less same. They were not more as compared to crizotinib. Crizotinib as such is supposed to be a well tolerable drug. Having a better efficacious drug with same tolerability profile actually builds our confidence to use this in near future. And the side effects which are more common in lorlatinib were hypercholesteremia and hypertriglyceridemia, which I feel is quite manageable. Unlike crizotinib, where we have these vision disturbances, alkaline transferase disturbances, which are problematic at times along with the diarrhea. So this what we have discussed, that permanent discontinuation rate were more or less same, and time to intracranial progression at 36 months was 0.08 hazard ratio, much better. Overall response rate 77.4%, and PFS was also much better with hazard ratio of 0.27. So though this is the latest version of the guidelines which enumerate all these as category 1, preferred are alectinib, brigatinib, lorlatinib. But seeing the previous data, I think this will again reshuffle, and probably the lorlatinib will become the preferred drug, and others might come down. So lorlatinib in first-line treatment of patients with ALK positive NSCLC, this was a meta-analysis in which they had done meta-analysis and compared this versus all other available drugs. And here we see that in all these subsets, whether we talk about alectinib, brigatinib, ceritinib, crizotinib, it's all of them are favoring lorlatinib as compared to the comparator. So this is the meta-analysis. This is overall survival data, though immature, but again we see that if we compare it with other drugs, barring alectinib, it is favoring everywhere lorlatinib. Alectinib, it's more or less same if you talk about the overall survival, but if we compare to brigatinib, ceritinib, crizotinib, it favors lorlatinib. Then this is the comparison of these other drugs, lorlatinib, alectinib, and brigatinib in the systemic review network analysis. And here also, if we see in this meta-analysis as well, that all these parameters are favoring the usage of lorlatinib. So result from meta-analysis, including only one RCT of ALK positive with head-to-head comparison with crizotinib, indicates that first-line lorlatinib is best treatment for PFS, for better PFS, and lorlatinib shows significant PFS advantage as compared to brigatinib and alectinib, with a probability to reach the best PFS of 97.5% in previously untreated patients. And this prolongs PFS versus brigatinib and alectinib with the probability to reach PFS of 96.4% ALK inhibitor naive patient. So these are the subgroup analysis. Again, we see that all of them are, all these subgroups, irrespective of race, smoking status, and age, they favor that the PFS is better with the usage of lorlatinib as compared to brigatinib or alectinib. So conclusion with these meta-analysis is that in terms of PFS, the results indicate that lorlatinib was the best treatment choice in patients with ALK inhibitor naive or untreated ALK positive advanced NSCLC. And among these drugs, probability to reach best confirmed response rates was 48% and intracranial response was 44% with lorlatinib. It improves PFS as compared to brigatinib and alectinib with a p-value of 0.03. And there was no significant difference found among them in OS and the adverse analysis. So this is the way it has been going through. If we see if we can use one of the strongest drugs like lorlatinib initially, or we try to sequence, we see that the green graph is doing much better as compared to the sequencing what we are seeing in the upper lines. And also we should know that not all patients will be taking all these sequence of therapy. So if we treat some patient on first line, then there will be dropout rates. Some 20-30% patients will drop out. So though we have added, but most of the patients will not even have this much of survival with the available drugs if we try to sequence rather than using the best drug forward. So conclusion, with approximately 18 months of additional follow-up since interim analysis in the Crown study, lorlatinib continued to show superior overall survival and intracranial efficacy compared with crizotinib in patients with ALK positive, and SCLC and PFS by BICR remained longer with lorlatinib, and the 3-year rate was 63.5% with lorlatinib as compared to 18.9% with crizo. And these efficacy benefits with lorlatinib compared to crizo were observed not only patient with baseline brain mets, but also the patient in which brain metastasis was not there in the starting. No new safety signals were observed, and these updated long-term data from Crown study confirm the efficacy of lorlatinib over crizotinib in patients with treatment-naive ALK positive NSCLC and supports its use in patients with or without brain mets. Thanks. With that, I'll conclude.
Hello. Thank you, sir.
Sir, it's understood that if a patient is progressing on lorlatinib, there is no other drug which will be used after that. No available TKI which will be used. The patient will be going for either chemotherapy or chemotherapy plus IO. But even then, if you see the PFS of lorlatinib, single agent to start with, and compare all these drugs in sequence, even then the PFS is much better, and supposedly the OS. So there is no drug after lorlatinib which is available, though we can repeat a NGS and see whether there are still some mutations which can be targeted.
To TKIs?
Sir, I think case to case, there have been reports that EGFR is also positive and LK is also positive. And people have used these drugs in combination also. But I don't think we'll be having any data. This will be just a matter of personal experience. What I have heard that these drugs have done well, but combining two drugs and managing the toxicity, financial and the physical remains a challenge. Thank you.
My question is that this sequencing the TKIs, you have just mentioned that there's no drug available after lorlatinib. So will you use alectinib first or lorlatinib?
So
and as we know that this is the only drug which is effective against mutation, which is commonly mutation resistant to alectinib, which G1 to.
Yes, sir. Most of the mutations, like this is the most effective drug. And also we see the intracranial efficacy. This is much better as compared to the other drugs. Previously, alectinib used to be supposed to be a wonder drug. But now in first line data, we see the intracranial efficacy that only 1 out of 112 patients had a CNS mets. Now, that is, you just cannot close your eyes on.
So that's because they are resistant and have this kind of mutation. Then why not we first go for alectinib followed by lorlatinib when we found this?
I think, sir, we need to have a study on that, whether using this and versus sequencing, which will be the winner? Thanks a lot.
Thank you, sir. Thank you so much. And next, I would like to invite Dr. Sachin Khurana to moderate the panel. And Dr. Sachin Khurana, sir, is Assistant Professor, Medical Oncology, AIMS, Delhi. Over to you, sir, to invite your panelists.
Hey, thank you very much. Thank you, organizers, for giving me the opportunity. So without wasting much time, I would like to invite my esteemed panelists for this session. Dr. Rakesh Taran from Indore. Welcome, sir. Dr. Tarachand Gupta from Bhagwan Mahavir, Jaipur. Dr. Preeti Agarwal from Apex Hospital, Jaipur. Dr. Deepak Mulachkar from RNR Hospital, Delhi. Dr. Rohit Rebelu from Ananta Institute of Medical Sciences, Udaipur. And Dr. Ankur Punia from Shri Ram Center, Mahatma Gandhi College. And Dr. Pankaj, if he's still there, we would be happy if he can give his inputs also. Yeah, please. No issue. Thank you very much. So we just heard a nice talk from Dr. Pankaj and a lot of things about second, third generation and lorlatinib. But I think the practical world is a bit different. So let us see and let us discuss with our panelists that how we are managing first this ALK positive patients in our routine practice. So let us start with the case scenario. 40-year-old male, no comorbidities, non-smoker, presented with shortness of breath and cough. PS1 evaluation revealed a right lung mass, bilateral lung nodules, mediastinal lymph nodes, biopsy, adenocarcinoma. So I think let's start with how are we proceeding with biomarker testing now? Maybe we can start with them. So do we do NGS upfront to go with GFR, ALK, cross?
Yes, I would prefer to go with the NGS upfront if possible, because I have the best possible options for the patient. Only for a patient who's having too much of symptoms, I would go for limited panel so I can start the treatment earlier. Otherwise, I would prefer to go for it.
And your reason for choosing NGS is to have wider options.
Wider options might be available for the patient because it's a young patient and adenocarcinomas, more chances that might get some common or uncommon mutation.
Yes. Anyways, so NGS first. Okay.
Yeah, I agree with him. Basically, what he says is absolutely right. And most of the times we end up doing panel testing. And more or less when we keep getting coupons for various tests, wherein you get coupons for NGS, it becomes easier. And then tissue is always an issue. That's there. But having said that, it usually takes longer for the results to come in when you do NG.
So you are worried about turnaround time?
No, turnaround.
Dr. Rohit?
My predominant worry is actually tissue because we don't have that many interventional radiologists where I work. So getting a good amount of tissue is a problem. So NGS solves the issue forever, whereas otherwise later on we get stuck because of tissue.
And are you, as Dr. mentioned about the turnaround time, so in your experience, what are your turnaround time for from diagnosis of adenocarcinoma to report of NGS and starting your therapy? So
IHC and then about 14 to 18 days for your NGS to come.
Okay, so
it's quite significant.
So you're ready with your
yeah, it takes about 3 weeks approximately.
So do you do NGS in all patients, or you are anticipating some molecular marker to be positive? Say same patient, 60-year-old, heavy smoker, and okay, adenocarcinoma, and yes, the PS1. Would you go for NGS or would you start? I mean, you like to do an EGFR ALK cross first?
I think the choice of test would not vary. I think if it's an adenocarcinoma, NGS would be preferred if the patient is affordable. But if, of course, if finances are an issue, then we go for more cheaper alternatives like just doing EGFR.
Sure. Preeti?
Similar, if the patient affordability, of course, then if it is 60-year-old adenocarcinoma, non-affordable, of course, I would not push him for NGS, would rather start chemotherapy, even not wait for the results. As if 40-year-old non-smoker, yes. And if affordable, NGS, if not, then EGFR, ALK cross, which are more common mutations.
With all the panelists that If the patient is affording for the higher molecules, then I will go for the NGS. Otherwise, EGFR alkalos is sufficient. If patient cannot afford the medicine, then I will not go for the NGS.
Rakesh, your opinion?
In the
It's going
biggest,
to be final opinion now.
biggest problem in private practice, the no one wants to wait for 2 or 3 weeks. So most of the time what I do is I send for EGFR cross, ask the patient for a week, and if it's positive, fair enough. If it's negative, I start with chemotherapy and then ask for.
Yeah, so I think I would be honest, and in my practice, I usually do EGFR cross and just start the therapy. Yeah, so NGS solves the problem of tissue, Dr. Rohit mentioned, but I think the turnaround time can be, sometimes very painful to start, treatment if the patient is specifically impatient. So anyways, next would be how common you have seen ALK? Is it the standard which is mentioned in literature, or anybody has any different view? I mean, more ALK or something like that, or all of you agree with the fact that whatever incidence is mentioned in the literature is the same which you experience in your practice? Anybody?
I think about 2%.
Anybody who differs 3 to 5% type? Okay. So now testing platform for ALK, I think most of my panelists say for NGS, but if you are doing a sequential testing, you go for FISH or IHC or anything. Preeti, maybe you can take up.
I would like IHC because it is available, it's cheaper.
Ankur? Great.
Because
Any takers for FISH or anybody not thinking that IHC is less reliable than FISH or anything like that?
You can get it confirmed by the FISH, but you should not wait for the confirmation.
Exactly. I think until unless IHC is 2+ or doubtful, then only we go for FISH. Otherwise, IHC is the standard of care, and the results have also been consistent with IHC and FISH. So next is now this patient was found to be ALK positive. So what factors in your practice do you consider before planning therapy? I think I'll ask this to everybody now. Ankur, is it cost, efficacy, tolerability, all, none?
all the factors makes a difference eventually, but we are planning. First of all, I think most of the cost affordability is the #1 problem most of the patients. We have to define the treatment, not just the first line, second line, what kind of patient might be able to take when he progresses. Expensive drug in the upfront and he might not be able to take some second drug, then no point of such kind of thing. So cost affordability obviously is the #1. Then yes, efficacy. We have to give the most efficacious drug up. Front. But tolerability obviously comes into the play as
There's a lot of talk going on which is the most efficacious drug and all. But I have at least 2 or 3 patients who are 4 years down on crizotinib, still going strong. So it's not that. And most of the times, since I have a little difference because I come from a public sector wherein if I write a drug, I procure it and give it to the patient. So in that aspect, the logistics becomes very important for me. So most of the times right now we are initially we started with crizotinib. Then alectinib has become available with us. So as far as the cost becomes a little of a to me, because usually we're able to get for our patients, but really important.
Rohit, most important
To
for
me,
you
it is
in
cost.
your practice.
To me, it is cost.
It's
I
cost,
work
yeah.
around
I
a
think,
tribal
yeah,
area, so it's
that's what I wanted to hear.
Yeah, it is cost, sir.
It is
Cost.
ultimately. Yeah. Tarachan,
Crizotinib also cost.
maybe
Everything is cost.
somebody,
Chemotherapy has to be given sometime.
somebody who is dealing with only the rich patients and has the luxury to.
Option
Tarachan,
A. Option A. Cost.
cost is the most important. Sir,
Great.
again, the cost. So
We have a lot of agents. We have alectinib, we have lorlatinib, we have we will be having brigatinib most likely in some time. But I think what remains a limiting factor, I think it's still the cost. Again, I think again, for the sake of discussion, let us keep cost aside. And now the preferred first line of therapy. Maybe Rakesh says you can take it up from here.
Keep cost aside, lorlatinib.
Yeah, alectinib.
Lorlatinib.
Lorlatinib. And why?
I did few of the survivors on lorlatinib who are really doing good.
On first line.
On the second line.
Second line. Okay.
But that can be managed with the lower dose of rosuvastatin only. And the intracranial activity is also better than alectinib. And if we see the meta-analysis of network meta-analysis, then a hazard ratio favor over the alectinib. Although there is no head-to-head trial, but still, yes, I have the better experience with lorlatinib.
Okay. Preeti.
Alectinib or lorlatinib, any of the two.
Any of the two. Okay. Say you have to choose between one. Then.
Design, and if you look with no brain metastasis, only 1 out of 120 or something actually failed in the brain. So that is the reason I think lorlatinib is probably the way to. I think after lorlatinib in 2 more years, I am pretty sure we're going to have something else. So I think lorlatinib first and then chemo after that, if he progresses, or probably in a year or two, we're going to have one more molecule. That's definitely.
But the data says alectinib also has good intracranial efficacy. What makes you believe that lorlatinib?
The PFS actually
better?
was slightly better, is better, even though the absolute follow-up is not yet completed. In about 1 or 2 months back, the PFS seems to be better. Of course, cross-trial comparison is not very correct, but the PFS seems to be better with them.
Dr. Deepak.
We need a phase 3 trial comparing alectinib with lorlatinib.
Which may not be there.
Which may not be something in we will have something on those lines. But yes, if you just look at the data right now, yes, you will have to say lorlatinib. Then you can keep justifying why you want to give something else. That can keep happening. But if you just go by the data, what is there? Yes, you'll have to say it is lorlatinib.
Okay. Anyway,
nothing to add, sir. Lorlatinib.
So lorlatinib is the clear winner here. Dr. Pankaj is here or not? So, anybody of you who is who is worried about that, or you think
one of my patient has communicated me this mostly on the compassionate ground. There was some psychosis type of component. In that case, you can start with low dose, maybe 50 milligram, and then gradually escalate, or you divide the dose into 50 milligram BD, something like it, and that is easy way to go ahead.
Okay. Any experience with first line lorlatinib? Anybody first line lorlatinib? Obviously, in the later lines, you might have used.
I have used in 2 patients.
Okay.
One is since 1 year, and Even within 15 days, we need to start. I may start from the day one also. First, both of the patients have within 15 days hypertriglyceridemia, for which I have to start. But they show the response within 2-3 days. There was some time like pain relief or another thing, and within 1 month they were nearby symptom free.
My question here is, if there is another drug in which you may not require any other drug to use, so you are saying that you may have to start rosuvastatin, you have to deal with edema or cognitive side effects or and other things, then why not use another drug which has maybe possibly less side effects and has a almost equivalent
Yeah.
intracranial efficacy?
Yeah,
Or,
you are right. Like alectinib, you are talking about.
Yeah,
And,
yeah.
Thing is that I have already mentioned that in last question that the network meta-analysis showing the very good PFS, and the side effect is manageable with a single drug only.
Yeah, please.
But we are discussing only beneficial, but that I suggest that this more edge over electronegative CNS tumors. Now, how many patients have CNS tumor after this progression? Because they are already stage 4 and metastatic, and how many percentage patient have CNS tumor in metastatic stage 4 adenocarcinoma?
I think what one of the panelists mentioned was that they usually fail in brain. But I think my point again, and I agree with
even
you,
also it's
that both
good for
alectinib
alectinib in
and
brain,
lorlatinib has similar more or less similar intracranial efficacy. And I think so we can discuss in the end, but I think there is no clear winner as of now. So still we have we know that there'll never be a trial comparing alectinib or lorlatinib. It's going to be real world data. But so I'll just come to the CNS thing.
And Sachin, before you
please.
go ahead, I mean, we are all medical oncologists. We know how to deal with side effects. That's what we deal with most of the times.
We know how to deal with side effects, but the patient may not be comfortable in experiencing those side effects.
We know,
we can deal with them, but the patient may say that I want these these side effects, and then there may be a different choice. Anyways, would your choice? Well, everybody was more or less for lorlatinib. Preeti, maybe you can answer this question. Would your choice be different if the patient has brain metastasis at base?
So as you said, we don't have head-to-head comparison, and CNS efficacy may be similar between lorlatinib and alectinib. Any of the drug is okay. So there is no one to choose lorlatinib versus alectinib, any of the two.
And I think other panelists would go for lorlatinib, considering that even in absence of brain metastasis. Okay, so we have Crown, we have Alex now. What are your impressions of these studies? Do you think there is a clear winner between lorlatinib or alectinib based on the data of these two studies, considering efficacy as well as safety, leaving cost aside? Rakesh.
I had a good experience with lorlatinib, so I will still with lorlatinib.
So lorlatinib is the winner. I know, so we can't do cross-trial, comparisons, but still, lorlatinib is the clear winner.
Lorlatinib has not done well after alectinib, so you don't have the option.
Okay, Tarak.
Yeah, I don't think, as Dr. Deepak rightly mentioned, that without phase 3 trial we can answer this question.
Yeah.
But experience is with lorlatinib now.
Okay. Preeti.
Same.
Dr. Rohit, any difference?
No difference. In our army, we have a saying, कि 19-20 का फर्क है.
Sorry?
19-20 का फर्क.
Okay.
हाँ?
Okay.
तो यहाँ आप कह लो 18-20 का फर्क है.
That's all. 20 किसको दे रहे हैं? लॉर्लाटिनिब को?
20
लॉर्लाटिनिब को मिल रहे हैं, 18 इलेक्टिनिब को मिल रहे हैं. So it's like a 2-point difference so far. Yeah. Ankur, 18, 20, 17, 20, 16, 20.
18
18-20 hai. Okay.
Till the final.
Anybody in the
data
audience who say 20-20?
So any cost difference in between twos, I will choose the option after.
So cost leaving aside, I know cost is the primary factor. Well, in my practice, cost is the primary factor. But between efficacy and tolerability, both combined, 20-20, 19-20, 18-20, or anything else. And who is the winner?
The decision of our panelists.
Sorry?
The decision of our panelists.
So you respect this. So 18-20, right? Okay, great.
When you give the two options to the patient, he automatically goes for second option.
Patient will go for the second option. That's fine, sir. I mean, let the juniors also do something. maybe Tarachand can take take the patient. It's fine. That's fine. So it's like 18-20, and so panelists here agree, and that considering both safety as well as efficacy, lorlatinib is the answer here. But anyways, well, this is from the Crown data, CNS response rate. So in those with measurable or non-measurable brain mets at baseline, it was around 66% and 82% with measurable brain metastasis. LX, I think, wasn't much different from this, 81% and 59%. So, well, this is both are now approved drugs, both lorlatinib as well as alectinib, and well, my practice is still with Pizza and ceratinib. Anyways, I think this has already been mentioned. Tarachand has mentioned his experience about lorlatinib, and Dr. Rakesh has also mentioned that the CNS adverse effects can be managed by lowering the dose. Impact on QL. So, well, again to all panelists, starting from Ankur. Do you think quality of life is important? I guess it is. I'll answer that. And do you think between lorlatinib and other TKIs, there will be any quality of life?
Ultimately, it comes down how do you manage the patient. So if patient is able to get the maximum benefit out of a drug, it's better to give the patient the best possible option. With any new drug comes, or we have some side effects, newer side effects which comes, but eventually we learn to manage them. So to give strong quality of life, we have to give the patient. So that's my take.
So मैं कहूँ कि इतना टेंशन लेना ही क्यों, पेशेंट भी खुश रहे, आप भी खुश रहो. So why not choose a drug with less side effects? I know we are we can manage those side effects, but देने क्यों हैं?
Then second points come to the patient preference also, sir.
Okay.
The patient preference also matters then. What kind of, if he is happy to have maybe a better outcome with a little bit of side effects, then yes. But if patient who completely agrees that I don't want any side effects, all the best, safest drug possible, then yes. Rather than to give lorlatinib, start with the alectinib.
I think that point is fair, which a learned patient can choose. But I think still it possibly maybe lorlatinib will be better, but it is still we don't have any head-to-head trials, so it's very hard to say, very very difficult to say with certainty that one drug is better than. That's my take. I mean, Dr. Deepak, quality of life.
Agree with you solely, completely.
Complete. Thank you. Yes.
Yeah, actually, OS and QOL, these are the two primary endpoints of that should be the primary endpoint of every study. Over the two, an oncologist would always go for OS, but I think a patient would sometimes choose more of quality of life because he would, whatever survival he has, he wants to live it. I think this is something we offer our patients, that these are the side effect profiles we expect. Unless and until you have the CNS adverse effects, right? I think lorlatinib is not too much of an issue to manage. And I think about 20 to 30% of the patients generally have CNS, 70 to 80% have the triglyceride, which we manage. So I think it's better to take a risk with efficacy, and hopefully they don't get the CNS side.
Possible efficacy, I would say. Anyways, Preeti.
Yes, quality of life is very important.
So if only quality of life is the thing, then would you choose alectinib or lorlatinib?
Yes.
Alectinib.
Yeah.
So there's one winner for alectinib. Okay.
But I have already answered.
You were sorry. Also quality of life. Sir, quality of life.
I go with my moderator. How can I oppose it?
No, no. No, so it's just a discussion. So yeah, I think quality of life is an issue. Well, what lorlatinib, the side effects of yeah. So I think yeah. So almost some side effect was seen in almost 100% of the patients, and the most common were dyslipidemia, increased weight, edema, and cognitive. This cognitive side effect is something which I am worried about, but I'm not sure. I don't have that much experience with lorlatinib in the first line. Definitely in the second line, it has excellent intracranial efficacy. I agree to that. But yeah, I think I am somehow a bit worried about these cognitive side effects. Yes, they may be manageable. The grade 3 are very few, but still this may be something that has to be learned over the period of time, and see as we gain more experience, maybe we are more versed with using this lorlatinib, and it may end up a clear winner. So the side effect management, and Dr. Tarachan mentioned that he would tend to use rosuvastatin or atorvastatin upfront. How do you manage hypocholesterolemia, sir? Rakesh, sir? Any particular drug you use, or we experience both hypertriglyceridemia, hyper cholesterolemia? Do you use only rosuvastatin? Do you use fenofibrate, or
I send them to my physician to manage the show.
say that's the best thing to do? Preeti?
Rosuvastatin, sir.
And
And I think fibrates have some, I think there's interaction.
2 more
with-
minutes.
There is interaction. I think fibrates are not the drugs, but I don't have much experience with lorlatinib as of now.
Statins, but yeah, I also refer it to medical college, so I have to refer it to my physician.
Use statins. I just have one patient on lorlatinib. When I say we use statins, it is just one patient. Okay.
Fine. Okay. I think the CNS side effects, grade 3 were less. I agree. As Dr. Rakesh mentioned, we can decrease the dose. Dose modifications we can decrease by 25 mg every time. Okay, now just last question. This patient was actually started on crizotinib and progressed after 12 months. Would you revive, sir? And why? Okay. Tarachan, would you rebiopsy or would you start lorlatinib straight away?
No, I would do rebiopsy for any other rare mutation if possible, or in there any mutation in ALK gene also.
Preeti?
Yes, I would also rebiopsy.
Anybody who would not do a biopsy and straight away go to alectinib, lorlatinib, or any other drug? All would do a biopsy. Okay. Next line, again, alectinib versus lorlatinib. Lorlatinib is the winner, I guess. Anyways, so this is a recent pattern. We know, I think, one mutation which is only managed by lorlatinib is G1202.
Can you just go
yeah,
back, say?
Sorry?
There was a slide which was demonstrating various ALK.
This one,
Yes,
sir?
this one.
Yeah.
So, should we look for this as well at the time of treatment decisions or for the
I think
progressions? I am not sure.
treating with still the treatment decision do not depend upon the variant or the type of mutation. As of now, this is what I think. In future, definitely it could be something more targeted. There is a ALK master protocol going on where different sequences are being tried based on the different mutations present or different resistance mechanism present and different variants. So V1, V2, V3 of ALK, but I think we still don't have that data. This is what I think, and I think still we have to go by those things. So I think the second line would definitely depend upon the type of mutation in the near future. So with that, I think I've already exceeded my time, but yeah, my take would be still 2020. And the quality of life should be the most important thing. This is what I feel. Thank you.
Now I would like to invite Dr. Deepak Gupta. He is a senior consultant medical oncology, BMCHRC, Jaipur.
Okay. Very good evening. I have been given the task to discuss the trials of Atizo, IM power 1110, 130, and 150. So the topic is role of atezolizumab in first line metastatic NSCLs, options to meet individual patient needs. So this is the landscape of lung cancer treatment. NSCLCs in 80s and 90s, we used chemotherapy, and then came treatment based upon the histopathology, adeno versus squamous, and anti-angiogenesis came into picture. Then in 2000 onwards, we had some molecular targeted therapy against EGFR and L. And now in second decade, we had checkpoint inhibitors, and today topic is on the same. So this Kaplan-Meier curve shows that how we have improved survival with targeted therapies as compared to conventional chemotherapies. See, the hazard ratio is 0.47 and median survival is, median OS is improved from 12.7 months to 30 months, beyond 30 months. And today we'll discuss three trials, IM power 1110, which is for atezolizumab monotherapy in PD-L1 selected patients. IM power 130, which is to test the steroid sparing chemotherapy along with combination with atezolizumab, and IM power 150 to test the co-drug combination of ABCP. So first, IM power 1110, which is for both squamous and non-squamous patients, and atezo monotherapy in PD-L1 selected patients. So stage 4 non-squamous or squamous NSCLCs, chemotherapy naive, PD-L1 selected, that is more than 1%, EGFR and ALK negative, were randomized to atezo single agent versus chemotherapy, which is pemetrexed or and carboplatin or cisplatin in non-squamous, and gemcitabine with platinum in squamous cancer, followed by atezo maintenance in atezo arm, and in non-squamous pemetrexed or in squamous best supportive care until progression. Crossover was not permitted, and primary endpoint was OS in wild type population, excluding patient with EGFR and L. So this is the distribution of PD-L1. So all patients were more than PD-L1, and 1/3 of patients, approximately 35% had IC3 category, that is more than 10% PD-L1 on immune cells. This is the baseline characteristics, so well balanced between arms and PD-L1 subgroups also. Histology, squamous adenocarcinoma was present in approximately 70%. And this is the primary endpoint of OS, which was significantly better with atezo, 20.2 month versus 13.1 month with a hazard ratio of 0.59. This was in IC3 population. This is the subgroup analysis, which shows more or less beneficial for all the subgroups in IC3 population. And subsequent treatment, it was received more in 28% of patients. Immunotherapy was received. 1/3 of patient had further received chemotherapy, immunotherapy in chemotherapy arm. And this is the median PFS. It is 8.1 month with Atezo versus 5 months in IC3 population. And PFS was not formally tested in further IC2 and IC1 because of hierarchy statistical plan. The PFS was significantly better. Overall response rates, it was 38% versus 28%. And if we include IC2 or IC1 population, the response rate was significantly better with Atezo. These are the toxicities. More or less, the toxicities were, it was a favorable safety profile as compared to chemotherapy. Grade 3 and 4 adverse events were less with Atezo, and any adverse event leading to treatment withdrawal was also less with Atezo as compared to chemotherapy. And immune-mediated adverse events, that is grade 3 and grade 4, was more 6% as compared to 1.5%. These are the toxicities mainly seen with immunotherapy. More commonly seen with Atezo was in hepatitis, pruritus, and hypothyroidism. Rest of the toxicities were more common with chemotherapy as compared to Atezo. So to summarize, IMpower 1110, Atezo represents a promising first-line treatment option in patient with PD-L1 high NSCLCs. It's a positive study that demonstrated statistically significant and clinically meaningful improvement in OS in TC3 or IC3 wild-type population with a hazard ratio of 0.59. Safety profile was consistent with prior observations. No new unexpected safety signals were identified. Atezo had a favorable safety profile, and patients treated with Atezo had a longer treatment exposure than patients treated with chemotherapy. Now to coming to second trial, IMpower 150, which is also for non-squamous NSCLCs, phase 3 study of Atezo plus chemo plus bevacizumab in first-line advanced non-squamous NSCLC. So these stage 4 NSCLC, which were chemotherapy naive, they were randomized to Atezo plus paclitaxel and carboplatin, Atezo plus carboplatin, paclitaxel and bevacizumab, that is ABCP, and third arm was BCP, that is bevacizumab, paclitaxel and carboplatin, followed by maintenance, either Atezo or combination of Atezo plus bevacizumab as per their arm. So this was tried to see if there is a addition, does the addition of Atezo to bevacizumab, paclitaxel and carboplatin add any clinical benefit? So the rationale behind this is that bevacizumab leads to efficient priming and activation of T cell response and reprogramming tumor microenvironment. So Atezo's ability to restore anti-cancer immunity through T cells mediated cancer cell killing is further enhanced through bevacizumab's mediated immunomodulatory effects. So these are the baseline characteristics. 14% of patients had liver metastasis at baseline, which was a stratification factor, and 10% patient had EGFR mutation, and these patients were also balanced on 3 arms. And PDL1, it was 50-50 split between PDL0 or PDL more than 1. So this is the OS curves, arm B versus arm C. So ABCP versus BCP. So median OS was 19.5 months versus 14.7 months with a hazard ratio of 0.80, which was significant. And there was so overall response rate and duration of response was also improved in intent to treat analysis. So intent to treat analysis, 56% response rate with 4-drug combination versus 41% with BCP. In PDL1 high, response rates were further more increased to 69% versus 49% with BCP. In PDL1 low and PDL1 negative also, response rates were better with 4-drug combination as compared to BCP arm. Median duration of response was also increased 11.5 months versus 6 months with Atezo versus BCP. And OS benefit was also observed across all subgroups, PDL1 subgroups like PDL1 high, that is IC3, with a hazard ratio of 0.70. OS was 25 months versus 15 months. In PDL1 low, also OS was 20 months versus 16 months with a hazard ratio of 0.8. And in PDL1 negative, it was numerically better, although hazard ratio was 0.82. In subgroups like EGFR positive, those who have received EGFR TKI. So clinically meaningful PFS benefit was observed from arm B as compared to arm C in patient with EGFR mutation positive or ALK positive NSCLCs with a hazard ratio of 0.59 and median OS of 9.7 months as compared to 6.1 month. Kaplan-Meier curve starts separating around 6 months, and there is a plateau also. OS benefit was also seen in EGFR sensitizing mutation. Arm B versus arm C hazard ratio was 0.6, 29.4 month as compared to 18 month with BCP arm. But in arm A versus arm C, there was no benefit in OS. Overall response rates were also better with 4 drug combination, 71% response rate versus 42%, and they had 6% CR also with ABCP arm. Another subgroup is liver metastasis, which is a poor prognostic group. So clinically meaningful PFS was also benefit was also observed for arm B as compared to arm C. Median OS was 8.2 months as compared to 5.4 months with a hazard ratio of 0.41, which is another, because liver metastasis being a negative prognostic factor, this is also a very good survival. Arm B versus arm C, there was OS benefit in liver metastasis group, hazard ratio of 0.52, but in arm A versus arm C, there was no significant difference in survival. And OS benefit, there was an overall survival benefit also in liver metastasis when bevacizumab was added to atezolizumab, but there was no OS benefit in arm A versus arm C. So combination of both atezo and bevacizumab is important for clinically relevant OS benefit. Overall response rates were also better with 4 drug combination, 60% versus 41%, and median duration of response was also doubled from 4.6 months to 10.7 months. I skip this. Slides are not. Again. So this is the last trial, Empower 130 in non-squamous phase 3 study of nab-paclitaxel and carboplatin with or without atezolizumab in first-line advanced non-squamous NSCLCs. So trial design was stage 4 NSCLCs, non-squamous, chemotherapy naive, QGPS 0 to 1. Arm A was atezolizumab plus carboplatin and nab-paclitaxel, and Arm B was paclitaxel, non-nab-paclitaxel and carboplatin, followed by maintenance atezolizumab in Arm 1 and pemetrexed or best supportive care in Arm 2. Crossover was not permitted after amendment, but despite this amendment, 41% of patients of control arm crossover to atezolizumab, and total 60% of control arm received immunotherapy. Baseline characteristics were generally balanced in both arms. Investigator assessed PFS was significantly improved with addition of atezolizumab to carboplatin plus nab-paclitaxel. 12-month PFS was 29% versus 14% with chemotherapy only, which was almost doubled with a hazard ratio of 0.64. OS was also significantly improved with the addition of atezo to nab-paclitaxel and carboplatin. And hazard ratio was 0.79, and 2 years OS was 39% versus 30%, median being 18.6 versus 13.9 months. OS benefit was observed across all clinically relevant subgroups in intent to treat wild type population. In EGFR and ALK positive NSCLC, no PFS or OS benefit was observed over chemotherapy alone. Overall response rates and duration of response were also improved with arm A as compared to arm B, 49% versus 31.9% response rates, and PR was 46 versus 30%. It was well tolerated, and safety profile was consistent with known safety profile of each drug. And major toxicities were related to immune side effects were more or less similar, but all grade 3 and grade 4 was less than 5%. So IMpower 130 was a positive phase 3 study for atezolizumab in first line NSCLCs, providing an alternative CIT plus chemotherapy regimen for patients with chemotherapy naive NSCLCs. It demonstrated statistically significant and clinically relevant OS benefit when atezolizumab was added to carboplatin and nab-paclitaxel despite the high crossover rate. It demonstrated a PFS and benefit and higher overall response rates when atezo was added to chemotherapy. PFS and OS benefit was also observed across key clinical subgroups except with EGFR and ALK positive study groups and in patient with liver metastasis. And atezo plus chemotherapy had a safety profile consistent with adverse event associated with single agent therapy. No new safety signals were identified. I think this is all. Thank you. Oh, thank you.
So now I would like to invite Dr. Sunil Gupta, sir. He is a director in HOD Hemato Medical Oncology and a bone marrow transplant department of Venkateshwar Cancer Center, Dwarka. Sir, please.
Thank you very much for your kind introduction. Very good evening, dear friends, ladies and gentlemen. At the outset, I really thank the sponsor of this program, my dear Dr. Sarjuja, my colleague, my friend, who has invited me for this talk. But again, I am thanking the AstraZeneca who has given me this opportunity. So many times we are talking about a randomized trial. The results, the representation of patient is only 2 to 4%, but we don't know about the real world picture. Today, I would like to discuss about the real world evidence on a third generation TKI, ositinib, which is a drug of choice for a T790 mutation in adenocarcinoma patients as a standard of care in management of mutations, basically in adenocarcinoma. Just see, patient with EGFR mutation, progression-free survival improvement are seen with the TKI once compared with the cytotoxic drug. If you see the phase 3 trial, people are talking about a landmark study, Flora trial. Ositinib is a third generation TKI, basically acting as an irreversible drug as compared to first generation and second generation TKI. And the median overall progression-free survival is 18.9 months, which is much higher as compared to 10.2 months with hazard ratio of 0.46 and significant p-value 0.001. And this is the landmark study which changes the picture in treatment of adenocarcinoma in lung. If you see the overall survival and median overall survival, 38.61, which is again very high, and no TKI shown a overall survival benefit in any randomized trial, which Flora trial shows as 31.8, hazard ratio 0.8, and this is the conclusion made ositinib the best treatment option for patient with untreated mutations positive adenocarcinoma. Now just see, this is the final analysis of the landmark study. I'm just discussing the important aspect of a landmark trial, and I will discuss what are the real world data of this. This is a double-blind study, and just see the inclusion. I'm highlighting few things which is very important in this trial. They enrolled more than 18 years or equal to that patients, but in Japan, they has included more than 20 or equal to that in Japan and Taiwan. This is the major difference. PS should be 0 to 1, exon 19 deletion, exon 21, no prior cystic treatment, anti-cancer treatment or TKI, or stable CNS patch. Randomized to 2 arm, ositinib versus the first generation TKI, gefitinib or erlotinib. And the assessment criteria was reached 1.1, 6 weeks later for progression of disease. The important thing which I want to mention you regarding this, crossover was allowed for a patient in the competitor PKI arm who could receive open label ositinib upon central confirmation of progression and T79 mutation positive. Overall survival is always a randomized trial results, and this drug has shown the overall survival benefit. And they reported 318 death for this. And they mentioned about that 22% patient on ositinib arm and roughly 5% patient in competitor arm were ongoing study treatment. Just see the baseline. They mention about male, female. So females are almost, almost double as compared to male. The median age is 64. Asian patients are more than non-Asian patients. Smoker was 65, never smoker 35. TNS PET seen in 19 versus 23. PS 0 is in 40% of the patient. PS1, 60% of the patient. This means most of the patients are having a good PS. And once patient is having a good PS, almost overall survival or the response of the treatment seen. Metastatic disease in 95% of the patient and advanced disease in 5%. Adenocarcinoma. Histopathology adenocarcinoma was seen in 99% of the patient as compared to 1 to 2. And exon 9 deletion 19 is in 60%. Means exon 21. Just see, all these sub has shown a good response. And the response in the sense progression 5. Ositinib 18.9 as compared to first generation TKI 10.2. This means almost 8-month difference seen with this. The important thing they have noted that any patient who is basically female, PS0, or when patient is having exon 19 deletion, they are responding better. Just see the overalls. 38.6 as compared to the first generation means competitor. I'm talking about first generation TKI means erlotinib and gefitinib. 31.8. The graph is really showing advantage of this drug since beginning because number of patients are having a T79 mutation, one of the reason of progression of disease, that is carcinoma. It's not. Just see the conclusion of this trial. They clearly mention about that median overall survival with this drug is seen roughly 6.8 months. Once you're talking about first generation TKI and second generation. The important thing is that 28% of the patient in ositinib arm and 9% of the patient in first generation TKI are remain on the first line. Just see that this is the difference between first generation versus third generation. Ositinib presented a favorable, even in tox, even in response, and results showed even in overall survival. The final overall analysis of flora reinforced This PKI is the standard of care for first line treatment in patients those who are having a adenocarcinoma and mutations positive. And just see, this is the slides basically provided me to the AstraZeneca. I cannot change anything. That's why you can see a version of NCCN guide of 2021. Nothing changed even in March 2002. Why I'm highlighting, just see the importance of this slide. Once you have an EGFR mutation discovered prior to the first line systemic therapy, just see category 1 recommendations are so many, but I'm talking about a preferred category 1 recommendation is only third generation TKI ositinib. You can see a category 1, even the second generation afatinib, gefitinib, dacotinib, erlotinib, but my word is a preferred category 1 recommendation by the NCCN is third generation TKI ositinib. Even EGFR mutation discovered during the first line systemic. You can complete the chemotherapy or maintenance, or you can interrupt if patient is having any toxicity and switch on this third generation TKI. Now, I am talking about my topic. Why I'm talking about a real world picture of this third generation TKI. We have a 3 bases. We have a floral study, OSI effects, and myoconus. And I will discuss in brief all the 3 and conclude my talk. This is a flower study. Once you're talking about any randomized trial, please just see the world says 2 to 4% patients are enrolled, and we are talking about result, and overall survival. And nobody knows about the real world picture. The real world data have become useful tool to assess unique insight in the routine oncology practice, the post-marketing setting, and which I am discussing. Just see the baseline thing. We have a median age 68. We have a brain mets in 30% of the patients. Just see, which I am highlighting, that we have seen more than 90% patients are stage 4A and 4B. Means 4A, 23%, 4B, 71%, and bone mets and other mets. I'm not going in detail of this. I'm highlighting few things which is very important. Just see the inclusion. They mentioned about more than 18 years, adenocarcinoma, mutations positive, clinically stage 3B and 4, and eligible for TKI. I mean to say, patient is fit for TKI. Exclusion criteria means patient should not receive any TKI or any drug which is clinical. Just see the important endpoint of. Once we are talking about MD, measures from the ositinib start to discontinue from any cause. Any cause means due to side effect or due to intolerance, due to progression of disease. Now we are seeing that response. TTD is under exploration as a prognostic real world endpoint, and we are most of the time talking about progression, survival, overall survival, disease control rate, response rate, and even progression of PET. And we are having a diagnostic therapeutic pathway. Since diagnosis, we are not bothered about the treatment, and number of times we are going for rebiopsy in a metastatic disease, could be a tissue or could be a liquid biopsy. I will show you how many percent. So the effectiveness of this means you know that any patient who is having a poor comorbid condition like coronary arteries, hypertension, diabetes, rare EGFR mutation, I will show you the data that few rare mutations are seen, the response rate is poor. I'm giving an example like MET gene amplifications. Active brain mets were included in FLORA trial, and they mentioned about outcome were similar to published data that heading and basically enforce the positive role. And no difference in progression. Survival, overall survival were noted in elderly patients, because they have included more than 75 years of age. And I will show you what group they have divided and what is the overall response. And just see, there is a very important slide which I am highlighting. You can easily see that in between there is a graph which shows that if any patient who is symptomatic in lung cancer, they are responding not better than asymptomatic patient. And the median time is 18.8 months. And if patient is having more than 3 mats equal to that, again, they are not responding better as compared to less mats with this TKI. And the median is 21.4 months. And just the overall, the median is 25.31. This graph clearly shows the picture. The symptom play important role even in the overall response rate and survival. So I can conclude that TTD appear to be a more suitable endpoint to evaluate the outcome in pragmatic real-world picture. And this is seen roughly 25.3 months versus FLORA trial 28.8. Better TTD was associated with fewer than 3 progression site, an isolated progression. Sometimes you can have a oligomats. The response is much better as compared to more than 3 mats by this real world picture. So poor treatment outcome for patient with brain mets, presence of symptom, which I have already given you idea that graph is showing those who are having a symptomatic presentation, they are responding poorly and the outcome is poor, at least 3 mats, and suggest tumor load as a negative prognostic mark. Means high volume disease, the response rate is seen, but the outcome is poor as compared to low volume disease. This is basically just see the effective. They have reported no CR, but they reported that 73% patients are having a partial response. Stable disease in 23% means that more than 90% patients have a disease response. Stable disease itself means 30% response. PD is only in 4%. This is a click in my mind as in a medical oncologist. I believe that stable disease and even PR and good quality of life is one of the indicators to treat these patients, and the real world picture is showing that. And again, effectiveness, I clearly shows that if median progression-free survival in patient with or without brain mets, just see the difference. Graph is showing that if brain mets, the response is less and survival is less. Same thing with the patient with or without symptom, which I have already shown. And overall, median is 18.9 months. I have clearly shown you that more than 70% patients are having a partial response, and more than 20% patients had an PR. Only 4% has a progression of disease. After a median follow-up of 12.3 months, progression-free survival was 18.9 months. This is very, very important, which converted into the overall survival, which were more important for us as a clinician. So multivariant analysis, longer progression-free survival was noted in the absence of brain mets. Prolonged progression-free survival without symptom in patients. TDT of 9 months or higher was significantly associated with better overall survival. Now, I am talking about the therapeutic pathways of real. We are talking about a patient, those who had a progression of disease, and these patients are basically 44. 21 cases means 47.7% underwent a rebiopsy at progression. Tissue biopsies are basically in 67.7%, liquid biopsies in 28%. Molecular analysis shows that drug-label resistance mechanism, they have reported the rare mutations like MET amplifications, new drugs are available. They have reported the EGFR amplification, HER2 receptor, these are less than 2%, but targets are different. and that's why they are not responding to the first line TKI, second line TKI. So I can conclude this study that few side effects are reported, which is manageable by the medical oncologist. You can see in pneumonitis, which could be in the tune of 12.8%. And even the severe one reported 0.7%, means few patients had a severe acute pneumonitis and could be probably morbidity and mortality you can see, but manageable diarrhea as well as stomatitis, pneumonitis, and rash. The important thing. In retrospective world analysis, they found that VT means venous thrombosis embolism was reported in ositinib roughly 2%, but that was not significant with P value and not seen in routine practice. So I can conclude my talk that 87% experience adverse effect and 33% were grade 3 and 4. Venous thrombosis, they have reported, was the most common in the real world picture, and they are reported roughly 2%, but no difference in rate of VT was reported according to age, performance status, comorbid condition, and tumor load, which I mentioned high burden versus low burden. No difference in survival outcome was observed according to age, comorbid condition, type of EGFR mutation, and I would like to say third generation TKI positive confirmed effectiveness and safety in the real world scenario as per the data suggests. Now, OSI facts, what is the meaning of this and why there is a need? The current study investigated the difference in efficacy with patient background and the safety of first-line ositinib treatment in real-world scenario. Inclusion criteria, EGFR in advanced and non-small cell lung cancer, adenocarcinoma. But the important thing is the exclusion criteria, any anti-cancer treatment or radiotherapy to the chest wall, post-operative adjuvant treatment, or ositinib received in second line criteria. So baseline characteristic of this OSI effect, they mention about that. I'm highlighting few important things regarding. So many speakers talked about the immunotherapy. My previous speaker talked about. I'm talking about the PDL1. People are using right and left, but see the importance of PDL1. More than 50% seen in only 11% of means approximately 12%. You can say 11% in lung cancer. Less than means 49 to 1% is 31%. Unknown is 26%. Less than 1% is seen in 30% of the patient. So the important thing is that this play important role in the sense of response, even in brain mets. Symptomatic only 6.1%. I'm talking about a metastatic disease, more than 3 mets or equal to that. So the primary endpoint was progression-free survival. Secondary endpoint was overall survival. Everywhere overall survival play important role in oncology. If this is seen, means this drug is good. The time to treatment failure, response rate, safety, and post-treatment. I'm talking about the response rate in which you have a CR, PR, stable disease and progression of disease, but I'm talking about objective response rate, which means most of the time nobody knows about that as a clinician. What is the meaning of objective response rate? You are having a CR plus PR. Then you are talking about a objective response rate. And once you're talking about disease control rate, you have a CR, PR, and a stable disease. And most of the time, the clinician doesn't know about that and we forget that. We know and we forget. I'm highlighting that once you have a 3 analysis, that disease control rate, if you are going for a CR plus PR, objective response. Primary endpoint, progression-free events occurred in 180 patient of the 538 patient, and this is 20.5 months. Other parameters. Male are responding less as compared to female, malignant pleural effusion, liver mets. The visceral mets specifically for liver and advanced unresectable high volume disease responded not well as compared to other subgroup. With respect to PL1, just see progression survival not reached when the TPS score is less than 1%. But if less than 49 means 1 to 49, response rate is 14.7 months. And if TPS 50%, response rate is 11.1 months. This is the primary endpoint. The male malignant effusion, liver, as well as the PD-L1 play an important role in a present era once you're talking about third generation TKI as an option. So treatment discontinuation profile, just see why the patient stopped the treatment. What was the reason? I'm highlighting few. 44.3% patient had progression of pneumonitis, which I have conveyed you 12.8, overall 25.6%. These are the two culprits seen as a discontinuation of treatment. Other events like 6%, I'm not going on progression of disease. Safety. Pneumonitis, just the first 12.8. And they mention about non-hematological toxicity less than or grade 3, roughly 11.2, and other side effects not much. So I can conclude my talk with this second evidence real world. Overall response rate 76.2%. Disease control rate was 94.1%. Progression-free survival is better with the third generation TKI as compared to PD-L1, irrespective of. Median TTF was 19.1 months. Median time from start of treatment to onset of side effect. Just see the side effect, 56 days. And this range is from 5 to 565 days. And nobody bother about the late side effect or the delayed side effect. I just want to highlight that 5 days, 556 days are the period where you can see the side effect routinely 56. And most of the time we forget that, oh, it's a delayed side. No. This is not due to drug, but this is reported by the real world. Pneumonitis, 12.8%. 4% patients are having a major problem, and sometimes fatal pneumonitis, 0.7%, need a acute respiratory failure. And conclusion, progression-free survival after first-line ositinib treatment in real world practice was favorable because this is supported by the overall survival and response rate. Discontinuation due to side effect is only 18.8%, especially pneumonitis, which I am highlighting again and again, require further investigation. Now I am talking about the third support of real world data. Just see why there is need for this. I'm highlighting few things which is very important. There remain a need to evaluate real world disease. There remain a need to evaluate real world disease characteristics and clinical outcomes of patients with mutations treated with first line, third generation TI, ositinib monotherapy. My word is monotherapy. This study report the demographic and clinical characteristics of real world in the sense of a real world time to treatment discontinuation and real world time to next generation or death with advanced mutations positive adenocarcinoma who received first-line ositinib in the United States. Just see, a global observational prospective coherent studies is ongoing in the United States, Europe, and Asia, and involved analysis of registry. My word is registry and electronic health record data from country-specific data source in participating countries. They basically have 280 US cancer clinics, 800 sites for care. This study started in June 30th, 2020, will complete in 2023. And this is the criteria for inclusion. Basically, in 2011, advanced non-small cell lung cancer diagnosis started, and basically identification seen in 2018, and mass 2031, 2020 patient identification and interim analysis done in June 2020 30th, and still continue June 2030, 2023 they will stop and conclude. So the characteristic is basically a age 70 years. I'm just showing two things. We are talking about the academic center. Even in United States, only 16% patients were enrolled in academic center, and community-based hospital were 83%. I'm talking about the median age 70 years, and they split it into three: 18 to 64, 65 to 74, and more than 75 or that. Females predominant as compared to male, whites more than 50% as compared to other world's person. This is stage 4. You can see that 81% of the patients were stage 4, and yes, 0 to 1 is in 53%, unknown 31%, history of smoking in 43%, and histopathology, just see, adenocarcinoma 97%. And they have a basically criteria. Charlson statistics, 1987, they started for all the disease as a classification for morbidity and mortality, and we are talking about a metastatic disease. Just see the mutations percent. Exon 19, 51%. Exon 21, 33%. Both common and uncommon, 4%. This is for your information. Just see treatment sequence. You can easily see that 58% patients remain on first-line ositinib therapy or were lost follow-up. 18.8% received second-line treatment. 18.4% died while on first line, and 4.7% discontinue first line. So real world time to next treatment or death, just see, median time is 9.5 months, and median basically for real world picture is 17.9 months. They mention about 37% events, 18.4% patient died, 18.8 switched to second line. In multivariant analysis, they found that stage of presentation is very important. Smoking status is again important. The Charlson's comorbid index more than 3 is very important. Mutations again important, and number of metastatic site more than 4 is equal to that, again important for real world data. If you see the real world time to treatment discontinuation, they mention about 7 months median basically period. Events 42%, 18.4% died, 18.8% switched to second line treatment, 4.7% discontinued. Just see the multivariant analysis. They clearly mention about that Charlson's comorbid index should be more than equal, 3 or more than that. Performance data is more than 2 or equal to that. And number of metastatic disease more than 4 or equal to that. Evidence of liver mets is a poor prognostic. So I can conclude by 3 evidence on a real world pictures regarding third generation TKI. The conclusion is the study provide real world insight into the use of first line ositinib in patient with advanced EGFR mutation adenocarcinoma based on the first data cutoff analysis of US subpopulation. The interim picture shows that real world time to treatment discontinuation and real world time to next treatment or death results support the effectiveness of ositinib in the real world condition. Long-term outcome will be evaluated in the final analysis in 2023 in June. Thank you very much for your kind patience to listen me regarding this real-world data on third generation TKI, which is the treatment of choice in adenocarcinoma. Thank you very much.
Thank you so much, sir. Now I invite Dr. Ankur Punia, sir. He is Assistant Professor, Department of Medical Oncologist, Shri Ram Cancer Center, Mahatma Gandhi Medical College, Jaipur.
Every regarding CAPMAT, MET mutation in SCL, almost 3% of it no patient presented MET mutation, uncommon mutation, and it's mutually exclusive, but it's also common in the patient who develops a secondary resistance mechanism. Most common is the exon 14 mutation. It's linked to an early diagnosis and in older age. But itself is a poor prognostic marker as patient with the MET exon 14 mutation tends to poorly compared to our wild type. The retrospective study, it was seen that 24 patients who received immunotherapy, they have a very low response rates of 17% and a median PFS of just 2 months. These patients, irrespective of PD-L1 expression, with high PD-L1 expression, have a poor response to immunotherapy. But MET inhibition initially showed that it prolongs survival in mutated stage for NSCLs. Patients with MET mutation didn't receive any kind of MET inhibitor. In any kind of MET TKI in prospective study, focus was around 25 months. Drastic difference, we use a targeted therapy to target this particular mutation. So now the capmatinib is a very selective, oral, and highly potent reversible inhibitor of MET kinase. It's almost 10,000-fold sensitive for particular MET receptor kinase. Among the commonly available MET inhibitor, the most potent is the trial which established it, the geometry mono-1 trial, which multiple cohorts were there. Today we are going to focus on the 2 cohorts, cohort 4 and 5. Cohort 4 included patients who were pre-treated, and cohort 5 included patients who were treatment naive. As you can see, around 10% patients had a baseline METs, and most of the patients didn't have a history of smoking. As cohort 4 was a pre-treated patient, was 75% of patients have received first-line therapy. Most of the patients have received chemotherapy. 95% patients have received immunotherapy. Around 20. The best overall response rates in the pre-treated cohort 4 was around 40%. Disease control rate was seen around 79 patients. Around 40% patients had a partial OCR. The cohort 5, which was a treatment naive patients, good response rate, around 70% was seen, and a disease control of almost 97% was seen. The responses, patient who achieved a response, deep response, we seen as all the patients, both the cohort. Median depth of response in the pre-treated cohort was 9.7 months. It was 12.6 months, the treatment naive patient. Progression-free survival was similarly for 5.4 months in the cohort 4 and 12 months in the cohort treatment naive. Patient who had a response, almost 82% patients in the treated population and 70% patients in the treatment population had a tumor response at the first evaluation, that was at 6 weeks, and they had a rapid and a durable response patient who responded. As we can see in this swimmer plot, both the cohorts, whether they were pre-treated, they were treatment naive. And as capmatinib has a good intracranial penetration as well, 13 patients who were available who had a baseline brain metastasis, 7 patients responded, 4 patients had a complete CR, and 3 patients had a stabilization of the intracranial disease. Similarly, the intracranial responses were also seen at the 6 weeks was the first evaluation, and only 1 patient had a progression, and all 12 patients had intracranial disease control. So responses were seen irrespective, because initially the drug was tried based on the MET amplification, but in both the cohorts, irrespective of the type, the amplification was low or high, the response was seen irrespective of. So this study was updated with 2 further cohorts, cohort 6 and 7. 6 was again a pre-treated cohort, and a 7 was a treatment naive cohort. So the first line patients, there was a response rate of 66.7% and disease control rate of around 97%. In the latest cohort 7, it was almost 100 patients had disease control, and nobody progressed while on this therapy. In the second line and third line patients, the cohort 4 and the cohort 6, responses rate 40 to 50%, and a disease control rate of 90% was seen cohort of patients. The majority of patients who experienced response, or almost 80% patient had a response at the first evaluation, that is at 6 weeks. So median duration of capmatinib first line was 12.6 months, and median PFS similarly was 12.3 the first line, and around 6 months the second to third line. So overall survival of around 20 months was seen in the treatment naive patient in the cohort 5, and around 13.6 months patient who were pre-treated with chemotherapy. Now, looking at the side effects, the most commonest side effect was seen with capmatinib was peripheral edema, GI side effects like nausea and vomiting, and increased blood creatinine. Most of these side effects were grade 1 or 2. Very few side effects like edema, which was 9.7%, grade 3 for edema was seen. It was higher in the patient using capmatinib. So, looking at concluding, patient or treatment naive patients have a very good overall response rates of 65-66%. And even in the pre-treated patients, the response rates were 40 to 50%. And we have very meaningful median OS of 20 months in the first line and 14 months in the second line pre-treated patient. Side effects, which are a little bit unique to this drug, are manageable and not that much alteration is needed. So this updated result further confirmed that the MET exon 14 mutation is a targetable mutation. With the use of this drug, can further improve the patient of this particular class of patient.
Hello. Now, I would like to invite Dr. Sandeep Jasuja, sir. He is a medical superintendent, State Cancer Institute, head of Department of Medical Oncologist, SMS Hospital, Jaipur.
Good evening, friends. As we know, we are running behind the time, so I will just brief and summarize within quick time, because being an organizer, all brunt comes to me to cut down my presentation. So anyhow, so this is a pharma sponsor, DRL sponsor session, and where they have assigned me the role of bevacizumab in NSCLC. As we know, this is the long race horse which running from long time in NSCLC from 2020, 2002 till it's proven its own value in spite of having these all new drugs coming up in a big way, like immunotherapy, like targeted therapy and anything. And I hope it will be continue the race in spite of all new horses are coming in the field. So the content of our my topic is bevacizumab in driver mutation negative NSCLC and also in non-squamous cell carcinoma NSCLC, or in what is the role of we will discuss role of bevacizumab in EGFR mutated NSCLC. So as we all know, the angiogenesis, the major key factor for angiogenesis is the vascular endothelial growth factor upregulation. And this upregulation happen because of environmental factors or genetic mutation analysis. What is environmental factor like hypoxia, hormonal growth factor, EGFR, PDGFR? If it is increased in body, it lead to increase the upregulation of the VEG receptors, and also gene mutation like P53, 73, SRK, KRAS, R, and VHL also upregulated the VGFR level, and this leads to increased angiogenesis, and you all know and everyone knows increasing angiogenesis leads to increased proliferation, migration, and increased survival of tumor tissue. So again, data have shown that where the high density of vascular density compared to low vascular and also high wedge predict the poor survival in patients, and this is significant. Overall survival is significant less where the MVD is high and VGFR level is high. So that's why it's a significant p-value. So I will cover this bevacizumab in some trial with phase of trial, like phase 3 trial is ECOX 459, which is landmark trial, and the database review, Medicare review, which have proven the efficacy of bevacizumab along with back carbo and followed by maintenance, and other point break trial which directly compare head-on Pem-carbo bevacizumab versus pacli-carbo bevacizumab followed by maintenance with Pem-bev or maintenance with only bev in pacli-carbo arm. As we all know that now everyone see that the pembrolizumab is the standard of care treatment in patients who are EGFR or driver mutation negative, and there is no hope for this patient apart from chemotherapy, and the chemotherapy only approved of Pem-carbo and Pem-carbo in these patients. And also important point is that carboplatin paclitaxel is standard of care treatment in these patients, but somehow increased toxicity without much increased, only the toxicity is little bit increased neurotoxicity. That's why you use Pem-carbo compared to pacli-carbo in NSCLC patients, but overall survival and time to progression survival is same in both arms. And we will see what happen when we add the bevacizumab, and point break trial have given us the answer when we use the BEV in both arms. And Sail-Avail and IRIS trial are the comparative analysis they did in a comparative analysis, and apart from irrespective of any drug and what is the dose should be dose of they define bevacizumab 7.5 milligram or 50 milligram, and we will see the result and in following slides. So this is the landmark trial of ECOX 459 trial, which is published in New England Journal, and which established the role of bevacizumab in a patient of NSCLC non-driver mutation. And the eligibility they have chosen, the eligibility criteria is the standard criteria, and after stratification they randomize the patient in pacli-carbo arm versus BPC arm. I will just mention here now BPC. Bevacizumab pacli-carbo arm and PC is the pacli-carbo arm. So I will just give the show name in following slides. So, but very important point was there is no crossover in this patient, and no patient was permitted in crossover for these patients. And this trial is really a well-designed trial of 440 around 900 patients, 850 patients, and on all parameters, this is well controlled and well designed trial, and have shown that the all parameters, you see the sex, male, female, age more than 15, ECOX 10,
01 or stage of 3B and received radiotherapy or not. And all parameters, it is well-designed trial and have enough equivalent, almost equivalent patient in both arms. And the result of ECOX trial have shown that if we see the overall survival, then again it's proven that BPC group have 1 year survival is 52% versus 10% in PCM, and if you see the 2 year survival, then it is 20% versus 15% in PCM, and it is also significant. And response, if you see the progression-free survival, it is also increased and favoring the BPC arm over paclitaxel arm, and p-value is significant and 6.2 months. See it compared to 4.5, 1.5 month survival advantage is there. And if you see the overall response rate, that's again 15% patient respond in PCM compared to 35% patient responded very well to BPC arm. So if we go to the subgroup analysis, if we go subgroup analysis at the various parameter like disease at the stage of disease, measurable disease, sex, male, female, age less than 50, 65, more than 65, or all parameters. If you look around the curve, then there is all parameter have low hazard ratio less than 1, which favor BPC arm compared to PC arm. And what's about the safety analysis? Then again, next question comes to us, okay, you are favoring BPC arm in these patients. So what is the safety analysis? As we are always worried about the safety of patients when we use the bevacizumab, and the class effect of bevacizumab is hypertension, proteinuria, and rashes happen in the patient where we use the bevacizumab, and we are sometimes fear of intracranial hemorrhage or any hemorrhagic events occur in bevacizumab arm. But if you see the analysis of 4599 trial, then you will find here is that there is surprising, there is no increase any toxicity compared to BPC with PC arm. But yeah, it's less or more equivalent. P-value is less than 6. I can't comment on this that this is less toxic than PC arm, but I can say confidently that it's a non-inferiority trial and not increase toxicity in BPC arm compared to PC arm. So as we all know that these trials are designed in a strict manner and strict with a strict exclusion and exclusion criteria. So we may have good result. Someone can comment or someone can ask me, we may have good result. What happened in the real world? What is your experience in real world? How many patients get this benefit from this treatment of BPC versus PC? So coming to this also point, there is one Medicare subgroup analysis was done as a retrospective cohort study, and they have chosen the patient. They have they included a patient treated from 2005 to 2009 for around 71,000 patients of non-small all lung cancer patient, and they have put the exclusion criteria, and they want to see the response of the bevacizumab above 65 years of age. So cut down is the 65, and they want to compare the treatment toxicity and benefit in patient of 65 to above 65 to 75 and more than 75. So they compared 65 to 75 population compared to 75 plus of population when they treated with this the patient treated with BPC versus paclitaxel. In exclusion and exclusion criteria were squamous cell carcinoma. They excluded squamous cell carcinoma, histology, age more than 65, patient treatment other than this PC versus BPC, or received radiotherapy or not, and patient operable or not, or within 4 months they have received the treatment or not. And when we combine this all exclusion criteria, they only just found a 1706 patient eligible for the evaluation. And they again categorize this 1700 patient into patient who have received BPC and who have not had not received BPC and just received CP treatment. And in CP treatment, the patients are 1100 almost, and in BPC, this is 600 patients received, and this again subcategorized into less than 75, more than 75 in both arms. And what the result they got? Median survival of 2 years. After 2 years, you are just seeing that after 2 years, both curve were combining and meeting at endpoint. But if you see that after 30 days of treatment, both curves separated very well and appreciated very well in separation. And at the 2 years follow up, have the clear cut benefit of 10.5 month, 1 year follow up, 10.5 month overall survival compared to 8.5 month overall survival in CP arm. So there is clear cut benefit of 2.3 month difference in both arms. So again, have proven the role of bevacizumab in patient of NSCLC negative mutation driver negative patients. Then again, this sub-analyzed according to the age, if the patient have age of 65 to 74 or patient more than 70 years. And again, they compare the in both arm CP and BPC arm, and they have found that the maximum benefit patient got in a more than age of 75 years when the patient are treated BPC compared to PC, and 3.3 months of overall survival difference was there in favor of BPC arm. And in a patient of less than 75 years, again, they have shown that there is 1.3 month survival benefit in the less than 65 year also patient. So final results have shown that overall survival, progression-free survival, and response rate benefit always is their benefit when we add bevacizumab to paclitaxel in a treatment of NSCLC, and Medicare CA database also proven that the therapy with BPS is associated with long survival and comparable toxicity. I can't say fewer hospitalization than CP, but yes, comparable toxicity with CP. So next, coming to what to do, because this all trial with paclitaxel and bevacizumab, now the standard care is the PEM-carbo. So why not how to choose these drugs? Should we add this PEM-carbo, bevacizumab in PEM-carbo arm also? So that answer clearly given by Point Break trial, and this is one of the very good trial, which is well design trial and have taken all exclusion and exclusion criteria what previous trial had taken, and they also compare bevacizumab carboplatin pemetrexed versus bevacizumab carboplatin pemetrexed followed by bev pemetrexed maintenance till progression in carbopem arm, and only bevacizumab in paclitaxel arm till progression of the disease. And what they found is that and analysis, what they want from this trial is that intention to treat population and what is the result of maintenance therapy in this patient. And maintenance therapy is defined as patient receiving at least one dose of the treatment at cycle 5. So again, if you go by subparameter and characteristic of this baseline characteristic of the point break mutation, and you will find that this is again a well-designed trial comparing all parameters at a same point and equivalent platform. And if you see the sex, ECOX performance, disease space, or any parameter, what commonly we used, and one important point is here, if you look at the downside of down to this slides, is the smoker and non-smoker. And they have also differentiated between smoker and non-smoker. Whatever the result in smoker, never smoker, ever smoker, comparing in both arms. Again, the overall survival in intention to treat population is meeting favoring the BP. That is not favoring any arm if we add the bevacizumab, but less or more survival is less or more equivalent 52 to 54 months and 24 into 21 comparing PEM carbo versus paclit carbo, and overall survival is less or more same. So you can add. bevacizumab in this also, PEM carbo also compared to pacli carbo also. But if we see the progression-free survival, that is little bit favoring the PEM carbo arm when we add the bevacizumab in PEM carbo arm compared to PEM carbo, pacli carbo arm. So progression-free survival and in the intention to treat population and progression-free survival in maintenance both favor PEM carbo arm versus, over pacli carbo arm when we add bevacizumab and maintenance bevacizumab. So if you go see this hazard ratio, then again there is no major difference between both arm, and some kind of favor pacli carbo arm, some favor PEM carbo arm. So overall survival less or more is same in both arm. But if you see the result in other intermediate in progression-free survival in period which histology which favor little bit pacli carbo arm over PEM carbo arm. So coming to side effect of PEM carbo bev versus PEM carbo PEM carbo pacli bevacizumab, you will find that surprisingly there's on neutropenia is little bit more in pacli carbo arm compared to PEM carbo arm, and also their sensory neuropathy is more over PEM carbo arm, PEM carbo versus pacli carbo. Pacli carbo have more sensory neuropathy than PEM carbo arm. So if you look at all kind of side effect, then it's a little bit higher in PEM carbo. That's why it's translated into there is no difference in overall survival in spite of having progression-free survival advantage in PEM carbo arm. So conclusion of Point Break is the progression-free survival was significantly improved with PEM carbo arm. There was no survival advantage benefit observed, and the median survival overall survival is 71%. And now we can add this bevacizumab safely with PEM carbo arm also. So again, these are some of trials, other trials which I have also proven the efficacy of bevacizumab in other drugs also, not only from carbo. Some patients, some doctors use gem carbo, some doctors use nivolumab, vinorelbine upfrontly in the patient, or docetaxel. So these other trial have also included this other chemotherapy along with bevacizumab, and they have also shown that there is little benefit. There is also benefit when we add the bevacizumab in this patient. And this trial, AVAIL trial, also evaluated 7.5 milligram per kg compared to 15 milligram and had shown that there is no much difference. So 7.5 milligram per kg bevacizumab can be administered very safely with all chemotherapy. So if you see this analysis, that also again favor bevacizumab ratio less than 1 in all trial. If we join see the result of all trials, and hazard ratio is less than 1, so favor the bevacizumab over the control arm. And our recent NCCN guideline have also included bevacizumab in the their bevacizumab in their part as a part of treatment. And if you see here that PD-L1 inhibitor, where we cannot use PD-L1 or PD-1 or PD-L1 inhibitor, we can use bevacizumab irrespective of PD-L1. Indirectly, they support that we can use bevacizumab irrespective of PD-L1 status. So there is no ifs and buts that we have to use this immunotherapy in this patient if the PD-L1 is high, but sometimes patients don't afford, and sometimes patients don't have so much money, or sometimes there is contraindication due to hepatitis, due to autoimmune disease, due to ulcerative colitis, or any kind of autoimmune disease. We can add bevacizumab in this patient also. There is a clear message given by NCCN guideline. So in maintenance therapy in NSCLC, we also got one still got one category 1 recommendation for maintenance therapy along with pemetrexed or pemetrexed single agent or bevacizumab plus pemetrexed by NCCN. So sometimes we have many doubts in our mind that these drugs are antibody drugs, these are the MAVs drugs, then is biosimilar drug have the same efficacy or same side effect compared to innovators? So NCCN guideline clearly have given the place of the biosimilar therapies, and they have mentioned here that if you are using the biosimilar therapy, it's okay, you go ahead and you should continue biosimilar therapies, MAVs, this bevacizumab in maintenance therapy. So they have also given some place biosimilar therapy in their book and textbook. So coming to the EGFR positive patient, what bevacizumab did in driver mutation positive patients, and there are 3 trials which have addressed this issue, burning issue, because now a lot of buzz is coming that only driver mutation is okay. Give driver mutation, give Jeftinib, Lotinib, Osmatinib, whatever you want to give. But then we leave the other part of therapy and like VHG inhibitors, and that's why this 3 trial have given a very much clear idea when we can use this bevacizumab with the driver mutation positive like EGFR positive patients, and the RV study and JV0026 trial and Beveridge trial have established the role of bevacizumab in patient of NSCLC. So I will not go into detail because of shortage of time, but somehow if you are seeing this exon insertion 30 where there is no result available, there is no treatment available, because we know the exon 19 and exon 21 patient get the treatment of EGFR and they could have a very good response and everything is good and fine, but this patient exon 20 insertion don't respond very well to this therapy. So what to do in this patient? I do agree, someone can comment about there is subset analysis of exon 20 insertion, like some 2-3 mutation can respond to EGFR related therapy, then we have to do NGS, and that is the different story. But if patient have exon insertion 20 positive, then we don't have other option apart from treating this patient with the chemotherapy. Then again, this I have shown that if we add this this study have shown that if we add this study was done in China and 165 patient, and if we add the bevacizumab, and that also significantly improve the progression-free survival compared to CT alone 7.5 month versus 5.6 month. And also if we use in second line, the benefit we get more with adding this bevacizumab 2.4 versus 6.6 month survival benefit when we add bevacizumab compared to CT alone. So this is the Flatron database was used for retrospective study of exon 21 insertion of 181 patient, where the choice was by investigators and treating doctors, and they have collected this data and see that there is some patient who are treated by platinum plus wedge inhibitors or wedge inhibitor alone, and they have shown that where the patient have get this treatment of platinum based treatment in the exon 20 have good advantage on PFS compared to all other treatment, and also translated into the overall increased overall survival in these patients. So what we are discussing before that, we can we use this allotinib plus bevacizumab in patient, and what is the safety profile in a patient who are exon 19 or 21 positivity? And this trial have addressed this issue, and this is also a very good trial, and compared these 2 arms, bevacizumab allotinib versus allotinib alone therapy in a patient of almost 214 patients dividedly equally in both arms, and the exclusion inclusion criteria, standard criteria, what we used and we would see in the previous trials, and they have shown that there is a clear-cut median progression-free survival benefit of 16.9 months compared to allotinib on median is 13%. When we use this, we add bevacizumab in this patient. So also they have shown that in exon different effect of bevacizumab adding with the allotinib in different exon 19 and exon deletion of exon 19 and exon 21. So here you can see and appreciate that better benefit, maximum, more benefit was occurred in exon 21 mutation, and there is progression-free survival is median overall survival was 51 months compared to 38 months in patient, and exon 19 there was median overall survival 41 and still not and under consideration. So Beverly trial is a landmark trial which I have also established the role of bevacizumab in allotinib patient, and allotinib patient in untreated non-squamous cell carcinoma and having activity EGFR mutation of stage 4 and PS2 less than 2, and they compared allotinib versus experimental arm allotinib versus bevacizumab 15 milligram per kg plus 150 mg allotinib in 2 arms, and have shown that there is again very good results, and show the superiority of adding bevacizumab in this patient. And also in Beverly trial, what they did it in that they have also investigated choice of assessing the PFS compared to centrally double blinded centrally reviewed progression-free survival by the doctors, and they have found that either it's by investigator choice assessed the PFS or centrally assessed the PFS in this patient when we add bevacizumab to allotinib, that less or more are the same, and in allotinib this 9.6 month around progression-free survival compared to bevacizumab where is 15 around the 15 months progression-free survival in beva. So again, this have shown efficacy result and overall survival. We have discussed that allotinib 22.8 months and versus allotinib bev 33 months benefit, and there is benefit in this patient. If we see the subgroup analysis of this patient with the progression-free survival, overall survival, again hazard ratio except the never smoker, except in never smoker, hazard ratio is less than 1 favoring the bevacizumab. Especially the bevacizumab is very good in a smokers patient. If we add the smoker patient, EGFR positive patient, if we add bevacizumab with allotinib, it's a very good combination and have maximum benefit patients. I will skip these slides because of we have already discussed. This is safety. Now coming to the safety profile, and again the safety, if we add the bevacizumab with the allotinib, that's the most safety profile is same, and class effect of hypertension little bit high, and that is high in bev, but it is manageable, and this is around 5 to 10% patient have high hypertension or malignant hypertension. What are the other clinical trials which are in pipeline or which have proven the efficacy of bevacizumab? There are a lot of trials are happening in the world, and phase 2, phase 3 trials, and which are comparing the bevacizumab and allotinib, and they are all having early results show that there is little bit benefit of bevacizumab adding over allotinib. And these are the recent again trial. Now we know that osimertinib is the standard of care treatment in these patients. Now in upfront we are using. So this to address how to use bevacizumab or ramucirumab in this patient. These are ongoing trial which can give us answer in coming days. And this trial, Ramos trial, Torgas trial, and NCT 0418-106 trial, US trial, which comparing osimertinib plus osimertinib bevacizumab. And time will tell us which trial will give us better answer to add bevacizumab. And in my concluding slides, bevacizumab, if we add, can be we add safely in to get maximum benefit in induction and also maintenance, and more benefit occur in less than 50% patient, and it doesn't add much toxicity as apprehended by our doctors colleague and our other persons. And EGFR mutated patient, yes, we can add with chemo 20 or 21 with allotinib. In smoker, yes, we get benefit, and if patient are mutated P53, then the results are more and have good benefit. Thank you very much for patience. Thank you.
Thank you so much, sir. Now I would like to invite Dr. Tina Bharadwaj, molecular biologist as co-diagnostic.
A very good evening to all the dignitaries. Thank you so much for giving us the opportunity to speak today on comprehensive genomic profiling in solid. As we all know, that oncologists often look at the specific mutations in the tumor, which represents important targets for specific treatment. Coming to the precision medicine, it has opened a new horizon into research and diagnosis. There has been a remarkable milestone achieved where 2019 NTRK has been proposed to be the tumor agonist in various cancers, including the various histologies. The era of precision medicine optimizes the cancer treatment. It provides the clinical benefit for each patient, assists in choosing the targeted treatments, ultimately minimizes the medical expenses. All this is based on the tumor's unique genetic profiling. When it comes to the pros, there are cons which are present into precision medicine. First is the exhaustion of the precious tissue during single molecular testing. There has been missing out of timely detection of genomic alteration at right time, leading to ineffective therapy. I'm sorry for the delay. To overcome these challenges, there are personalized medicine which requires comprehensive and precise genetic profiling of each patient tumor. This is aimed at right treatment, at right diagnosis, right at the right time with minimal ill consequences and maximum efficacy. Comprehensive genomic profiling in solid tumors has helped us for timely and accurate identification of molecular alterations. Also, it has helped us to evaluate large number of therapeutic relevant variants and molecular signatures. Also have turned out to be a tumor agonist method in various histologies in pan cancers, also in taking therapeutic decisions and assist in monitoring therapeutic response, treatment, resistance, and disease relapse. The use of genetic markers allows cancers to be further classified by the pathways defined at the molecular level. So these can be categorized into three classes. The first class is a direct impact of the care of the specific cancer of interest. Second is the biological important but not clinically actionable, and genetic markers which are of uncertain importance. The European Society of Medical Oncology has developed a scale of clinically actionable molecular targets, which is defined into 6 levels of clinical evidence of molecular targets according to the implications for patient management that has not only helped us to harmonize and standardize the reporting and interpretation of the clinical relevant genomic data, but also offers a common language to all the relevant stakeholders in cancer medicine and drug development. Molecular pathology has become the fundamental when it comes to tumor diagnosis, tumor prognosis, and where we can derive therapeutic decision. And this development has happened in the past decades substantially, and it has impacted the overall patient survival. All this can be achieved by the next generation sequencing, which has helped in comprehensive genomic profiling, where it assists in consolidated testing by evaluating spectrum of genomic regions, which has strong biological and clinical relevance, along with the sensitivity and detection, reliability of the coverage, and heterogeneous characteristics of the tissue, which is well suited for low quality clinical tissue samples and variable amount of necrotic and neoplastic contents. With this, we have the minimalistic approach where the nucleic acid input with minimum of 20 nanogram has also done wonders and which has helped to save precious tissue sample, and it has minimized the risk and the chances of rebiopsy. There is better approach and also better therapeutic outcomes because it has helped in replacing the single gene testing performed. It has reduced the test not performed, increases the number of informed cases, and helped build a database for future studies. When we are comparing the large and small panels, over here in a country like India, where the cost is the major concern, small panels are being chosen. But however, the advantages with the larger panel is that coverage of the clinically important genes. There is additional security of screening the prognostic and the predictive significant biomarkers, and also analyze the varying allelic frequencies. Coming to the clinical approach, normally a balanced approach has been seen where the screening is done of the well-established clinical important biomarkers. However, a hybrid approach is being used today in today's era. In hybrid approach, we have the harboring mutations where all the hotspots mutations are covered of the oncogenes and all the exons of the tumor suppressor genes are being involved, which maximize the clinical utility of the genomic areas and markers sequence. Also, it helps us to screen the larger regions of the genome like BRCA1, 2, APC, and ATM, where we can pick up and identify in the background germline mutation. The need of the R is to identify a reliable and cost-effective comprehensive genomic panel, which will aid in massive parallel sequencing multiple genes at the same time, identify the deleterious somatic aberrations, assist in detecting the baseline of the disease progression, also see the guidance of the therapy, ultimately helps in concluding a druggable somatic mutations. So for this, we have a 161 gene panel, which is covering 161 genes inclusive of hotspot mutations, single nucleotide variants, indels, copy number variants, and gene fusions. The processing of the sample when we receive is the tissue. The tissue is being sectioned and it undergoes through the pathological review where the tumor content has been marked, the DNA and the RNA is being extracted. Post that, it goes ahead for the NGS protocols where libraries are being prepped, chip loading is being done, and sequencing is being processed. Once the sequencing data is being received by mutations where of randomized is also being screened. So we conducted a study of 243 patient samples where the RNA and the DNA were isolated from the tumor samples, and they were subjected to target amplification with Oncomines somatic 161 gene panel and run on Thermo Fisher Ion Torrent S5. The NGS output sequences which we received was aligned as per the human reference genome Ion S5 torrent servers. Variants were identified or as per the Ion report software. These are the 161 genes which were screened inclusive of hotspot mutations, copies, fusion, the result obtained into the study, DNA RNA alterations were more prevalent in the 6th decade in the females and 7th decade in the male, where the prevalence and the positivity rate was higher in the females when compared to the male. The top mutations which we have checked are in consensus with the global data and also the relevance, like for example, when it comes to lung cancer, TP53, KRAS, EGFR, and BRAF are the most commonly encountered mutation, followed by breast with PIK3CA, and so on. So concluding, the study is unique as it screens 161 gene at one time, which eliminates the need of several tests before rendering therapy. Also, it aids the clinician in personalizing the drug regimen. Also, it screens and improvises the evaluation of moderate and low penetration genes and help the genetic counselor and oncologist to go ahead for the clinical management of the patient. Coming to this, we have the next broader panel, that is the gene code paradigm, which has a coverage of DNA and RNA mutations of more than 500 genes. This not only helps to study the single gene biomarkers, but also help us to understand the tumor mutational burden and microsatellite instability, along with a segregated HRR panel. These are the genes which have been covered along with the fusion drivers. So when we are talking about the comprehensive genomic profiling, we should also talk on the clinical trials. I would like to acknowledge S. Ludwig, who presented in 2021 in ESMO presentation, where they had considered 506 patients, inclusive of all the cancers. They did find 72% of the patients with actionable mutation. Amongst these 72%, for a new trial, 41% was eligible to go ahead for testing and eligible to take the treatment. In that, 1/3 of the patients were benefited, and this is why they have actually told like comprehensive genomic profiling actually helps in standard patient care. So ultimately, I would like to thank all our patients who has donated their tissue, which has helped the molecular pathologists to understand the tumor of tumorigenesis, give a report which can help the clinician to understand the mutations, mutation burdens, and MSIs, which has been encountered in the tumor all the time and listening to me.
Thank you so much, ma'am.